Ladies and gentlemen, esteemed guests and experts, I extend a warm welcome to the second day of the Taipei Valve Summit 2023. It's an honor to have every one of you here as we continue our journey of exploring the latest advancement and breakthroughs in this field of heart valve disease. Today we have 6 sessions with the first topic, Redo surgery, transcatheter heart valve in failed surgical valve or transcatheter heart valve in valve. So let's begin our exciting program and welcome our renowned moderators and panelists. Thank you.
So this is our first session in, today. Hello. Good. Good morning, ladies and gentlemen. Today, this is the our first session today will be the roundtable discussion on the topic on the Redo surgery, THV in failed surgical valve or TAV-in-TAV. So I'm Jian-Yi. We have 4 moderators for this session, myself and Dr. Xu from Changchun University in Taiwan, and Dr. Poon from University of Queensland in Australia, and Dr. Jimmy Hong is National University in Singapore. And we also have an excellent panelist here, Dr. Michael Reardon. Everybody know him. He's from Texas. He's a world-renowned surgeon and also the interventional cardiological kind of surgeon. So he's a leader in this area. And then we have Dr. Chen from Korea and Dr. Han also from Korea. And we have a Dr. Ali from New Zealand, and Dr. Zhang have both from China, Beijing, and Dr. Guoyin Chang from China, and Dr. Noppon from Thailand, and Dr. Michael Lee is from Hong Kong, and Dr. Lee Yung-Tsai from Zhengxin Hospital. So I think this format will be everyone have a presentation within 5 minutes, and at the end we have a 2-case presentation by Dr. Lee, and then at the end we have a panel discussion. Okay, so I think we should start the session. And first, I will introduce first the speaker is Dr. Michael Lee is online. Oh yeah, hello.
Hi, Sam. Hi.
So, he's my friend. We know each other for a long time, and he's interventional cardiologist, is an excellent, cardiologist in Hong Kong. He's a professor at both Hong Kong University and Chinese University of Hong Kong. And he was trained in the actually Brigham Women's Hospital, Harvard School, between 1999 to 2000. And he established a Hong Kong Society of Transcatheter Echo Cardiovascular Therapy, and he's he's a founding president. And also he currently the president-elected of the Asia Pacific Society of Interventional Cardiology. His interest in the PCI, mechanical cardio or circulation device for cardiogenic shock and structural heart valve intervention, and the robot assistant PCI. Dr. Lee, please.
Oh, thank you, Jen, for the very kind introduction. I'm sorry that I cannot be with you this year. Hopefully next year I can meet you face to face, and thank you for the invitation. So this morning, I would just like to start off by setting the stage on talking about this structural valve degeneration or the durability of this surgical as well as the transcatheter heart valves. These are my disclosures. Before we start the discussion, I think we all have to have a common language to talk on. We have to have common definitions. So bioprosthetic valve dysfunction actually include 4 main categories. First of all, the structural valve deterioration, which means actual deterioration of the prosthetic valve itself, causing hemodynamic dysfunction. And then we have non-structural valve deterioration. That means the previous paraprosthetic regurgitation, malpositioned, patient prosthesis mismatch, and so on, leading to later on degeneration or dysfunction. And then the valve can get thrombosed. We can see thrombus, and then lastly, endocarditis infection of the valves or the device itself. And these are the definitions of the structural valve deterioration for moderate, severe hemodynamic structural valve deterioration, and so on. So we have to have this language before we can actually discuss further on this structural valve deterioration. And we know surgical heart valves have been used for many, many years. And there have been abundant evidence showing that these surgical heart valves actually also get degenerated after 10, 15 years. And you can also see that for these surgical heart valves, younger patients actually have a more rapid deterioration, more rapid deterioration than older patients. Although the elderly, once they get deteriorated, their deterioration rate is a lot faster. So we have to bear this in mind when we are talking about the surgical heart valves. When we come back to the TAV device itself, We know they are both balloon expandable and self-expanding devices. This is from the Partner 2 trial. You can see that after 5 years, a previous generation SAPIEN valve, SAPIEN XT, actually decreased a lot faster than the surgical heart valves. But if you compare the current generation SAPIEN 3 and the surgical heart valves, actually their deterioration rate is very, very similar after 5 years. We have actually more evidence with the self-expanding device. This is the core valve US pivotal as well as the TAV trials combined data. And you can see that as compared to the surgical heart valves, the TAV device with the core valves and later on the absolute device actually show a significantly lower rate of structural valve deterioration as compared to the surgical valves after 5 years. And this lower rate of structural valve deterioration actually is more prominent in the small annuli, less than or small or equal to 23 mm valves, more significant, although there is still a trend towards a lower rate of deterioration with the large annuli. So both small and large annuli, I think, has actually shown more benefit or lower rate of deterioration with the TAV device. And we know that once the valve get deteriorated, no matter it is surgical valves or the TAV valves, the patient outcomes, these hard endpoints of mortality, rehospitalization, and all the other hard endpoints will actually get worse. So we have to pay particular attention to this structural valve deterioration. Longer term data with this self-expanding device, in particular the core valve, this is the first generation core valve, has been provided by the Noppon trial. So after 8 years of follow-up, you can see that bioprosthetic valve failure, actually TAV valve and surgical valves are actually the same after 8 years. But if you look at the structural valve deterioration alone, you can see that actually the TAV device has a lower rate of structural valve deterioration as compared to the surgical heart valves. Of course, we need to wait for more longer-term data to tell us more. And this can also be reflected by the hemodynamic parameters like the mean gradient after the device put in, as well as the effective orifice area. You can see that the TAV device has some more advantage over the surgical valves in terms of both the gradient, the mean gradient, and the EOA. So I would just like to set the scene within the previous 5 minutes, telling you that structural valve deterioration, yes, it is unavoidable for both surgical heart valves and the transcatheter valves. And this deterioration is associated with worse clinical outcomes. Durability of these valves, the transcatheter valves, is at least, I would say, comparable, if not better than the surgical heart valves after 5 to 8 years of clinical follow-up. But of course, we need to wait longer-term data, at least more than 10, 15 years, before we can compare to the surgical heart valves. We still don't know the durabilities of separately the self-expanding and the balloon expandable valves. Are they the same, or one is actually more advantageous over the other? But I think in the era of lifetime management of younger and lower risk aortic stenosis patients, we need to pay particular attention to this structural valve deterioration of the transcatheter valves before we advise the patient to put in which valve first, and subsequently, when we need to do valve in valve, which valve to go later in the later part of their life. I think this has set the scene for your subsequent discussions. Thank you very much.
Thank you, Dr. Lee, for your excellent overview on the durability of surgical and the transcatheter valve. So we will discuss at the end. So I would like have Dr. Hsu to introduce our second speaker.
Thank you. So our distinguished guest, dear colleagues, ladies and gentlemen, good morning. I'm Dr. Yung-Tsai from Chang'an Memorial Hospital, Taiwan. So on the next, it's my honor to introduce our next speaker, Dr. Noppon, Taksaudom from Thailand. And Dr. Noppon, currently he is the Faculty of Medicine of Chiang Mai University, Thailand. And also he received endovascular training at Germany from 2011. And also he received the fellowship of congenital cardiac surgery training at the Okayama University Hospital. And he also received a fellowship in aortic surgery and the TAV with Professor Toru Kuratani at Osaka Graduated School of Medicine, Osaka University. So currently he is the expert of TAV procedure. So today it's our honor to invite him to give us a lecture. The title is regarding the valve-in-valve TAVR or Redo-Transcatheter. So let's give a warm welcome to Dr. Noppon. Thank you.
Okay, thank you. Thank you very much for the great introduction. Today we have only five minutes, so I will start it now. I will start with the TAVR valve-in-valve. The TAVR valve-in-valve right now in the current guidelines stay in the class 2A, even from ESC or the A or the AA guideline, and it is just confined for the patient with high risk patient. If we look at the short-term outcome, you can see that it is quite a promising result that encourage us to do the TAV valve-in-valve. The 30-day mortality, everything is good, and if you look at the meta-analysis, all of the meta-analysis also confirm that the 30-day mortality is good, and the bleeding is low, and the length of the hospital and everything is good. But if from the same cohort study, if we look a little bit longer, you can see that the line of incident of the endpoint, combined endpoint, is crossing at 1.5 years. It means that in the long run, the TAV valve-in-valve may have some problem that we still don't know. And the long-term result is also confirmed by many meta analysis, and this is one of them. They show that the benefit of the TAV valve-in-valve is lost after 1 year, and then after that, the suffer is favored. And what is the potential problem of the TAV valve-in-valve? Is maybe come from the study, the limitation itself, because right now we don't have a randomized control trial yet, and there is mixed type of the suffer in the study, and the patient in the valve-in-valve is also the high-risk patient and the older patient. Whatever the method, we try to minimize the bias, we cannot get rid of it. And the meta-analysis right now is just include just only few number of the study. Another problem is maybe come from the coronary obstruction. We know that the sutureless valve, the eternal-mounted design valve, is a cause of the high risk of the coronary obstruction. And we can estimate that it's from the CT scan using the VTC or the VTSTJ. And if there's a problem, we can protect it by using the basilica or the chimney. But we don't know the long-term result of that procedure yet. But don't forget that the coronary obstruction can occur in the delay onset, even more than 24 hours. That is maybe come from the valve thrombosis from the TAV valve-in-valve that is higher. And residual gradient is another concern. You know that the patient with a small heart valve with a stenotic failure with a pre-existing PPM is a risk. And we can cope with that with using the supra-annular design, use a proper size, not too big, and use a higher implantation depth. But and also if there is a residual gradient, we can use a balloon valve fracture, but not all the valve can be fractured. The last is about the concomitant operation. Even in the same rate of the revascularization in the study, but everyone knows that the CVG has a long-term result better than the PCI. And if we are the surgeon, we have to enter to the shares, especially for the redo case. If there is some residual lesion, we will repair it, especially for the moderate MR and the moderate digastric regurgitation. So in my in about the surgical perspective of the TAV valve, what is the surgical valve choice? I think it would be the valve that's bigger, and in Asia maybe 21 millimeter. I don't know, but it's maybe bigger right now. And the standard internal mounted design would be better than the external mounted designs with a bigger valve area. Right now, we have a new design surgical valve that has an expandable frame that is dedicated for the TAV valve. And the surgeon should encourage to do the root in last minute. And if we have to do that, we have to enlarge it adequately. Should be more than 23 millimeter. And the implantation technique of the surgical heart valve too. Right now we use the supraannular designs, and if the root is already large, and we can and then we can put a really big valve, the intraannular may be better because the problem about the coronary height. And if we have to put the stainless valve, the mini load procedure would be better than the subcoronary implantation. And if we have to deal with the root procedure, the higher coronary implantation maybe have to do. And in conclusion, in my preference, if I have the patient, I have to do, and I will prefer to do the Redo-Transcatheter if the patient have a low risk, younger, with a concomitant operation, and also the parallel leakage. And if the patient have the small heart valve with a severe PPM, and that valve cannot be fractured. And in the last, if there is a risk of coronary obstruction, THV malposition due to root injury, I will do the Redo-Transcatheter. Thank you.
So thank you very much for Dr. Noppon's very excellent speech. And also we will have a discussion later. So please keep our question and comment until the discussion section. So on the next, it's Dr. Poon to introduce.
Hello, good morning. So our third speaker is Janar, Dr. Janar and Sathananthan. He's actually my colleague, and he's an outstanding, young, energetic, interventional cardiologist, and very smart. He clinically interested in both coronary intervention and the structural valve intervention. He lead the cardiovascular translational laboratory at the hospital, and he's also Canadian representative for International Standards Organization, the device board for testing on cardiovascular device. So he has done many researches on the valve-in-valve, TAV-in-TAV, particularly in the in vitro situation, and also he has, is one of the main operator for the TAV and the valve-in-valve. Hello, Janar, you online? Excellent. So he will give a talk on Redo-TAV technical considerations.
So good morning, everyone, or good afternoon, whichever time zone you're in. Thank you very much for the invitation to speak today. I apologize that I cannot join you live, but I'm sure you'll have a very spirited discussion. So my topic today is planning for a TAV-in-TAV and some technical considerations to consider. My name is Janar Sathananthan, and I'm an interventional cardiologist in Vancouver, in Canada, at St. Paul's and Vancouver General Hospital. So when we talk about TAVI, this is what we consider to be historically a younger patient with aortic stenosis. This is Mick Jagger. He's probably the most famous patient to have a TAVI procedure, but I would think nowadays that in most contemporary practice at the age of 75, most people would think that he would be a fairly routine case at his age group for a TAVI procedure. But we're kind of moving as a field to start thinking about what if these other individuals had a need for a TAVI or presented with severe calcific aortic stenosis. What therapy would these individuals need? This is how I think about the treatment options for severe calcific aortic stenosis in these four buckets. If we look at some of these options to the left of the screen, like the Ross procedure, we know the Ross procedure is a very good treatment option for patients when performed well. However, one of the challenges is that there's a limited number of surgeons that perform this operation in a consistent fashion, or let alone a surgical program that offers this. And so it's not necessarily something that's available globally in a homogeneous fashion. Mechanical heart valves, of course, have very good demonstrated durability. However, patients do not like lack need for oral anticoagulation, and so hence the use of mechanical heart valves has dropped in recent years, and the promise of using a DOAC still remains to come into fruition. So really, we're left with bioprosthetic valves, surgical valves, or TAVR as an option for the majority of patients. These are guidelines with regards to different age groups, and largely speaking, if you summarize them, patients over the age of 75, TAVI is considered a default first approach. Between 65 and 75, you could go either way. And under the age of 65, generally speaking, surgery should be your first consideration. And if you look at Redo-TAVR as a whole, in terms of number of cases that have been done, it's not very common at the moment, but the numbers are slowly increasing. And you can see data from the TVT registry. It's about 0.5% of all TAVR cases, and the Redo-TAVR registry, it was from Uri Landis, it was also less than 0.5% as well. But this is going to come. We are going to see an increasing number of Redo-TAVR cases. And the reason I say that is because if you look at this data that was presented in the US of contemporary trends in the use of TAVR for isolated aortic valve stenosis, you can see this is different age groups. So when you're over the age of 80 in the US, this is over 280,000 patients. Almost all patients had a TAVR. Between 65 and 80 years old, it was as high as 87% in 2021. But what was staggering to me was that if you look at the less than 65-year age group, there was a significant increase. And in fact, almost 50% of patients that were under the age of 65 got a TAVI. So these patients are going to come back, and they will almost certainly need repeat procedures if they were to have a TAVI first. And so you have treatment options like this, Redo-TAVR. It can be straightforward to do. This is one of our cases from Vancouver on the left, and this is what an explanted Evolute looks like from our explanted valve registry that we have here. So when you think about valve-in-valve TAVR, and this is treatment of failed surgical valves with a TAVI valve. We're all very familiar with Dr. Vinny Bapat's app, which is incredibly helpful. But most surgical valves are roughly the same height. They have very similar designs, and therefore the where we place these valves is also very, very consistent across different platforms. Now, by comparison, if you just consider just the factors on the left, which is what type of valve you used first, the implant depth of the first valve, because that can vary, the commissural alignment of that valve can vary, then the second valve that you choose and where you place the second valve, you already have a number of permutation and combinations, and so it's much more of a mosaic when you think about Redo-TAVI. Now, while Uri's series that was published in JACC showed that Redo-TAVI is feasible and safe, it is important to note that this is very selected patients, and this is selected patients that were thought to have a low risk of coronary obstruction. Learning from our experience from TAVI and failed surgical valves, we have become very good at identifying the risk of coronary obstruction. And so you can see that this series from Raj Makar's group showed that there is a risk of obstruction that can occur. And this very nice series from Toby Rogers' group showed that when you compare short frame versus tall frame valves, there is differences in terms of risk of obstruction, and they looked at different treatment combinations, but you can see that the rate of obstruction with a tall frame valve can vary between to as high as 91% or even 75%. But what is important is that even if you have a short frame valve, approximately a quarter of cases may be at risk of need of coronary obstruction. And so this is not a small risk regardless of what platform you have. We also know from Wuri's series that there was a slightly higher than expected rate of moderate AI, and then given the different combinations of Redo-TAVR that you can have, we wanted to test this out because obviously not many people have a significant amount of clinical experience with cases such as this. We looked at different combinations of Redo-TAVR in a bench study, and we found that largely most combinations are good, but there are some that may be a word of caution, and we will talk about that. Specifically, this is another paper that we did that we will highlight some of the key learnings from, but largely speaking, one of the areas of concern is where do you put a short frame valve into a tall frame valve and do that safely? Particularly, for example, like we looked at in this paper, where would you place a SAPIEN inside an evolute, and what are the things to consider? So let's go through that. So some of the technical things that you need to know is that when you think about Redo-TAVR, unlike treating a failed surgical valve, there are some nuances and some differences and some new terminologies to consider, such as neoskirt height, which is familiar, but there are differences, leaflet overhang, index THV expansion, and leaflet deflection. So let's go through each of these. So neoskirt height, as we're very familiar, this with surgical valve, this is when the first valve leaflets are pinned up and basically create a tube graft when the second valve is placed. Now, as you can see, we try to show differences in neoskirt height across different commercially available transcatheter heart valves, and there's wide variability compared to commercially available surgical valves. You can have, just for example, comparing the SAPIEN 3 to the Evolute Pro, the neoskirt, which is from the inflow to the top of the pin leaflet, can vary between approximately 17 millimeters out to as much as 27 millimeters. And so therefore, when you combine this in relationship to patient anatomy, the risk of obstruction can vary, as we've demonstrated in the prior slides, between different THV platforms. But what is actually important is the height of the neoskirt above the annular plane. And what we demonstrate here is this is a combination of SAPIEN and SAPIEN. And you can see that if the first SAPIEN was deployed low, you would have a lower neoskirt than if the first SAPIEN had been deployed high. And so that's an important consideration. And this is another slide that shows that the neoskirt is not necessarily high for all supraannular valves. For example, this is the recommended implant depth of 3 different commercially available valves. You have the SAPIEN in the middle, the Evolute, which is generally recommended to be implanted between 3 and 5 millimeters deep. And then you have the accurate valve that is generally always aimed to be deployed between 5 and 7 millimeters. And you can see that the neoskirt height for the accurate is actually closer to that of the SAPIEN than it is to the Evolute. And so each valve needs to be considered on its own rather than assuming a class effect. The neoskirt height can also vary based on treatment. So, for example, if you put a SAPIEN low, you will get a much lower neoskirt height inside an Evolute than if you put a SAPIEN high inside the Evolute. And this is just showing different node positions of where the outflow of the SAPIEN would sit in relative to the Evolute valve. And so same thing in this combination here, the neoskirt height can vary between 20 and 27. One thing that can happen, though, is that the lower you go with the SAPIEN inside an Evolute, not surprisingly, you get this phenomenon called leaflet overhang. And we demonstrated that in our paper, which basically shows that if you deploy a SAPIEN low inside the Evolute, you have the leaflets of the index Evolute hanging over the outflow of the SAPIEN valve. And so you can see that that leaflet overhang can be as much as 90%. But the higher you go, you can mitigate that and can go down to as low as 9%. And maybe the sweet spot is by deploying the SAPIEN 3 outflow at node 5, where you only have approximately 50% overhang. We did not see any functional impact on performance when we did this testing of the new valve, but the only caveat is that We tested this in brand new surgical valves and not in explants, which we're currently working on. By going too low, there's also some concern with regards to leaflet overhang, and that you can get a dynamic flow effect between the two valves, and this may potentially be of concern in the future. We have to understand this a little bit more. Index THV expansion is also important, and the reason it's important is because when you place a sapien inside an evolute, for example, what happens is that the index evolute expands out because of the sapien. And so this expansion can be as much as 5 millimeters by radius in some combinations. And so it's important to understand what the impact of this will be. And this is detailed in our publication. The reason that's important is that if you are going to measure your VTC risk, and this is Philip Blanky's original description, say this is your circle just showing the evolute frame, that is insufficient because you have to account for what the sapien will do. So it's actually better to draw a circle assuming the maximal expansion of the sapien just to be safe, because you may actually end up with a situation like this where the VTC is actually very high risk rather than being safe. The other thing that can occur is actually the opposite effect in some combinations. So we know that in sapien and sapien deployments, you can actually get potential underexpansion of your new index THV. So this is an example of a 23 millimeter sapien XT valve that was treated with an S3 23 millimeter, and you can see that the valve of the 23 millimeter valve is actually underexpanded. It's only 20 millimeters. We looked at this on the bench, and what you can see is that you have a 23 millimeter S3 and a 26 millimeter S3 treated into XT combinations. And even despite us trying to post-dilate these to high pressure with the non-compliant true balloon, you can see that there's still under-expansion of these valve leaflets of the new valve. And you get this phenomenon called leaflet pinwheeling, where you have redundant leaflets. And these leaflets, when you have pinwheeling, may cause strain on the leaflets. And certainly that has been shown from a biomechanical perspective, and that may reduce durability in the long term. In some combinations, for example, and this is sapien inside an accurate neo valve, you actually get a completely different phenomenon where you don't get expansion of the valve at all. In fact, the upper crown of the accurate, which is this region here, is very rigid. And so therefore, what actually happens is that you get under expansion of the sapien, but it potentially beneficial from a risk of coronary obstruction. This is the actual technical edge of the accurate neo valve. And what you actually get in the end is actually this gap that exists. So you actually gain a bit of VTC, which is approximately about 2 millimeters. And what was nice was that Ole de Backer did a clinical case of a sapien inside an accurate that was very close to the left coronary ostia, and he was successfully able to do this and demonstrated this gap that exists. So hopefully what I've shown to you is that this is clearly a very mosaic approach to different cases. Each individual case of Redo-TAVI needs to be considered and, more importantly, planned individually. Taking a one-size approach for all patients will not work like it does, generally speaking, in failed surgical valves. We have to be very careful, very thorough in our planning for Redo-TAVI. Just like any TAVI case, the success of a Redo-TAVI case comes from planning. So to help aid with this complexity, there may be future solutions when it comes to case planning. This is Darcy simulation, which actually just got FDA clearance for its precision TAVI product. You can see here, they're simulating a sapien inside an evolute. They can show you exactly what that looks like. And also what it looks like relative to the coronary anatomy, the root anatomy, which is very, very important. There are also some future solutions. One of the challenges with Redo-TAVI is the presence of the first valve leaflets. And so what you may be able to do is actually modify these leaflets. And we have different technologies that cut leaflets. But what may be more exciting is if you look at the image on the right, this is a technology called Excision Medical, which actually removes the leaflet. completely. And so hopefully this will be a future solution in the future. So in conclusion, in patients with longevity, I think it's crucial to plan for future procedures. THV design and initial implantation will have an impact on the Redo-TAVR, and a failed approach to Redo-TAV is absolutely essential. Thank you very much for your attention.
So this is recorded, and I would like to have Dr. Han to introduce the next speaker.
So next, hello. Yeah, so next speaker is Dr. Karl Poon. I think Dr. Karl Poon, we don't really need much introduction. He's very popular in Taiwan. I understand that Dr. Karl has proctored many centers in Taiwan. So as you know, Dr. Karl has is one of the highest, if not the highest implanter, TAVI implanter in Australia, with over 300 cases a year. And I think we also read many of his publications. He's a permanent fixture in many of the international meetings like EuroPCR, London Valve, and of course, Dr. Karl is very well published. So we all agree that Dr. Karl will be the best person to talk to us on, educate us on the next topic, on pitfalls in aortic valve-in-valve. So Karl, stage is all yours.
Thanks, Jimmy. That's extremely kind of you to say that. I think we have some issues with IT. Hopefully we can get to that quickly. But hope you enjoyed Janar's talk. It's always been trailblazing. He's invited to our meeting, national meeting in a week or two to talk about his experience. But once perfect. So I've been asked to talk about aortic valve-in-valve, particularly surgical valve-in-valve. So with the focus on basilica. So native coronary obstruction in native tri-leaflet aortic stenosis TAV is relatively rare. And I think nature would not allow a leaflet that obstructs a coronary every single heartbeat from the day of birth. And I think to have coronary obstruction, even though coronaries are perfused in diastole, to have coronary obstruction, you'd probably need some pathological changes, particularly lengthened leaflets with bulky calcification. So thankfully, it's a rare event in native tri-leaflet aortic stenosis TAVI. The scene is very different for surgical bioprosthetic AVR because I think the anatomy gets changed. The valve can be placed high. There could be leaflet mounted on the outside, but more importantly, the new concept of sinus sequestration, because the valve can obstruct at, or the leaflet can obstruct at the sinotubular junction. And this is why, as we all know, there are strategies such as basilica, which is perhaps a little bit more established, and some of the other ones that Janar mentioned, particularly shortcut with PiCardio, that's been gaining some traction in the US. And I think in Europe as well, we don't have access to it in Australia, despite asking many times. So the only strategy to improve the chance of coronary flow, at least in Australia, is basilica. So we did our first basilica in 2019 or 2018. So it was interesting to hear from Jenna that, and there's this idea that accurate will not obstruct because there's a gap. And in fact, when we did our first case many years ago, being the first in the world, the commentators did not believe that we did it. And these are the data before 2020. We failed at the right coronary. We had to do a left coronary twice, but these were early days, and now the past 5 cases was an additional 20 or 30 minutes. And I hear all the time that it seems to be a difficult procedure, but to be honest, once you've done 1 or 2, you know the steps very well. And it's 20 to 30 minutes extra. But this was our very first case of all the cases that we had to do. We had to do an accurate neo that failed early, and we had a catheter engaging the left with TOE guidance and lacerated. Now, this is a very unique scenario. So when you do TAV-in-TAV and you have to lacerate, there's the idea that because the leaflets are so much longer than a surgical valve, it may not work, and perhaps it didn't work. We wouldn't know. We did CT afterwards as well. But essentially now we tend to do balloon-assisted basilica where we actually traverse the leaflet and then use a 5 mm non-compliant balloon to improve the chance. But this is the basic setup. So you have ipsilateral access and contralateral arterial access as well as per usual TAVI. You don't need contrast for or pigtail. So the contralateral access is really just to snare the wire. So the coronary guiding catheter, we used to use 8 French, 7 French, but you don't need support. You need a length or the lack of. You really need a shortened guide so that you can have other catheter within, such as our favorite now, a pigtail catheter, because you can cut it and change the angulation. The startle wire for traversal or laceration is very stiff. So we learned in the early days that the stiff wire will just straighten out, and this is why the pigtail is probably the best option to control your angulation by pulling and pushing in terms of where to touch the leaflet. The contralateral side is really just for snare. So in the US, they had the pachyderm, but they've stopped making it for a few years now. So the benefit of the pachyderm is that it's almost shaped to attack the left leaflet. Now, all of this is just about the left coronary. The right, I still don't know what's the best option. So this was an epic valve, hard to see as we learnt yesterday. 7 French guide, cut pigtail, so shorter guiding catheter, longer pigtail. The pigtail has been crucial. That's certainly our preferred setup. So you have a snare just below the valve. This was an interesting, memorable case because this required no electricity. The stiff wire, perhaps particularly fragile leaflet, traversed without electricity, which is unusual. Sometimes you need a lot of electricity, up to 100 to traverse. Nevertheless, this is a stabilization wire within a 6 French guiding catheter and a snare. The snare should be spaced or sized based on the LVOT. Check the contralateral angle to make sure that the wire is within the snare. You don't want to snare further down because we had a case where we snare and encase the mitral apparatus. Every time we pulled, there's a hemodynamic collapse, and that's when we learned that we had a lot of chordae in our early days, so avoid that. So we snare, unlike Dr. Lee's case shown yesterday, we snare and actually pull the wire back into the JR4, so the wire actually gets kinked in there, and we use that as support. The piggyback microcatheter is good. You can stabilize and lock the without a TUI, so you know the relationship between the catheter and the flying V. So I tend to actually make a V first and then scrape rather than scraping and cause a V again, but that's where you lacerate and pull. I should have gone to the pulling because there's a tip here where this was wrong in that the catheters really should have been on the inner curve before you start, because we had a lot of electricity here before we actually lacerated. So it really needed to set up with all the catheters on the inner curve before we lacerate. And the last thing is there's always concern about aortic regurgitation, and quite often there will be an expected but tolerable, as long as you probably have another minute or two before you have to rush to put a valve in. But the rest of it was perhaps a routine valve-in-valve. We cracked it with the true balloon, and this kind of shows what would have happened if there was sinus sequestration, albeit grafted LAD, but ungrafted circumflex system. Because we didn't have the pachyderm, I would suggest by Helen Greenbaum to actually use heat gun to change the shape. But again, in this whole process, I learned the Estado wire is just so stiff. At the end of the day, you put the Estado wire down, everything straighten out. So that's why we use the cut pigtail technique. So with proper planning, it really has not been as difficult as we feared. And I think Jeffrey Kahn would say a single-sided, left-sided basilica is about the same as a tip-to-base lampoon in terms of difficulty. The ones I struggle will be with, as has been the published data, double basilica is particularly challenging and hard, and right-sided basilica similar to a base to tip lamp Poon, but I think in the context of aortic valve-in-valve, it may need to be an extra skill set that we have that's basilica. Thank you. So it's actually my pleasure to introduce Dr. Lee, who's a very high volume TAVI operator, but particularly impressively has adopted a lot of new techniques that I've learned, including lampoon and all sorts of basilica and TAVI in ring. So he has 2 cases I understand that we can learn from. Dr. Lee is obviously a surgeon at this hospital who practices as a cardiologist in TAVI. Thank you.
Thank you, Dr. Karl, for the introduction. And I will introduce a case, 67 years old female. He got a failed aortic prosthesis and torrential tricuspid regurgitation. She received the 2 metallic valve in aortic and mitral position. After a couple of years, because initially the aortic valve is 17 and the mild aortic patient prosthesis mismatch, and the only comorbidity, atrial fibrillation. The STS score is 2 and the frailty score is 0. So here is the echocardiography. We can show here the aortic valve failed, and there's a pressure gradient is 77/44. It's how do we do the next is quite difficult because we redo the aortic valve. However, the mitral in position in a good function, so that we try to do the redo. And at the same time, there's a torrential tricuspid regurgitation. You can see here the right side is quite large, and the regurgitation is torrential. So as we do the CAT scan before the surgery, and the outer mitral curtain is calcification, and we think it is quite difficult to remove all the thing, and even do the enlargement step some dangerous. So we cut the aorta first and implant stepping 3 20 millimeter extra 1 millimeter balloon, and then with good function. In here we can see very low coronary high, and you can see the movie here as we slowly deploy the aortic valve, and you can see you must aim the balloon skirt to the valve skirt to the annulus, so you can deploy it very gradually, and the only mark is the shrink skirt over the previous valve and the S3 skirt. So that's I think it's quite difficult to keep the constant pressure. That's you must adjust quite a lot. So there's after procedure, only mild aortic stenosis, and the tricuspid valve function is quite well. So for our opinion, for in this case, as the redo surgery can do more because the transcatheter valve usually leaves another problem, such as a coronary problem, need the coronary intervention, or the tricuspid valve problem, you need to do the tricuspid. However, the technique or the result of the tricuspid is not clearly, or even you leave the mitral problem did not solve the problems. So this is our first case for aortic valve redo surgery.
So our next speaker is Dr. Faeez Muhammad Ali. Dr. Faeez is an intervention cardiologist from New Zealand, Waikato Hospital. He's the lead on intervention and also lead on the structural heart program over there. And we understand Dr. Faeez is also not only he's an expert and a high volume implanter for TAVI, he's also holds a hot portfolio of quality improvement in his department, and he's a lead cardiologist for a innovative and new program initiated to screen patients in community who are lost to medical system, which is a first of such program in New Zealand. So Dr. Faeez, we look forward to your lecture on mitral valve-in-valve. Stage is all yours.
Right. Thank you very much. Greetings from New Zealand. Good morning. I've been asked to speak about mitral valve-in-valve, state-of-the-art, and I will try to do this in 5 minutes. Right. So I have no particular disclosures with respect to this talk. So in state-of-the-art, what's new in mitral valve-in-valve? I'd just like to touch upon 3 main things: the midterm data that was recently published, the management of the left ventricular outflow tract, which is really the Achilles heel of the newer generation of TMVR devices for the mitral valve, and the role of imaging and 4DIs, what we can do for valve-in-valve. So as you all know, valve-in-valve is a well-established therapy in patients with dysfunctional bioprosthetic valves, and those patients who are high risk of redo surgery. Surprisingly, there are no randomized control trials. We have a bunch of registry data. So this is the mitral trial that was spearheaded and presented by Dr. Mayra Guerrero from the US, where they looked at patients with valve-in-valve, valve-in-ring, valve-in-Mac, and they followed them up for recently presented their 5-year data. What's surprising to note is the in-hospital, I'm not showing that slide, but the in-hospital mortality for valve-in-valve was around 3%. Valve-in-ring was about 6%. Valve-in-Mac was about 8 to 10%. But when you come out to 1 year, the valve-in-valve remains more or less the same. The valve-in-ring is about 26%, and valve-in-Mac it's about 33%. And out to 5 years, the valve-in-valve is about 21%, valve-in-ring and valve-in-Mac about 65 and 67%. So this does tell us that valve-in-valve is a relatively safe procedure with really reasonably good midterm outcomes. But valve-in-ring and valve-in-Mac is certainly an unmet need where we need better devices to manage a sicker cohort of patients. So this really probably reflects the sicker cohort of patients that was treated, the lower LV function, the high risk of redo. So it really is an unmet need where we need to focus newer technologies for patients with mitral valve-in-ring and valve-in-Mac. But the real positive thing that I take out of this data is the durability of the SAPIEN valve in all 3 spaces, because you can see that even up to 5 years, the mean gradient was more or less stable at about 5 to 7. But mind you, this is a small number of about just around 40, 50 patients. But nevertheless, a good signal to say that these valves may be doing okay in the mitral space. That was the midterm data. Now, regarding the left ventricular outflow tract, as you all know, it's a small tunnel. It's a tunnel between the interventricular septum anteriorly and the anterior mitral leaflet posteriorly. In systole, it closes up and widens out. In diastole, it opens out. The LVOT narrows down as the anterior mitral leaflet opens. As you can imagine, when you put a prosthetic valve into the mitral space, it produces sort of a fixed systolic obstruction to the left ventricular outflow tract. And if it does obstruct, the results are quite bad. Patients almost have an in-hospital mortality of about 50%. Now, as far as mitral valve-in-valve is concerned, the risk is really low. It's very uncommon to have for us to do a tip-to-base or some sort of Lampoon procedure or some sort of modification of the LVOT to mitigate the risk. But it is very high in valve-in-Mac and the new TMVR devices. And Dr. Kang-Yin will tell you about the Apollo trial and the almost 50% of patients who are almost excluded from those group of trials because of issues in the LVOT. So it's really important to plan the procedures. CT scan can tell you what group of patients are at high risk. Risk factors like asymmetrical septal hypertrophy, long anterior leaflet more than 22, the device, the dimensions of the device. Those are all things that need to be taken into account. This is a nice flowchart that was published by the group at Emory, where they showed that if you had a neo-LVOT of less than 200 or a skirt neo-LVOT of less than 180, then you'd probably need to do something for the left ventricular outflow tract. So what are the options to modify? Alcohol septal ablation, Lampoon, classic antegrade tip-to-base balloon assisted, and the new kid on the block is the Sesame procedure, which I will touch upon and a bit later. So this is a patient that we recently had. The patient had a high risk of LVOT obstruction. The new LVOT was 138, and post alcohol septal ablation, it was about 210 to 20. So alcohol septal ablation does work, but it's interesting to note in the mitral registry, about 1/3 of patients needed septal ablation, and of those 1/3, nearly around 4 or 5 patients needed some form of leaflet modification to further facilitate it. So it's not foolproof, so to speak. I know you had we all had a masterclass of Lampoon yesterday, so I won't go into it too much. It's essentially where you lacerate the anterior leaflets, cause it to splay out like a curtain, and allow blood to flow through the struts. So this is an interesting patient we just recently had about 2 years ago. Young patient, a 26-year-old patient who presented in shock and pulmonary edema. She was morbidly obese with a BMI of more than 60, had a failed mosaic valve, 25 millimeter mosaic valve in the mitral position with a mean grade of 25, severe pulmonary hypertension, severe RV dysfunction, essentially crashing and burning, and she was not surgical. You can see that the struts of the mosaic was protruding into the LVOT with the predicted knee LVOT of 160. And hence we decided to do a tip-to-base Lampoon because it's easy to do and doesn't take too much time, and the aortomitral curtain is protected, so it makes it a lot easier. You can see that the flying V lacerates the adjoining septal leaflet. You can see the corresponding TOE images. And over here, you can see during the cut, bubbles are generated, and at 5 o'clock, you can see a nice little rent in the leaflet, suggesting that it was successful. Then we went on to deploy a 26 millimeter sapien valve and went on to fracture with a 26 millimeter Atlas Gold. The result was very good. The mean grade was about just 4 or 5. And over here, you can see the entire sapien valve projecting into the LVOT with no significant gradients. 2 years later, she came back, but this time the aortic valve had gone off. But this time around, she was in a much better position to have open heart surgery, and that was done. The valve was explanted. You can see that the fracture frame or the sewing ring of the mosaic that was fractured, and the splay of the Lampoon that worked well. The gradients of the mitral valve was working beautifully, but you can see the significant pannus that she had on the explanted aortic valves, and this patient did reasonably well. The next procedure is called Sesame. This has been pioneered by Dr. Aaron Greenbaum, Dr. Letterman, Jafar Khan, the group at Emory and NIH, where essentially what they do is they mimic a surgical myotomy, where they use transcatheter electrosurgery to pass an electrified wire through the interventricular septum and snare it out into the left ventricle. Using a flying knee, they lacerate it. So essentially it creates a canal-like structure in the interventricular septum, and over a period of time, the circular fibers cause it to splay apart more, and that facilitates a TMVR. It's also being used in patients with hypertrophic cardiomyopathy with no good septal options for a septal ablation. They have reported a few first-in-man cases, and I'm sure they're doing their studies, which we will all keenly await. Now, the role of fusion imaging. A lot of vendors have various modes of fusion imaging, combining CT with fluoro or TOE with fluoro. Very useful in certain cases. You can plan your transseptal puncture. Certain valves, like the Biocor Epic valve, you cannot see it. You look carefully enough, you may imagine a string over there. It might be really useful in those cases where you can plan your procedures, overlay it, go in and deploy a valve. Newer dynamic fusion imaging modalities are coming up where there's real-time fusion of the TOE or the CT images with the fluoro, and that should make it a lot more accurate. 4D ICE is really picking up, especially in the tricuspid space. But as far as mitral valve is concerned, those patients, you want a minimalistic approach, or you want to avoid anesthesia, or TOEs are contraindicated. This is an amazing modality to have, where you can literally plan your transseptal puncture, pass your ICE catheter into the LA, minimal manipulation required, you get beautiful MPR images, and then the rest of the procedure is essentially the same, where you implant the valve, get really good images. But this, I will stop. So just to conclude, mitral valve is a safe option. We need better solutions for valve and ring, valve and MAC. LVOT management strategies are evolving, and it really helps us take on more challenging cases, and imaging will allow streamlining of cases. Thank you.
Let me introduce the second case for the mitral valve operation. And a 72 years old, we failed mitral valve repair because of the previous mitral valve is too small, and you can see the posterior was not. It's under the coaptation high, and the anterior is not fully open, so it causes the severe mitral regurgitation. And here is another picture that shows that the coaptation lung is not good enough. So the STS score for this case is 7, and we convinced the patient to receive the reduced surgery. However, patient refused to do reduced surgery because the first time bad experience. And the patient was referred for the transcatheter mitral tear. However, we think the posterior is too short, cannot capture again. So that we try to do the mitral valve in rim. And here is the CAT scan. Neo LVOT to septum is 5 millimeter, and the outer mitral angle is 120. Neo LVOT is 185. It's a borderline case. However, in the mitral valve in rim, LVOT is always the concern. So we try to do a Noppon procedure, and the CT area is 437. This is 29 valve in ring procedure. So that's every case we do brain protection device. Usually we can capture some debris, especially we do a Noppon procedure or prosthetic procedure. And we puncture the septum with VRK1 and SL1 with under the TE guide. And then we do the Noppon procedure. I had showed yesterday, and just we previously showed as the Noppon procedure. It's quite easy, and this evening we will do another Noppon for the mitral valve in rim. And then we do the septostomy. Then deploy the valve is with 30-70, and we deploy very gradually because if we put to atrial side, the supravalvular leakage will occur, and if we implant to ventricle, that's maybe cause the embolization. So this patient is under is mostly 70-30 and partly in the inferior part, posterior wall part is around 82%. 80% to 20%, so that's without any regurgitation burden. It's our case shown here, and we did for discussion.
I guess we finished all the talk. So thank you for all the speakers for the excellent talk, and I think we covered all the aortic valve, mitral valve, valve in valve, and reduce, and all the other pitfalls. So we'll have 25 minutes for discussion. I'm pretty sure there's a lots of discussion point and the questions, and anyone want to start it?
So, Dr. Poon, thank you very much for your excellent speech. And in your presentation, you mentioned that Basilica procedure, and also you mentioned that 2 techniques, and one is a transversal, and another one is snare. So my question is, in which scenario where you choose the snare technique and another one for the transversal? Is there any consideration for these 2 techniques? Thank you.
Thanks, Dr. Shi. I think so. I think as part of the procedure, you traverse and then you snare the wire in such a way you can lacerate at the same time. So so that's sort of all part of that. That's necessary. I think I second the comment from Dr. Lee as well about the need for, or perhaps consideration for, cerebral embolic protection device. Not that there's any data, but I also second that every time we did it, there's a high chance of debris capture. But usually I think we do traverse and snare for most of these leaflet modification, which may be why it's considered somewhat challenging and maybe even tedious. But if I'm allowed a question, maybe I'll engage Mike. I'm sure you have a comment, but I suppose in the current era, when we actually do not have randomized controlled trials between valve-in-valve and redo surgery, how do you decide now for this subset? But going forward, do you think there's a need for explant for TAVI failure compared to TAV-in-TAV? Because I'll be very interested to see how much are screened out, and we obviously don't have the data there. As a pioneer in this, do you think that's necessary, explant compared to TAV-in-TAV?
I think, Karl, that's going to be very difficult to do pragmatically. When I look at failed TAVIs that are sent to me to consider for a TAVI-in-TAV, the two major reasons I have for turning them down and operating them are the risk of coronary obstruction and pre-existing patient prosthetic mismatch. And I'm not going to be able to randomize those people. For those that don't have a patient prosthetic mismatch and don't have the risk of coronary obstruction, it's going to be very hard to get my patients who are more elderly patients to consent to surgery, along with the fact that we have some pretty good data that TAVI-in-TAV, when it can be done well, is a very low-risk procedure. Whereas TAVI explant still is fairly high risk. I think for sites that are now doing this routinely, my next one that I'm going to do is on Monday, so it's becoming a fairly routine operation. The mortality is coming way down, but it's still a much bigger thing than TAVI-in-TAV. So, I think that although it sounds interesting from an academic standpoint, I think pragmatically, it's going to be hard to find the right people because of those that literally need surgery because of coronary obstruction or endocarditis or patient prosthetic mismatch versus what the patients are going to want too. And I'm a big fan of surgery. It's just that not always appropriate.
One interesting idea I've seen is rather than doing an explant, particularly a long frame where you convert to root surgery, is to just cut out the leaflets. Yeah. Do you think that's a good idea at all? Does it make the surgery any easier?
Well, so it depends on what you're trying to achieve. So let's think about the first case we saw with the aortic valve, where we just put a sapien inside that old valve. We did this on a young lady who really needed 2 mechanical valves, but she was too sick to get them. And so that made a great bridging operation to get her to the operation that she needed. If this lady had been 67 and you're hoping to get a 15-year outcome, I would not have done that. I would have taken the valve out. I would have done a Y annuloplasty, which you can do even with a mitral valve in there, and put in a big aortic valve, or just done 2 valves, even if you had to do a commando. So I think you have to be thinking about the patients and what you're trying to achieve. I personally don't. If I'm going to operate on, once I've stopped your heart and cardioplegia and open it, it's not that hard for me to take that valve out and do it. It's really not technically that difficult. I think a lot of these are being done by surgeons that haven't done many yet. They just haven't learned the techniques. But again, if your patient's sick, they're not going to live very long. It's an easier in and out. I think the first case we saw today was a brilliant approach to a sick young lady who needed a bridge to get her further.
Great comments. Thanks. I want to also ask you to first ask you for about the comments on the one topic, and then we'll ask all the panels. And as you know, the TAVI now has moved to the very young patient, and we know there will have a second intervention for sure. The current data is up to the 30% that we do, but that's all because there's an elder patient that we usually put the tissue valve. But in the future, I'm pretty sure it will be almost the 90% chance that you have a second operation. And Janar has present all the combinations valve and have difficulty. Some definitely have a more risk for the coronary access issue and the problems. So I just want your comments on that. If for the young patient, the 50 years old, now you need a TAVI, is a healthy young patient, and definitely need a second valve intervention. So what type of valve you will choose? Because you have extensive experience in both the core valve and and the SAPIEN valve. So I just want to you comment what type of valve you were selection for this kind of patient.
For a 50-year-old?
50-year-old, no other comorbidity, otherwise pretty healthy. We know that 100% will have a second.
Okay, well, first of all, since I'm 70, very young to me is anybody younger than 70. And 50-year-old is only 4 years older than my oldest daughter, which means that that's much too young for a TAVI. Unless there's something else. If they're healthy, they're 50 years old, they're not going to get a TAVI in my institution.
We presume this is not surgery for just for TAVI. So okay, no other option. Patient refused to have surgery, now decided to have a TAVI. So what do you comment on?
So a 50-year-old in my place just can't decide to have a TAVI. They can go shopping for another doctor, but they're not going to get a TAVI in my institution. And unless there's something wrong with them, I don't think they're going to live but 10 years. If they're not going to live but 10 years, then if it's a woman and she's going to get a 23 or bigger balloon expandable valve or a self-expanding, okay. A man at 26 or bigger balloon expandable or a self-expanding. I don't put 23s in men very often. I would never put a 20 in somebody that I expect to live very long. But that's you know, I have done some 50-year-olds, but they're 50-year-olds that had so many comorbidities they weren't going to live 10 years.
Okay, how about a 60 young?
Well, 60 is also very young. Remember, in the low risk trial, only 1.6% of people were 60 or less. I ran the screening committee. Only 7% were 65 or less. And if you were less than 65, you did not get in the trial unless you were not a normal 65-year-old. I just didn't let you in. So again, when you look at these low risk trials, you have to remember they were still very carefully selected. Remember in the partner trial, of all the people that were approved locally and sent to the National Screening Committee, 34% of them were denied at the National Screening Committee. If you're denying 1/3 of your patients that are approved locally, we are not looking at all comers. So again, we need to be very selective of who we do. In my institution, 65 and below still goes to surgery unless there's mitigating circumstances.
Excellent. I'm really happy I totally agree. And I just want to give it so I just want to ask the panel that if you know, I'm pretty sure the guideline will change. I'm pretty sure that in the real world, I think this TAVI will move to the young patient because right now the trend is like already moved to the 65. The 45%, I know the 45% they will say these patients have some comorbidity, is a frail, this kind of situation. But the 50% that's less than 65 years old, I think probably some patients are pretty healthy. But this will happen, I think, in the next few years. So what you think which valve should be choose? Because this is the dilemma in the real practice. You know, we use the SAPIEN valve, we use valve, use you know, other like neo, accurate neo, or the other you know, J valve or other valve. So what you very short comments. I will start with Dr. Han. What do you think?
I think the patient is younger, as Dr. Ricardo say.
No surgery. We just say no surgery. We just stop the surgery is not. Yes. Of course, we agree on surgery. I totally agree with Dr. Ricardo. I say surgery. We at our centers less than 70s. We actually push no TAVI, always surgery. So, but we just say this is now no surgery is out.
Well, I'm glad since I'm 70, I can have a TAVI at your center. So I'll come see you when I need my TAVI.
The younger age is the lesion characteristic is simpler than the aged patient. So I prefer the balloon expandable valve, you know, rather than the self-expandable valve. The reason why, first one is the chance of the conduction disturbance. The second one is the next time for the coronary artery access.
In my idea, it's already coronary issue in the future because if you check the multi-site CT, I think that if coronary is low or the STJ or the sinus passava is small, you should choose the balloon expandable. However, is some patient, especially bicuspid, in this age is mostly bicuspid valve, and the calcium is not quite large, such as in China, the calcium is quite bulky, that should be balloon expandable. However, if the calcium is just like yesterday we do just a few calcification, and is some aortic stenosis and resection, and the sinus is large. I think the balloon expandable and the self-expanding valve is just about the same.
Thanks.
Yes, of course, regarding the valve selection, we have to consider many factors, but in general, for a younger patient and the first valve, I will choose the balloon expandable, and the second one is self-expandable valve. Yeah, because I will consider about the residual gradient of the valve. So that's my opinion. Thank you.
Thanks. I think obviously the short frame valve, the balloon expandable, whichever platform, is fundamentally attractive, it seems. If you can place a valve low, particularly avoiding the STJ, but even balloon expandable, you know, as a strong user for balloon expandable over self-expander myself, I mean, I do have concern, particularly looking at the STJ. So if someone's STJ is quite narrow, no valves will be good enough because you have sinus sequestration. So for a young patient, if the STJ is as narrow as your annular derived diameter, I would strongly advise this patient not to have any transcatheter heart valve, because you will have sinus sequestration. And with the current technology, we don't know how to deal with it. So Janar mentioned about the excision, but stroke risk. And the other thing about all the transcatheter and transcatheter is it's very different to surgical valves, because the surgical valves is 3-post. You push the leaflets aside, it goes out. All the transcatheter heart valves, your very degenerative tissue would just be like a Big Mac hamburger in between 2 stents. It gets smaller and smaller, the EOA, and I'm sure Mike would agree the EOA will become a concern, let alone leaflet overhang and other issues. So I look at STJ for young patients, and unfortunately in Australia, or fortunately, we have no age cutoff. So as we discussed before, if I don't do it, someone else can and will. And I dare say that's reflected in the TVT registry as well. So it's a huge quagmire that we have created, but I look at the STJ for young patients every single time now.
No, I completely agree what's been discussed so far. I think this is a very pertinent question for lifetime management topic. So for a 50-year-old who refuses surgery, and I think the 2 things that to me will be very important to address is really make sure that the coronary access is still secure. And secondly, is that when the patient does need surgery, the surgery will be as straightforward as possible, a box standard AVR operation, rather than having to deal with the ascending aorta, aortic root operation. So turning a straightforward AVR into aortic root operation, that may be a concern to me for consideration.
Yeah. Yeah, but that's really not an issue for experienced surgeons. We've done about 38 of these. We've replaced 2 aortic roots that needed to be replaced. You know, surgeons can do either one of these valves really very easily. And I just want to point out one thing, because I'm trying to bite my tongue as we go down this line. You know, the self-expanding valve has been the only valve that's shown to have superior hemodynamics to surgery at all time points. And it's also the only one that's been shown to have superior durability. The Pibero paper that you showed where the S3 and the non-randomized arm looked like surgery, if you read deeper into that paper, if you do inverse treatment probability weighting, which is a better way of matching them, at years 4 and 5, the S3 had more structural valve deterioration than surgery. That wasn't brought out, but it's in the supplement if you go back and look at it. So I would tell you, when you're thinking about the first valve you're going to put in somebody, hemodynamics and durability affect your patient every day of their life. Coronary access or valve-in-valve may or may not come up in the future. I think they're important considerations, but to me, they're secondary considerations. First considerations is what affects your patient every day while they're up and walking around, and that's hemodynamics and durability. So again, I think we'd never do a 50-year-old period. I'll just let them go shopping and find who they want. and I would also tell you that surgeons are going to get very experienced in taking these valves out. And there's techniques for taking both valves out. Aortic root is really not that common. And the good news is we move to younger patients. Young surgeons are going to have a lot of business coming to them, taking these valves out. But again, I think it's very important to separate what might happen in the future versus what your patients live with every single day.
Great.
Okay, sure.
Quick comment.
So, as I am a surgeon, I still consider, I still think about using the surgical heart valve, but if the patient still insists we use TAVR, I will use a short frame balloon expandable valve. But in my opinion, it's about if 10 years later the patient change her mind to do the TAVR, I think the explantation technique would be a little bit easier than the short frame for the long frame valve.
On the panel, Dr. Ali, you have any comments on this? Very short comments, and then what?
Yeah, I just put out a disclaimer. In New Zealand, for sure, patients 70 and below will go for surgery invariably. Sure. 70 to 80 is a joint discussion. Above 80 is just straightforward TAVI. But the practice over here is essentially we look at two things: definitely coronary access and valve durability and hemodynamics as well, because we know self-expanding valves do way better than balloon expandable valves in terms of hemodynamics. The question is, when you have relatively young patients or young patients with limited life expectancy, what will serve them the best? How do you keep them out of hospital when you don't want them to come back? It's a tough question to answer, because if you have as you move to the younger population, you have more bicuspids that come in, and the bicuspids can be quite hostile, and you wouldn't want to put a large balloon expandable valve and risk a rupture. Those a lot of questions that need to be asked before you commit to a type of valve. But at the end of the day, if it's not bicuspid, fairly pristine annulus, balloon expandable is fine, but otherwise we would tend to use a self-expanding.
Great. Okay, it's a great comments from everyone. I think I guess all the comments mainly is based on the life expectancy and also the anatomy. I think critical, and the coronary access, that's the main concern, right, for when you select the valve. So interesting, and when all the comments here, so the TAVI you won't offer to the patient who's less than 70 years old on the panel list, and all the centers, different countries. But the data is really shocked me when I saw the US data. It's 40, 50, almost 50% of the patient, the less than 65 is already done by TAVI. So it's interesting that, here that everybody, our center is 70 at least, and most centers seems like a 70. That data is really shock me. And also, even like I talked to John Webb, and he also shocked that the data is like 50%. So I think it's very interesting, in the next few years of what we'll see what happened. So any other comments and questions? Or Dr. Hart?
I'd like to comment about the small size of the valve. One speaker said that the structural valve degeneration will occur maybe 10 years and 15 years, even in the TAVR and the SAVR valve. These are the usual finding. And second one is what is the most predictor or risk factor of the structural valve degeneration? Small size of it. Actually, anyhow, small valve size and the small valve area is one of the strongest predictor. So why do the surgeon or the interventionist deploy the small size of it? Because the patient stature, performance is small height, all anatomy is smaller. Therefore, they do implant the small size of a surgical valve and the TAVR valve. So, and this kind of situation is the more common in the Asia rather than in the Western country. Actually, in our lab is this kind of a small size of annulus is 140, 1/4, almost be 20 or 25%. 25% of the patient group is a huge number of patients. Therefore, in this kind of patient, we try to get the more larger, bigger size of the effective aortic and the orifice area. That is one of the concerns.
Great, thanks. I just want to, since we have two cases and a second case, I want to have some comments on the second case, the mitral valve, failed mitral valve repair, and then they did the Noppon and then valve, great outcome. But I think it's a great, the initial decision making and outcomes. But my question is, the patient is pretty healthy. They refuse to have surgery. So based on the current data, as a valve in the ring, the outcome is not great. But of course, that's a patient selection probably issue. But generally speaking, the outcome is not great compared to the valve. So if this patient failed in the few years, 72 years old, I think a life expectancy probably is another 10 years. So if failed, what the further option?
I think it should be the operation for the prosthetic failure, because we have the experience about one quite young case that he was 28, received the mitral valve in the mitral position, use the lotus valve. And when he do the mitral valve prosthesis, he say, if we do the conventional surgery, the reduced surgery to him, that he will jump from the floor. So that's at a later moment that we do the mitral valve. And after 8 years, and the valve failed because of the degeneration, and he lost power maybe 1 year or 2 years, and he came back for the liver failure and the heart failure. So we spent a lot of time to discuss about the choice. And this time he chose the metallic valve, so he no longer needed another surgery for mitral position.
So that's a general question. Now, this patient, just for general comments, not particular for this patient. So when we discuss with the patient, do we ask the patient that if this failed, what do you want? Because he refused surgery. And if you do surgery now, probably is relatively low risk. And you do another surgery when the age close to the 80s. And then what the kind of option for him? Because if you do a valve, probably will be pretty high risk for the LVOT obstruction. So now that's a real, in a real practice, right? Your patient that you discuss this kind of issue, and what's the sub, because he's relatively young. So do you think if you give this kind of information, patient would change the mind, or they would, that's an interesting question. Not particular for this valve, but for all the other cases down, in the real world, including me, some patient that refused to the surgery, and then we do some procedure, and of course, a simple procedure, good outcome, but we really discuss about the subsequently, potential situation.
Really, I do not have any idea about in the future we need to face the mitral valve failed cases. I think it will is not far away from this moment. And I think that we need to talk to patient about in the future that you maybe if you are 70 or 80, you need another valve. And sometimes involved that LVOT is large, that is not a concern. If the LVOT is concerned, the surgery is a better one. And I don't know that Noppon could be done in a second valve or cannot, because conventional Noppon, it cannot be done like just pull the wire. So you need a transapical one from the base to tip Noppon in the future.
I think there's the other aspect that you probably will not have commercial alignment in any manner.
Yeah.
You will need to be lucky. We tried and we got lucky, but it's not guaranteed. The only way I suspect to modify the leaflet in this position for TAV, mitral valve in valve, is probably shortcut or something similar where they can cut it. I think Noppon will be difficult.
For the mitral, I think, Karl, that's absolutely true, because you're going to have that frame to deal with. It's not like the aortic where you're inside the frame, you're going to be transversing. I have to say, I was really surprised to see this case, because I've never met a surgeon who's ever admitted that one of their mitral valve repairs failed. So, this clearly came from some surgeon that none of us know. And I think the first thing we have to do when we look at this is ask ourselves, what's the anatomy and could it be re-repaired? If you see an obvious flaw that can be re-repaired, it's worth really sitting down and talking to the patient about that. because that clearly will serve them better. And yes, I actually do talk to patients about what do they expect and what the future is. So when I get somebody that's 65 that gets into my guidelines that wants a TAVR, but I think they're going to live 25 years, and I think they do better with surgery, I do tell them that if I have to take your TAVR valve out, the data now says the hazard risk of death is 2 to 3 times more than if I was just doing a redo aortic valve. And sometimes they say, I'll take that risk. But sometimes they say, well, gee, I never knew that. So I think talking to patients about what they expect and what the future brings is really quite important, particularly for borderline people. You take an 80-year-old, you don't really need to talk. You're planning a one and done as much as possible. But we are seeing these younger people come in and pushing us. And as I said, I have enough to do. If you come in and you're 50, I just send you on your way if you don't want me to operate on you. But there are people pushing for that. And I would say the reason we're seeing so many young people is many of the cardiologists and surgeons out there have no idea what the low-risk data really says. They just know there's 2 trials, they're positive. They can't tell you how many people were less than 65. They can't tell you who is excluded from the trial. And I think it's incumbent upon us to really educate people about that.
I totally agree. Okay, and now that time is over a little bit, and thank you much for all the speakers for your excellent talk, and thanks for all the panelists and the moderate for excellent discussion. We have great session. Thank you.
Educated roundtable discussion. We will proceed to the next section. The topic is transcatheter and surgical valve interventions. Let's welcome our renowned moderators and panelists. So without further delay, so we proceed to the next session, please.
Okay, let's proceed to the next session. That's the keynote lectures on the topic of transcatheter and the surgical valve interventions. The moderators will be me and Dr. Ye Jian. He's coming, and Dr. Kentaro Hayashido. Okay. Dr. Kentaro Hayashido is the from Kyoto University. He's our old friend, and we were three. Okay, will be the moderators, and the participant. The participant experts will be Dr. Yin Wei-Xian from Chengxin General Hospital, and the speakers from and the others will be on the line, and they are the speakers of this session. So Dr. Ye Jian, okay, Dr. Ye Jian. And the first topic will be the surplus techniques for both aortic and mitral valve-in-valve that will be presented by Dr. Luigi Pirelli. Probably many people know him. He is the cardiothoracic surgeon and graduated from the University of Milan Medical School. And he received his resident and fellowship training in NYU, and afterwards he worked at the Lenox Hill Hospital in New York. Last year he was still in Lenox Hill Hospital, and recently he just moved to Columbia University and became the director of transcatheter valve therapy. Dr. Pirelli, are you on the line? Yes, you can. Yeah.
Yes.
Okay, thank you.
Hi, and thank you for having me. It's a great honor to be able to present the surplus technique. I hope you guys can see my screen, my slides. Yes?
Yeah, you're up.
Okay, perfect. Thank you very much. So we'll talk about surgical resection of prosthetic valve leaflets under direct vision, a technique that we named surplus for aortic and mitral valve-in-valve. These are my disclosures. So there is definitely a need for redo procedures. So life expectancy is increasing. We are doing procedures on younger patients that would rather have a bioprosthetic valve instead of mechanical. And patients are aware of the possibility of doing less invasive transcatheter options. And also, we are dealing with a different risk profile, because having to do these procedures, these index TAVRs or TMVRs in younger people, once the valves degenerate, we'll have patients that can still undergo surgery, and they're not inoperable. So in terms of lifetime management, the options for degenerated bioprosthesis are simple, are either surgery, so explant or extract the degenerated valve and reimplant a new one, or a TAV-in-TAV or a TAV-in valve. So what are the positive and negatives of the redo surgery? So redo surgery is an established procedure. We've been doing that for a while. Allows placement of a larger size valve if we address the root and we do any kind of root reconstruction or root enlargement. It allows surgeons to do combined procedures in patients that need the coronary vascularization or other valvular procedures, and can prepare for actually future TAVR. What are the negatives of the redo surgery? Well, it's invasive. It's invasive, and the recovery for the patient is definitely longer and more challenging. The patients go back to work in a month instead of a couple of days, and actually patients do not want it. And if we are actually talking about TAVR explant, we know that the mortality of this, or the outcomes of TAVR explants patient is not that great. As we saw in the explant TAVR registry, actually a good proportion of patients are not alive in the short term. And then if we look at the predictors of bad outcomes at 30 days, at 1 year, we can see that cardiopulmonary bypass time and cross-clamp time are two of the main determinants of poor outcome. So what about TAV-in-TAV or TAV-in-TAV? Well, the pros is that it's technically easier than redo open heart surgery. It's fast and less invasive. Patients can go back to their activity and their work right away. And it lowered short-term mortality and morbidity. But we don't know long-term results. There is always a risk of patient-prosthesis mismatch. There is no role in endocarditis, PVL, and patient-prosthesis mismatch. And sometimes it's not anatomically feasible because there is a risk of sinus sequestration and coronary occlusion. So we came up with this hybrid strategy that is both surgical and transcatheter that implies a surgical approach, implies an aortotomy, and the resection of the valve leaflets, leaving the frame of the degenerated THV intact or the stent of the bioprosthesis intact. And then this is followed by the implantation of a balloon expandable valve, basically a SAPIEN-3 valve under direct vision and fluoroscopic guidance. Why do we do it? Because it's faster. It implies a shorter times of bypass and cross-clamp time. It's technically less challenging. I was listening to the last few minutes of the previous session. Dr. Reardon is an extremely experienced surgeon, but not everybody is as good as him in explanting TAVR. And I would say the vast majority of surgeons in the US are not capable of obtaining good results with a full TAVR explants and root reconstruction. And also with this surplus technique is reproducible because it's easy to do and avoids the risk of sinus sequestration and coronary occlusion. It's still a surgical procedure, so it's still invasive. It still requires cardiopulmonary bypass and cross-clamp. And it has a limited role in endocarditis and patient-prosthesis mismatch because we leave actually the frame of the THV intact. It requires a hybrid OR and a structurally trained surgeon who has experience in deploying transcatheter valves. And we haven't done many cases so far, so we have still a limited experience. And of course, there is no long-term data available. So I'll show you a case of degenerated TAVR. Actually, this was the first surplus case that we did in New York. So a patient that had alternative access core valve implantation 8 years before. And as you can see, the valve is now extremely stenotic with hypomobility of all leaflets. We can see that there is alignment of the commissures. So the left main is in the middle of the sinus and not behind the commissures. But if you look at the CT scan, you can realize how tight is the self-expandable valve in the aortic root and the proximal ascending aorta. Basically, there is almost no space. And if you look at the risk plane of 26 millimeters above the inflow portion of the valve, you can see that falls above the coronary ostia, both left and right. So if we ever think about a transcatheter option for valve-in-valve, this would cause for sure sinus sequestration and coronary occlusion. The area of the annulus was 342, so in line for a 23 SAPIEN-3 valve. You can see that the left main, again, it's low compared to the SDJ and the risk plane of the core valve, as well as the RCA. I think in this case, the VTC of both coronaries doesn't matter because the reason for occlusion for coronary hypoperfusion would be sinus sequestration. And again, this is another reconstruction that tells you, again, how tight are the spaces and how little room there is at the SDJ. So we came up with this model in which basically the concept is to implant the SAPIEN valve into the core valve. And doing this, we can also align the commissures and the inner skirts of the two THVs. And we did try this on the bench first, and then we went and do the first-in-man surplus. So as you can see from the video that I'm going to play now, sorry, it doesn't play quite well. But two main points have to be made about this surplus. The first one is alignment of the commissures that are marked on the aorta for valve-in-valve alignment, and also the depth of implantation by which we want to actually align the two inflows of the two valves. So the hypoattenuated line of the S3 is aligned with the lower edge of the core valve, taking into account the foreshortening of the balloon expandable valve. And you can see that the heart is still, so of course you don't need rapid pacing because we're clamped, the aorta is open, and everything is done under direct vision. So once you resect the leaflets of the valve, of the core valve, you're ready to implant the balloon expandable valve. And also, just to make sure that that you have appropriate anchoring in a position, you do a post-dilation balloon valvuloplasty. As you can see, once you come off bypass, the heart function looks fine. There is no PVL, and you can see flow in the left main. The gradients post-implantation were extremely low. With the patient that did actually pretty well and was discharged on post day 5. What about mitral valves? So we have the same options. The generated bioprosthesis, we can treat them with surgery, so redo mitral valve replacement or a valve-in-valve TAVR. One of the biggest limitations of the valve-in-valve TAVRs in the mitral position is LVOT obstruction. That depends on several factors, as you probably already discussed. The device protrusion into the LV, the flaring, the aortomitral angulation, and the septal bulge. These are all factors that have to be taken into consideration on the pre-op CT scan. So we almost did the same thing with the mitral valve, instituting this mitral surplus. So it's of course faster, shortens the cardiopulmonary bypass and cross-clamp time. The goal is to resect the anterior leaflet of the mitral valve under direct vision and leave the stent of the bioprosthetic valve intact. After resection of the leaflets, a balloon expandable valve can be implanted, and we utilize also balloon valve fracture to accommodate a bigger size valve and avoid the patient prosthesis mismatch. Again, it's a surgical procedure, requires cardiopulmonary bypass and cross-clamp time, and has no role as the aortic surplus in endocarditis and PVL cases. Requires, again, a hybrid OR and TAVR-trained surgeons. And this is another case of a 78-year-old male with a history of atrial fibrillation. Bottom line, she had a mitral valve replacement with an Edwards Perimount 25 millimeters almost 20 years before, and came back with degenerated valve and class 3 symptoms. So you can see here the valve is disease is degenerated. The leaflets are both hypomobile. There was a mean gradient of 18 across the valve, and the CT scan shows a inner diameter of 23 millimeters, 22, 23 millimeters. Risk of LVOT obstruction was pretty consistent because the neo-LVOT area was 165 millimeters square. And this is another reconstruction and vision of the bioprosthetic valve protruding with the strut into the LVOT. So options, redo MVR, lampoon, and laceration of the septal leaflet of the bioprosthetic valve, and then mitral valve-in-valve, septal ablation and mitral valve-in-valve, and surplus that we tried in this patient because we thought it was useful to do. It's done under general anesthesia. We did femoral cannulation for arterial and venous through a right thoracotomy. We decided not to clamp and to use fibrillatory arrest. And you can see here through the right thoracotomy, we opened the Sandergaard groove. You can see the bioprosthetic mitral valve, again with almost calcified and hypomobile leaflets. With a blade, we resect the leaflets, as you can see here, Metzenbaum scissors and the blade, and we actually resected all the leaflets, although probably it's not necessary. And as you can see, we had some issues even in removing the leaflets. You can see the LVOT and actually the papillary muscles and the LV, now it's wide open. And then we did actually balloon valve fracture using a 28 millimeter true balloon. And you can see, especially on the left screen, that once the pressure of the balloon reached the peak, you could actually hear the pop and also see on fluoroscopy the fracture of the bioprosthetic stent. They will appear in a second. And again, this is done under direct vision. See, you just saw the pop of the valve frame. Afterwards, we put a wire, 035 wire in the ventricle, again, under direct vision. We pull in we dock the C-arm, and then we insert the previously crimped 26 millimeter Edward SAPIEN 3 Ultra plus 2 cc's. And we slowly inflate it, again, under fluoroscopy. We had an issue here because we lost capture on the pacemaker wire, but we were able, through a very slow inflation, to achieve optimal positioning of the valve. So this can be done relatively easily. Again, after removal of the leaflets, you're ready to go with the implantation of the balloon expandable valve, and it takes literally 10 minutes to do the whole procedure, and then to wean the patient off cardiopulmonary bypass. So you can see the positioning and the inflation of the balloon expandable valve. We can move a little forward. And this is how the SAPIEN 3 looks like after implantation. And the rest of the operation is carried out in the usual way. I had a fluoroscopy image here that it doesn't play, but I can tell you that the patient did well. Actually, the mean gradient post-op was only 4 millimeters of mercury. There was no LVOT obstruction. And we actually tried to do we resected the leaflets, and we tried to do a lampoon on the side table, and it was extremely difficult to lacerate the leaflet because it was calcified. So this is something that needs to be taken into consideration when we think about other options for relieving LVOT obstruction, because sometimes this is not feasible. So in conclusion, Surplus is a hybrid technique that can be used in patients that require redo procedure and are surgical candidates. It's useful in aortic valve-in-valve cases with high risk of sequestration, and in mitral valve-in-valve cases when there is a small neo-LVOT area. Surplus loses its value in case of valve endocarditis, patient prosthesis mismatch, and severe PVL. And the transcatheter options for sure should be always considered first if anatomically feasible. And the long-term results of Surplus are yet to be known. And I thank you very much for this opportunity, and I'm ready to answer your questions.
Thank you, Dr. Pirelli. That's a very good presentation, and I think that's probably in the future, more and more cases need open surgery for this kind of situations. Actually, I have done the case for metallic valve. You know, when I cut the metallic part of the valve and I leave the annulus sewing ring, and I put a SAPIEN 3 valve, and in it, and that works very well. So the same thing can be used for, especially for the TAVI valves. I think it's a very good idea. And is there any comment from you in the question on the line, or other doctors? You have any comment?
Well, I certainly agree with Dr. Pirelli about one thing is most surgeons hasn't figured this out yet. You know, the Vinny Bapa paper that you referenced and the one Gilbert Tang and Sayed just put out, we were part of both of those. And the mean number of TAVR explants done per surgeon was one.
Exactly.
And so I think, you know, you're right. I have this argument with Joe Baveri all the time. Do you do an annular enlargement or a root replacement? I keep telling Joe that you can't teach everybody a root. And I think you're right. You may not be able to teach everybody how to do a TAVR explant. And if you have a big valve where you're going to put a big enough valve in there, I think it's really nice. I really enjoyed your mitral. I think that's a very elegant way to get through a difficult situation.
Thank you. I think not everybody is as good as you or Vinny Bapat or Bavaria. You need to see how many of these cases will face in not busy aortic centers. And I think, I'm being honest with you, the TAVR explant in the right hands is probably the right procedure to do, but it's not always in the right hands. Yeah. So this is something that it's easy enough. Almost everybody can do. It's reproducible, cuts down the time of surgery. It's probably less traumatic if we want to see that. And it can be an option. I'm not saying that it has to be, it's the gold standard for these kind of situations, but
very an option. The average surgeon out there in the U.S. is doing less than one aortic valve a month. They need a simple way to do this.
I appreciate it. Thank you.
Okay, thank you so much. It's well, because we don't have any time left at the end for the discussion, so we probably have to proceed to the next topic, and well, leave some imaginations and for further, you know, for the further imagination for this kind of situations. Okay, so yeah, the second.
Okay, next speaker is David Wood, doctor. I'm not sure is it recorded or is online live lecture.
Go.
Oh, it's online. So, you're online. Great.
Thank you so much.
Hi, David.
Opportunity to present at Taipei Valve Summit 2023. It's a real pleasure, and thank you so much to the organizing committee as well as the panel. I just finished a live case for TVT, and it ties into this topic: equitable access, increased referrals, and early recovery TAVR. And I'm presenting here from Vancouver, Canada. I was at TVT yesterday with Janar and John Webb and the whole crew, but we flew back last night to do a live case. So I'm going to go through that because it really hits on these three topics. So here we go. This case was done a few hours ago at Vancouver General Hospital in Vancouver as part of the Vancouver Structural Heart Program with both Vancouver Hospital and St. Paul's Hospital. You'll note there's something different here right from the implanting team. We just list implanting physician, and that is to stress the importance of the patient who consented to have both their name and their image part of this presentation, as well as all the other images in this presentation, as well as Ashley, Suzanne, Shilpa, Kirsten, Erin, Danielle, Leslie, and Jennifer, because really it's the people who are making this project work. My disclosures. So really, this is a very straightforward case. 76-year-old gentleman, NYHA2. He's got severe tricuspid aortic valve stenosis with no significant past medical history or comorbidities. He had multiple different jobs. He owns several different companies. He now enjoys biking. He enjoys tennis. And his STS calculated score, for what it's worth, is less than 1%. You can see the picture of Vancouver there because I really didn't have much else to fill this slide with. He's a pretty straightforward single system patient. The imaging, again, Phil Pibereau is on the panel for this scan, but you can see EF60, severe tricuspid aortic valve stenosis with a mean gradient of 42. Same thing with the angiogram, mild epicardial coronary artery disease, no indication for revascularization. We are running the complete TAVR study here in Vancouver with eventually over 120 sites and 4,000 patients, but here the patient had normal coronaries. And the CT scan, annular area of 560 millimeters squared, so a 29 millimeter sapien 3 with excellent iliofemoral access. So why are we presenting this case as on the main stage at TVT, and why am I sharing it with you at Taipei Valve? It's because of this. What's been going on in Vancouver? Kind of two key things, something we call equitable access, going after this undertreated, underdiagnosed part of the population that has significant valvular heart disease and requires therapy, as well as early recovery TAVR. So like most places around the world, there's constraints on the system. We don't have enough nursing. We don't have enough beds. So already the system is under stress. And there's barriers to that. But having said that, we want to put the patients first. And we know at least half, if not more, of patients who undergo a transthoracic echocardiogram are not referred to the structural heart team for a variety of reasons. So that's become a passion project for myself and Janar and the whole Vancouver team, working with Aaron and Leslie. We want to get to those patients. So the first thing we've been doing in Vancouver is we've put automatic echo prompts with automatic referral to the structural heart clinic. We have 27,000 outpatient echoes a year. So as of April 17th, 6 weeks ago, we went live. So anytime on an echo, someone clicked greater than moderate, moderate to severe AS or severe AS, greater than moderate, moderate to severe, severe MR, or severe TR, a prompt came up saying your patient meets criteria for referral to the structural heart clinic. If you'd like to make the referral, please send a clinic note as well as recent blood work. I'm very excited to share with you. I just shared this 2 hours ago to the audience in Phoenix. That generated 222 new potential patients in only 5 weeks. 222 in 5 weeks. 91 aortic stenosis and 81 mitral regurgitation. From that list already, we've got 48 additional referrals. We obviously are going to look at this in detail. Who are these patients? Would they have been referred through a different pathway? But the exciting part is we feel like we're finally getting to that rest of the iceberg, the untreated or undertreated population. Okay, so I've already told you that our system is under stress, like many systems around the world. What are we going to do to optimize the existing infrastructure? So that comes to our early recovery TAVR pilot study based on the early recovery after surgery or ERAS literature. So we've done a 25 patient pilot study where basically we've tried to simplify PCI or TAVR even more than what we did in the 3M TAVR study or in Benchmark, such that now it is like PCI. Patient comes in the morning, has a procedure, radial monitoring, mobilized with a radial monitoring for about an hour, mobilized 3 hours later, and going home about 4 hours after the procedure. And what I would say to the audience there at Taipei Valve is all of these patients, these pictures were taken about 4 hours after the valve went in. So as you can see in the upper left corner, I would argue it's very challenging to say who had their valve 4 hours ago. Was it the man or the woman? The group of 3 people, who had the valve 4 hours ago? You might be surprised it was the woman on the right with the black jacket. Or down at the bottom there, who had the valve 4 hours ago? The man in the sweater or the woman? And again, people are surprised it's the man in the sweater. So what is this program? It's based on the our work with Benchmark. We've now worked with hundreds of sites around the world. We just presented with Dirk Frank over 2,400 patients, showing a significant reduction in length of stay. We also worked with the Benchmark sites talking about very early discharge during the pandemic. We worked with 7 Benchmark sites. So this to us is the natural progression of that pathway. So the strategy we used a couple of hours ago, literally 2 hours ago, was early recovery TAVR. 29 millimeter valve through the right groin, radial monitoring. There's a nurse at the head of the bed that looks after The patient talks to the patient. We give vasopressors if we need to. Usually we don't. We give very little or no minimal procedural sedation. And the live case broadcast, which is now available at TVT, the patient was able to chat with us throughout the whole case. So here's some screenshots from Phoenix, Arizona, a couple of hours ago. We bring the patient in the room at the beginning. He chats with us about what are his goals of care, that he wants to get back to enjoying his life, riding his bike, swimming, playing tennis. We chat with the patient, introduce ourselves. He then goes on the table. The procedure, as you know now, only takes about 20 minutes. As you can see from that side shot there, our patient, who is wonderful, talked to us throughout the case. He actually said after we put the big sheath, has the big sheath gone in yet? He couldn't actually feel it go in. And at the end of the case, he said to us, wow, that was easier than going to the dentist. And you can see here, the broader Vancouver team came in for the discussion with the panel. We have Janar in the forefront, John Webb, Ashley, Aaron, Scott Lim, and the surgeon Richard Cook. And what I'm excited to tell you is, yes, we are going to create stress on the system by putting automatic echo prompts because it's the right thing to do for patients. We are going to look after or treat the untreated patients. We are going to double or triple our waiting list for aortic and mitral procedures. It's pretty obvious, 222 additional patients, more than 90 new aortic patients, more than 80 new mitral patients per month. That is going to put incredible stress on the system. But the exciting part is we now have a solution where we can do a TAVR case in the morning, be done within an hour. The patient goes home 4.5 hours after the procedure. Here's our patient at 2 hours. I just took this picture. And now that same room is doing 8 or 9 coronary cases. It could also do an ASD or a PFO or a left atrial appendage, but it's allowing us to use our existing infrastructure in a very thoughtful way. We are no way suggesting this is ready for all patients. We're suggesting that in carefully selected patients, like our patient here, excellent anatomy, very good candidate for a balloon expandable sapien valve, very low pacemaker rate in our hands, less than 2-3% pacemaker rate. This is safe and reproducible. We've done our 25 patient pilot. We're going to be looking for sites around the world to do a prospective registry with several hundred patients, both with the equitable access piece to see just what this does to everyone's global waiting list. So we're actually treating the untreated patients or undertreated patients. And then we'll be looking to include sites who would be interested in doing early recovery TAVR, because this is going to be an essential tool in the toolbox as we deal with increased capacity with limited infrastructure. So I'd like to thank Taipei Valve for having me speak today. I wish I could be there live with you, my tonight, your tomorrow morning, but unfortunately we're doing another live case in an hour here, but wanted to record this so you kind of know what our thoughts are on automatic referrals, which I think is key to getting to undertreated patients. Obviously, everyone needs to treat as per current guidelines. And then finally, early recovery TAVR, really TAVR becoming like a PCI procedure, but with safety supports. We can put a patient on FEM support or get an urgent echo within 5 minutes. But in this pilot study, the patients are going home 4 hours later safely with no readmission rate so far. So thank you so much for the opportunity to present, and I look forward to seeing you at upcoming meetings. Thank you so much.
Okay, the next topic will be presented by Dr. Ye Jin. Everybody know him so well. And his topic will be transcatheter in the surgical mitral valve interventions in patients with the severe MAC. Let me make a brief introduction to Dr. Ye Jin again. He's a clinical professor and the director of cardiac surgery research at the University of British Columbia. And he's also the director of the surgical mitral and the tricuspid valve program at St. Paul's Hospital and the Vancouver General Hospital. He is the pioneer. Everybody knows that he is a pioneer in the development and the clinical applications of transcatheter heart valve therapies. Please, Dr. Ye Jin.
Thank Dr. Wei for your introduction. So I will give a little bit talk on the transcatheter and the surgical mitral valve intervention for patient with a severe MAC. I'm talking about a severe MAC because it's a definition of MAC can be quite variable. So as you know, there's quite a few publications in terms of how to deal with a MAC patient. But when you talk to MAC, it's really difficult to make a comparison because your MAC can be a circular, almost circular or very little in the anterior, posterior, and sometimes a patient has a pneumatic valve with not annular calcification, but the leaflets calcification. That's also called the MAC. But honestly, for the leaflets calcification, is really not the issue for any surgery. You can be lots of calcium on the leaflets, like a pneumatic valve, as long as not in the mitral annulus. The approach actually is pretty simple in terms of surgery. So that's why if you compare the literature result, it's really not compatible because you don't know what's the background on the patient. So the incidence MAC supply is not really low. It's about 5 to 15%. That's a pretty high. And we saw that the MAC patient probably not common, but we particularly, probably 5 or 6 years ago, we don't really have too many patients with a severe MAC. I guess the most patient, probably cardiology, don't refer this kind of patient to the surgical assessment because they think there's no way you can do a surgery. But surprised over the past, probably 5, 6 years, actually I received more MAC patient. And at the one point, I told people, I don't want to be a MAC surgeon because that's not fun to operate and frequently. So. Generally speaking, the female is more than male, and the Caucasian is probably higher than the African, and the Asian region actually relatively low in this region. So the outcome with MAC related MV dysfunction, you can see the basically is depend on the amount of MAC. If your gradient high, and of course your survival is worse. So the MAC, if without any mitral valve dysfunction, you really don't need to do anything. But unless the stenosis or the regurgitation, and for the stenosis, actually quite difficult to assess by echo. Sometimes lots of measurement is actually in the MAC patient they are not really accurate. So sometimes it could be very difficult to make a decision whether there's severe stenosis or not severe stenosis. So just like here, so generally speaking, you look at the valve area. If less than 1.5 square centimeter, you consider have a severe stenosis, and the regurgitation greater than moderate, and if severe regurgitation is relatively easy to determine in the MAC situation, but in the gradient, like for the gradient, it sometimes can be really not accurate. So sometimes you have to look at the morphologically whether this is really true anastomosis or not, and sometimes 3D echo is very helpful to measure the valve area. So as you see the MAC here, you can from a U left to the right, as the MAC as an extension can be the degree can be quite variable. So we call the circumferential. A truly circumferential MAC is not very common because usually it's a posterior circumferential MAC, and then anterior probably like a middle part is probably more common. And then of course, the most common probably was a posterior annular calcification. So CTA is definitely a gold standard to assess MAC, particularly the location, how much amount, how planning, how to plan your surgery or interventions or whatever. So overall, the mitral valve intervention, you can see that several options. Of course, the surgery is a traditional option for the MAC patient, but now we have a hybrid approach, have a TAV with a mitral valve and also a transcatheter mitral valve, or you have a mitral valve implantation with aortic, we just seen, and also can tear. And so different, there's quite a few methods available to manage MAC patient, but no one is the simple or the easy to do. So the surgical repair, as you know, traditionally, you're basically trying to remove all the calcium, and of course, you dig into myocardium. Usually, you get to see the fat. That means you basically perforate all the LV wall or the annulus, and then you need a patch, either bone pericardial patch, and then you put a suture on. That's a classical way to do it, and so there's a two way to do. One is two type of basic approach. One is aggressive decalcification. Basically, you remove all the calcification and put a patch. Whatever size patch you needed, you can just patch it and then put the valve in. So that's one approach. The most approach you traditionally usually more aggressive decalcification and then put a patch, but the surgical risk is pretty high. So that's why not too many patients done, because it's risky for sure. Even you use a patch, it's still risky. And another approach, probably is a favor will be a limited decalcification, and then you're trying to place the valve as a biggest size as you can. And my approach is for the past several years, I don't do the aggressive decalcification. I usually do the limited decalcification. The goal of the decalcification for me is, I'm not sure this can be played or not. So as you see, this valve is extremely calcified. You push the one side, your whole this annulus moves. That's you can tell this is a severe MAC, and you see the area of the opening is really small. You can't really put even 25 or 20, even 23. You use the aortic valve, you probably won't be able to put it. So you definitely have to remove the calcification. And my approach is how much you remove. I always remove the depending on patient size and the mismatch situation. So I will determine what size I want to put in. So I determine this patient is like I need a 25 or 27 valve, and then I will decalcify it until I can put this size valve in. And the way how to decalcification, there's a different ways. So my approach, I don't resect everything. I will preserve some leaflets for my suturing, and then trying to decalcify everything. But I didn't, because of timing, I didn't put all the. So the final, you can see this I put a valve in. There's no issue there, and there's no valve leak. And of course, this kind of surgery is the main issue is what size you can put in, because usually orifice is very small. Second is a valve leak. That's you will see almost for this kind of MAC, you do the procedure, you expect a valve leak. But the important thing is you need how to check the valve leak before you come off the bypass, because otherwise you need to rest again, then do again. I usually, so do you trying to check that any valve leak before you come out of the bypass, and then if any necessary, I fix the valve leak. But there's a different way to fix the valve leaks. So far, all my patients done as an aortic MAC patient, there's no really single patient had more than the valve leak, and most is just trivial. So it has been pretty successful. And I probably will in a couple of years, I probably have my series about outcomes. But this is the literature reported. So mortality about 4.7%. So, in terms of this kind of challenging surgeries, the risk actually is not that high. If you think about it, most we are impressing this kind of surgery is extremely risky, and we don't really want to do surgery. But in the reality, if you have your own approach, how to put a suture in, how to decalcify, as the risk is actually pretty small. And honestly, I haven't had any patient that died within 30 days. So I think that's have been pretty good outcomes. And the aortic root groove rupture, that's one major complication everybody scared is ALV groove rupture. And if you don't do the aggressive decalcification, this risk is almost zero. There's no really risk for this kind of So survival, surprisingly, this is a published survival is a MAC and no MAC. Actually, if you do it surgically nicely, the survival is similar to the other non-MAC patient. So that's why these patients we should we shouldn't say we can't offer anything. We have to offer something because we can extend their life expectancy and the survival rate. It's critical. So, but of course, the really, some patients that you probably cannot put a surgical valve. Some patients I do is they are so small, there's no way. Like a really usually difficult patient is an elderly, 80 years old, and a small lady. That's the most challenging patient for the valve replacement. So in this kind of situation, I do use transcatheter valve. That's called a hybrid approach. So, but you know, I think this approach is very simple, easy to do, and I usually don't put a lot of suture. I put a few suture just for stabilization. And the way you want to put the prejudice suture is depend on the situation. Usually, you put it in a place you have no MAC at all. So you want to put some prejudice suture to stabilize it and also to prevent the leak. But in the calcified area, you really cannot have a perivalve leak, generally speaking, not really the situation. So, but the downside of this one, the surgical is easy. You can do a minimally invasive procedure. You can do a surgery quickly, but the downside for the young patient, this I usually offer for the elder patient or the life suppressing is very, very, not long. You don't expect it will be another surgery. The downside is if you do this one, the problem is in the future, the LVT obstruction, because these kind of patients, if you do, if we need a second operation, if you undo the valve, that's almost impossible to do valve unless you have a leaflets modification before you can put the valve in. So that's why I don't offer this kind of valve to the young patient that expect to have a redo surgery again. I don't use this valve. I always use surgical valve because you put a surgical valve, there's an option for the valve, majority. So that's a downside, major downside. TSA is really not too many patients that's really suitable for this MAC patient, if a severe MAC, because usually they have a stenosis. If you put a tear, it really can cause a significant gradient. So that's usually not the option, generally speaking. And in terms of transcatheter mitral valve implantation, right now the dedicated probably the valve probably is the only one is Tendyne. Tendyne is a valve you can put into the calcified MAC patient, and the outcome is pretty good as a transapical approach. Transapical approach not a major issue if you have experience. It's really a pretty simple procedure, and you anchoring. So this is the valve is pretty simple and relatively it's a good outcome, early outcome. But I'm not sure that when it's failed to do the valve, it's easy to do or not. I don't have experience. I think there's some report as feasible, but probably we'll see probably in a few years and how easy to do the valve. So, but the outcome you see that with this, but this probably is a patient selection issue. But this is a list of all the patients. There's a 60% that died within 1 year. So I think hopefully this is just as a patient selection issue. But in the real situation, if the patient died within 1 year and you do this kind of procedure, I'm not sure how much benefit is really given to the patient, and we probably have to think about. So we have to carefully select the patient, and particularly what's their potential survival after the procedure. And for the transcatheter, transeptal, transapical valve into the MAC that we already hear this morning, is really not a very good long-term or even mid-term outcomes. But I did a few patients, generally speaking, there's a lot of exclusion. Lots of patients actually is not suitable for this kind of procedure, and a few patients may be okay for the procedure, but the difficulty is the sizing is extremely difficult. If you ask the radiologist, our radiologist is so experienced for the mitral annulus measurement, and even I ask them, the basic answer is, what do you want? What number you want? I can give you whatever you want. So because of calcification, and then you can include this calcium or exclude the calcium, the numbers total difference. So this case is the same. And I reviewed with them and asked that what's the number you really can give it to me. And then they at the end they say, can give these numbers and I can give it to you. but I cannot give you really like what's the size. So the only ways I do is I saw the balloon sizing is fantastic. I use the balloon sizing because, and then this is because of transapical approach. So that's why advantage. I can inject the contrast directly through the sheets, and then you have a perfect LV gram and look at it in the leakage. So this is a 20, I think it's a 25 balloon, and I put it in, and then that's just contrast, and then no leak. That's I know this 26 valve will be perfect fit. So I put a 26 valve in, and the outcome is great. And you can see that it's very the implantation is not difficult because the valve will never be embolized. There's lots of calcification. Even you miss a position, but maybe have a pedal leak, but the valve won't move away. So after this, you can see the really good outcomes. There's no pelvic leak and probably trace and no LVT obstruction, and patient did very well and discharge day 4, and she was very, very happy. But this case is interesting. 2 years, 3 years later, and presented to the hospital with a heart failure, and they say have a severe recurrent, I didn't put it there, severe recurrent mitral regurgitation. So in the other hospital, they phoned me, and they say that you have recurrent pelvic leak. So I was very surprised with this kind of MAC, perfect the implantation 2 to 3 years later, severe leakage. And then I look at the echo, actually the valve migrated and fractured, the stent is fractured. This is the first actually reported H3 valve stent fracture. So the fractured and migrated towards atrium. So patient does this develop severe pelvic leak. Of course, I did another procedure, transapical again, put another sapien valve and excellent outcomes. So it's possible to have a good outcome, but you know, the long-term outcome probably not good. So that's why at our center, we don't do the many MACs anymore, transcatheter valve for the MAC anymore, and most time I operate on these patients. So this, as I don't want to go through details, you can see it's not really good outcome as general speaking. The technical success only 60 to 70%, and 30-day mortality up to the 62%. I don't think we want to do this kind of procedure and to do any procedure on this patient, because even you survive the first, only survived for 3 months or 6 months, I don't think we should offer this kind of procedure, honestly. So we really need to learn what patient that really can get a benefit from this kind of procedure. So in terms of comparison, I just put it quickly, this slide, so the comparison, which one is suitable, you know, for this kind of MAC. I think a surgical, I think is still the best probably in terms exclusion rate is very, very small. Very few patients cannot do it. The success rate is pretty high, and I think a long-term is great. But in terms of hybrid and TMVI or TMVI with transcatheter valve, I think it is a disadvantages, and the overload outcome is still very suboptimal. So that's my approach, our general approach to the immaculate mitral valve dysfunction. I just say is a surgical candidate or not. If not surgical candidate, of course, we assess to the suitability for any transcatheter mitral valve. If no, I think a medical and palliative treatment. And if yes, we do the either transapical or transeptal approach for the mitral valve. If the high risk, the surgical, we need to determine is a very high risk or not high risk. If it's a high risk, and then we can do that, and whether TAV is suitable. And if yes, we go to the transcatheter. If not suitable, and then we could do a hybrid, like a hybrid procedure. And if no, not high risk, of course, I think these kind of patients should be operated by the MAC surgeon. We call the MAC surgeon, but I think at least with experience with MAC. So at our centers, most surgeons, they don't do procedure. They just refer it back to me. So I think I just do a little more these kind of cases. So I think we should have some people has experience to perform this kind of procedure, because the patient can die on the table. And if the patient that we need to look at the other center, whether it's a MAC surgery or not. I think it's very critical for the patient care, we also should look into the other center whether there's a suitable surgeon to perform the surgery. So that's kind of a general approach I do. And so this is my last slide. So I think a surgical intervention still remains a gold standard and for MAC patient, but these surgery should be performed by the experienced surgeon, particularly in the MAC for the MAC disease. And I think a hybrid procedure or transcatheter procedure is a good technique, but because currently the outcome is really suboptimal, we really need to think about which patient is really benefit from this kind of procedure. I don't think we should offer this procedure to any like a MAC patient is all, they are not really survive for a few months. I don't think we should offer for this kind of procedure. Thanks.
Thank you. Thank you, Dr. Jian-Ye, for your excellent lecture. I think there's not much time for discussion, so I have to proceed to the next big topic since we are a little bit behind. Okay, so the next topic will be moderated by Dr. Ye Jian. Okay, Michael read it. Yeah. Okay.
Hello, Dr. Wilden. I think everybody know him, so we already introduced several times. I think he's a world-renowned surgeon and also structural valve interventionist. So he's a professor and chief of cardiothoracic surgery and director of thoracic resident program at the Houston Methodist Hospital. And he's basically, I can probably spend hours to introduce everything, but from interest of time, I think I will let Dr. Wilden to give us talk. The first talk is a TAV failure, TAV-in-TAV or TAV explant, and the second talk will be April pivotal trial status.
Great. Can you see my slides?
Yes, we can see.
Great. Well, I really enjoyed James' talk, and I'm glad to know he's a MAC surgeon. I know where to send all my MAC cases to now, James. So I'll get your number and we'll send them up to Vancouver.
Thank you.
That's always tough cases. So we're going to talk about TAVR failure. These are my conflicts of interest. I'm conflicted pretty much across the TAVR field, but I'm also a cardiac surgeon, and I still like doing a lot of cardiac surgery. Now, all bioprosthetic valves will fail given time if they live long enough. So the real question is when to use a bioprosthetic valve and what to do when they fail. And the top for today are what to do if they fail. So what are the options for failure? Well, the options for failure are surgery, redo surgery versus TAVR-in surgery if you had a previous surgical valve, or if you have a TAVR valve, which is what we're talking about today, it's going to be TAVR-in-TAVR versus TAVR explant and surgery. So there's been a lot of global adoption of TAVR, and there's now more TAVRs done in the United States than there are total surgical aortic valve procedures. Most of these are native valves with a tri-leaflet, about 6.8% are bicuspid. And valve-in-valve, degenerative surgical valves is about 5.6%, and degenerative TAVR valves is less than 1%. As we treat younger and lower risk patients, we'll expect this number of degenerative TAVR prostheses to rise. And this is, of course, most of you have seen this slide over and over again. The blue line is all aortic valve procedures in the US. The orange line is TAVR procedures. And what we see is isolated TAVR and all procedures have gone below the TAVR line. This is never going to change. It's going to keep going further up. Now, for degenerative transcatheter valves, for TAVR-in-TAVR, it's now about 0.15% in the TVT registry, very small number. But if we look forward, what we see is that it's starting to go up. So the red bar is TAVR-in surgery, and the blue bar is TAVR-in-TAVR. And we're going to really see that kind of going up over time. We need to be prepared. Now, if they fail, we have really two options. One is to surgically explant this valve, or you saw the surplus earlier. That's certainly another option for that, but a surgical approach, or TAVR-in-TAVR. TAVR explant and surgery, there's been a number of papers written. We contributed to these papers, but both of these papers looked at overall TAVR failures, and about half of these were related to endocarditis. And of course, endocarditis really isn't a good substrate for TAVR-in-TAV. So Gilbert Tang and Sayed Zayed, who's currently my cardiology fellow at our group, looked at this, and what we did was we then eliminated everybody with endocarditis, so that we're now looking at just people that have a redo TAVR versus a TAVR explant for non-endocarditis problems. And what you can see is that the redo TAVR and the TAVR explants are really growing over time, and they're growing at a pretty much an even rate right now, with TAVR explants gaining in time. Now, they're about even between the two valve sizes, but if you go to the far right, that's the real money shot. The in-hospital and 30-day mortality is much higher in TAVR explant, as is the one-year mortality. So the hazard risk of even TAVR explant now is about 2 to 3 times just an AVR from an STS estimate. Now, we'll point out that when we looked at the mean number of TAVR explants done by surgeons that contributed to this, it's 1. There was a bunch of surgeons that did 1 and a few surgeons that did a fair number. And I think, like all surgical procedures, this is something surgeons just need to learn how to do. Now, if we landmark that, at 1 month, what we see is that once you get past the original risk of the explant, they tend to do very well. Now, I think one of the things that we need to bear in mind when we do this is we need to be able to put in a big enough valve. About 40% of the time that I do a TAVR explant, I put in a bigger valve, because a large majority of these are done because I had patient prosthetic mismatch to begin with. I use the technique that Bo Yang has described, and it allows us to get in a much bigger valve. I do mine a little bit differently than Bo. I don't use a rectangular piece of Dacron. I actually use a piece of 30-millimeter graft. I think the curve fits the aorta very nicely. I've now done myself, when I put this together, I've done 3 more since then. I've got 1 more Monday, 36 TAVR explants with surgical valves. I had 3 deaths. Every single one of those deaths were people that had been deemed non-surgical candidates, got a TAVR. And of course, when that TAVR failed, all of a sudden they became surgical candidates again, because there was no other option for them. I've done 3 root replacements, and every one of those root replacements were people that needed the root replaced for other reasons, never because of an injury to the anterior mitral leaflet, and the aorta has never been a problem. And the real key is learning how to take these and always moving to the center and not pulling them. And in fact, when I do the self-expanding valve, I cut off a 3-inch segment of the aortic tubing. I put some number 2 silk to the end of the valve, and I pull the valve up in the aortic tubing. I basically recapsulize the valve as I'm removing it, so it no longer is hanging out in your way. It makes it very simple. TAVR-in-TAV, it's really an emerging conundrum. There's very few facts and a lot of uncertainties about this. There's a lot of papers that have been written about this, about how to do it and what the results are. The problem is these are small numbers and, in general, retrospective studies. This is Landis' study looking at total TAVR procedures that then go down to TAVR and TAVR population, which goes from 64,000 to 434. If you take out the bailout procedures where people have failed with the initial TAVR, that's 223. That left only 212 that were real TAVR valve failures. 74 of those were less than a year, and 138 were more than a year. So you can see this is a very small number currently that we're dealing with. But there are some important things to really notice here. If you look at the aortic valve area, it's really pretty small. It only gets up to about 1.6 if you do a TAVR and TAVR. And the other problem is that the mean gradients, particularly for some of the smaller valves, tend to be fairly high, and even over 20. And Doug Johnson showed us a long time ago from the Cleveland Clinic that in surgical valves, if you came out with a higher initial gradient, particularly above 20, the risk of early structural valve deterioration went up exponentially. So what we're going to see is a number of these TAVRs and TAVRs that we're doing that are coming out with fairly high gradients, and TAVR and surgeries with fairly high gradients are going to have early failures, and they're just going to be back on your door in about 3 years looking for another procedure. And it's important to look back at Gorland's original work. When Gorland was working out flow across fixed orifice for the Gorland formula, what Gorland did was look at aortic flow on the vertical axis, mean grade on the horizontal axis. It fixed openings, which are these blue lines. The red lines represent fixed cardiac work, which is, and this is how the heart works at the lower flows, but it's just to show you what happens if you don't increase your heart work. Now, normal flow across the aortic valve is about 220 cc's a second. High flow is about 550 cc's a second. So if you choose the line that says 1, as an opening of 1 square centimeter, you see at rest, your mean gradient's about 40. If you go up to high flow, it goes up to 130. That, of course, is why people die with aortic stenosis. And you also notice that the difference between 0.2, 0.4, 0.6, 0.8, it's not an even change because it has to do with the square of the radius. And in fact, until you get to an EOA of about 2, you really can't increase your flow without increasing your gradient. And the problem with valve-in-valve, whether it's TAVR-in-TAV or TAVR in surgery, is you can rarely get up to an EOA of 2. And certainly if we start having younger people that fail that still want to be fairly active, we're going to have to think about what we're going to do. Again, this is Landis' work showing that the amount of patients with aortic regurgitation is really higher than we'd expect, with about 5% of these being moderate, which is really not something we expect in our native TAVRs anymore. Now, for failed TAVR with a TAVR-in-TAVR, it's a very small percentage of patients, about 0.22. The mean gradients were about 13, and the mortality was really low. It's about 1.4%, and coronary obstruction was less than 1%. I will point out that these are very highly selected cases. These operators were experienced operators. They went through this, and they selected out the ones that might have coronary obstruction. When I'm sent a TAVR valve that they want me to consider TAVR-in-TAVR, the 2 most common reasons for me to turn them down and go to surgery is the risk of coronary obstruction and pre-existing patient prosthetic mismatch, which leads you on to surgery. And again, what Landis did this when they went to look at TAV-in-TAV versus TAV-in-SAV, they found that the overall risk was just about the same, but there were some differences in the paravalvular leak. There's some difference in pacemaker. But again, the mortality difference was relatively small. And there's a lot of difference between the safety and feasibility of doing a redo TAVR. You've heard several talks about that already. I'm not going to go through this. I think we're running a little bit behind already. But a lot of it has to do with the anatomy of the coronaries, the anatomy of the sinuses, the anatomy of the STJ, how likely you are to get coronary obstruction, and how likely you are to leave somebody with significant patient prosthetic mismatch. I'm not going to go over this. Janar talked to you about this. Janar is doing a lot of great bench work on how you do a TAVR-in-TAVR. Typically, we put a self-expanding valve and a balloon expandable valve and a balloon expandable valve and a failed self-expanding valve. And exactly where you put these, again, is something that Janar is helping us work out on the bench, not in a guessing clinical way, but in a real scientific way of what this is going to mean based on overhang and based on flows. So there are a lot of limitations of the present data. It's retrospective and it's small. It's not clinically adjudicated. There's really no CT or echo core lab. They're just individual places doing it. It's not really always specific to transcatheter valve degeneration. There's incomplete echo follow-up. There's no CT imaging follow-up. And there's old definitions not really using VARC-3 definitions. So TAV-in-TAV, what we don't know. Well, we really don't know, how you go from TAV-1 to TAV-2. Does a balloon expandable go to another balloon or a non-balloon? Does non-balloon go to a balloon or non-balloon? As I said, my typical thing is to put a self-expanding into a failed balloon and a balloon to a failed self-expanding, but that's just my gestalt as to what to do. Right now, we really lack clinical data. And I think people are really helping us start to put that together. This study actually was done by Syed Zaid, who's my current fellow. He's graduating this year, taking a job at the Houston VA. He presented this at TVT 2022, presented a similar study just 2 days ago at TVT. So for TAV-in-TAV valve sizing, do we size according to the original CT? Do you use new CT for new prosthesis, original valve prosthesis, or all the above? We don't know. There's really no data. But again, I think people like Janar are helping us look at this in a scientific way. Risk of coronary occlusion, again, I'm not going to go over this. I think Janar and others have already talked a lot about this. The risk is very low in the TVT, but that's because these are very carefully selected people. And I would say at least half the people sent to me for TAV-in-TAV get screened out and end up getting surgery because we don't think they're safe to do. Again, Janar has already given you this to help catch us up on time. I'm not going to go over it. But the bottom line of this is there's a fair number of people, even with shorter balloon expandables, that are going to have a risk of coronary occlusion. And then there's other questions about how you're going to do this. Do you pre-post dilate or do you post dilate? I mean, we post dilate. We don't pre-dilate. What's your implant height? Leaflet modification strategies. All these need to be worked out. And again, Janar has been doing a lot of bench work helping us design this. He's already talked about this. I'm not going to go over this again. So when we look at this, we look at the mechanism of TAVR failure. We look at the valve sizing, leaflet modifications, commissural alignment as part of the technical details. We look at the mortality, valve embolization, and coronary obstruction and residual gradients as some of the procedural risk. Valve durability, thrombosis, and coronary access, that's still all knowledge gaps that need to be worked out. Patient prosthetics mismatch, paravalvular leak, and valvular regurgitation or stenosis are things that we need to consider as we approach deciding, are we going to do a TAVR-in-TAV or a TAVR explant and a surgical valve? So in conclusion, failed TAVR valves are going to be an increasing issue for both cardiologists and surgeons. TAVR-in-TAV is safe in appropriate patients. You have to consider coronary risk and patient prosthetic mismatch. TAVR explant and then surgery currently has an increased risk, but I think it's a new procedure that surgeons need to learn, and surgeons need to then place an adequate valve size. So currently my surgical fellows do these cases. Will be helping them because I want to see the next generation of surgeons come out being versed in this, just the way that current surgeons are very versed in doing redo aortic valve surgery. And in conclusion, the first valve needs to be the appropriate valve. Unfortunately, I often see both TAVR valves and surgical valves that are really inappropriately chosen as the first valve. And know the randomized trial data and what population was not tested as you make your decision for the first valve. So thank you. I'm going to stop there and happy to answer questions or move on to the next talk, whichever works out best.
Thank you. I will say move on to the next topic, and then we have some time for question. Is that okay?
I will do that and try to do my best to catch us up on time. So the Apollo pivotal trial status, my conflict of interest in this is I do work as a consultant to Medtronic. I am on the executive committee of the Apollo trial. I am the surgical PI of the Apollo MAC trial, and I co-chair the screening committee. So I'm fairly deeply involved in the trial. So there's a great potential for transcatheter mitral valve replacement. It's less invasive than surgery. It'll enable us to treat more patients with fewer complications and shorter recovery. The predictable and durable elimination of mitral regurgitation across a wide range of anatomy and pathologies. TEER is great, but it doesn't eliminate mitral regurgitation most of the time. And it certainly needs to be mild or less and preferably none. We know that as surgeons. And it really is a straightforward procedure for transcatheter operators as technical challenges are overcome. Now, the Intrepid valve is a circular inner valve that's 27 with a circular outer frame. So it's agnostic to how you put it in. It does not have to be lined up for the commissures. The conformal outer stent anchors without leaflet capture. The symmetrical design allows rotational alignment. Transfemoral delivery without the need for guide wire into the LVOT. Since we've moved from transapical to transfemoral, we've had a 276% increase in the number of cases that are then presented and treated. Right now, we have 42 and 48 valves, and a 54-millimeter valve is in development. When we started the Intrepid program, which was in 2014 with the pilot study that I was part of, it was in the first generation of this. We did phase 1 as just an EFS. We then moved into phase 2 as a single arm, originally randomized against surgery. Then we moved into an EFS of transfemoral and into an Apollo single arm trial. And eventually we'll move into a trial that is randomized against TEER. Phase 1 learnings was really understanding the TMVR treatment with the Intrepid valve. We actually enrolled 95 patients. There were 46 total deaths. There were 43 patients with 3-year follow-up, and patients with paired echoes at 3 years were 42. This was a prospective global multi-center non-randomized study, really looking at the feasibility of doing this. The mean age was almost 75. The mean age in the TMVR trials has been typically lower than the aortic valve trials, but these tend to be sicker patients. 60% were men. Almost everybody was functional class 3 or 4, 90%. The STS was 4.8, the ERA score was 5.1. A lot of comorbidities in these patients and a lot of previous surgery. If you look at the etiology, starting off, it was 2/3 secondary and 1/3 primary, basically. And one of the things that we did see about this is that this totally eliminated transvalvular regurgitation and paravalvular regurgitation. We had 2% moderate at the 3-year and none at 1 month. And if we look at the mean gradient coming out at 1 month was 4.2. It actually went down to 3.5 over time. And the LVOT peak gradient was 8.7 and dropped to 8.3 over time. As we moved to phase 2, we wanted further understanding of the treatable patients. It became a single-arm trial, and we were initially randomizing against open surgery. But again, surgeons were reluctant to randomize against open surgery, number one. And number two, COAP came out. And when COAP came out, it totally changed kind of the landscape of what we were going to do. And MitraClip was now approved for FMR patients, for functional mitral regurgitation patients. So we really needed to further understand the patients that were suitable for this technology. So the Apollo trial design was changed. You get assessed by a multidisciplinary heart team. You get approved. If you have severe mitral regurgitation, you can go into the primary cohort. We're going to treat up to 550 patients. Everybody had up to 2 roll-ins if you haven't done this before. And the primary endpoint was all-cause mortality or heart failure hospitalizations at 30 days, or a KCCQ improvement of less than 10 points at 1 year as a performance goal. We also have a MAC arm where we're going to enroll up to 300 patients with a primary endpoint of all-cause mortality or heart failure hospitalization at 1 year as a performance goal. Now, Dr. Yi just talked to us a lot about MAC. You know, MAC is not a single entity, and MAC is not just an anatomic problem for the interventionist and the surgeon, but MAC is also, to me, a systemic inflammatory disease. So MAC is something that we still are really working hard to define. And when we put people into our MAC cohort, we use a MAC score, a calcium score of 750 or above, as getting you in as a potential MAC patient. But it's really, Scott Lim and I run the screening for this. It's really looking at this and saying, do we think this would be a difficult surgical case? Is there enough MAC to say it's a difficult surgical case? So patients with moderate to severe or severe MR with presence of MAC, or patients with moderate MR and mitral stenosis in the presence of MAC, were something that we are going to accept in. Again, there were roll-ins, and again, the primary endpoint, as we said, was all-cause mortality or heart failure hospitalization at 1 year. And as we moved on, we're thinking now about who is and is not suitable for TEER. For everybody that comes into this trial, we ask ourselves, are they suitable for TEER? If they're in this kind of straightforward green zone where TEER is very feasible and likely to get to less than mild, then we don't let them into the TMVR. If they're in the prohibitively complex, then that gets you into the single arm trial. Where this transition from green to orange to red is going to be seen, but eventually we're going to have randomized trials that will go from the green up to the orange and randomize against TMVR. But to randomize against TMVR, I think you really need a transfemoral approach. I know Summit is currently randomizing transapical against TEER. I think that's going to be tough to win, certainly on safety. We also we also have defined the unsuitability for TEER. We look for anatomic things that are associated with stenosis after TEER, calcified leaflets, multiple regurgitant jets, anatomies that are associated with inadequate reduction, such as extreme valve complexity, cleft leaflets, short posterior leaflets, unlikely to be crass, tethered leaflets, long coaptation gaps, and really other anatomic limitations that may preclude TEER, such as the inability to obtain good grasping views on TEE. And so now we're going into the transfemoral phase of this. We now use this transfemoral device. The delivery system looks very much like a TEER delivery system. This is not an over-the-wire. You use over-the-wire to get the sheath in, but this is just a hydraulically driven piston that drives from the atrium into the ventricle. What we do is we get this valve actually aligned with the valve. We deploy the brim, and then there's a knob that just drives this thing forward under rapid pacing, and then it's released. It's actually a fairly simple thing to do. The biggest issue right now is that the catheter size is 35 French, so that's fairly big. Initially, we required you to cut down on the vein. We've now changed the protocol to allow percutaneous venous access. Now, this was presented by Faraz Zar, looking at our first 30 cases, first 15 cases at 30 days. And we had 0 mortality, 0 stroke, no reinterventions, and 7 bleeding events, and 1 hospitalization that was related to a minor vascular complication. We also had no mitral regurgitation at 30 days. And of the 90% that were functional class 3 and 4, Now basically 90% are functional class 1 and 2 at 30 days. This was a marked change from the transapical. When Tendyne first came out and the Summit trial was started, I was offered the opportunity to be the surgical PI on that, along with sorry, blanking on the name of the cardiologist, doesn't work, Paul Saraja. And we both turned it down because we didn't see a good transition from transapical to transfemoral and Tendyne. And I think we all know that's where the field's eventually going to end up. Now, Intrepid's going a little slower than I like, but we're there. And as I said, we've now increased enrollment 276% since we got that. We now have over 400 Intrepid valves implanted, over 100 transfemoral cases. Slides are actually old. We're approaching 200 transfemoral cases. And we have 5-year follow-up on some of the earliest cases. We've now expanded this to include Canada and a MAC study. Scott Lim and I are the PIs of the MAC arm. And we've extended this to Europe, and Tommy Modine and Stephen Vander Bartelsen are the co-PIs over there. Tommy Modine and Lille has already done the first Intrepid case over in Europe. So this is now becoming a global study. The transfemoral device, the next iterations are going to be a 54 valve, and we're going to go from a 35 French transfemoral system to a 29 French transfemoral system. And I think getting to 29 French is really going to be the step forward that we really need to accelerate this valve. So in summary, the Intrepid program continues to advance to better understand the device technology and patient populations and delivery systems. There's now a dedicated global infrastructure that has cultivated operators, investigators, clinical sites, engineers, clinical research staff, imaging specialists to execute this. And the primary focus is enrolling in the Apollo and the Apollo EU studies to treat high-risk patients unsuitable for surgery or TEER. And further investigation really needs to determine if this is a broad application in mitral valve disease. And I think the main determinant of that is going to find solutions to LVOT obstruction, since we still have over 50% of the patients that we submit get turned down for either valve size or LVOT. Valve size will be fixed with the 54 valve. LVOT is still an interesting engineering problem that we're working on. So thank you. I'll stop there, and hopefully that's caught us up a little bit.
Great. Thank you very much for the excellent talk, and I learned a lot. So I think we still have a few minutes to have a question. You think?
Thank you very much, Professor Rodron, for your fantastic lecture. And I'm very much impressed with the Intrepid transfemoral system. And what do you think is the most challenging part of the transfemoral approach compared to the transapical approach in terms of the putting the Intrepid device?
Well, I think the getting up the vein can be a little challenging. Getting to the apex heart is generally fairly easy as long as it doesn't bleed, but it's still not a good thing if you can avoid it. And I'd say the other thing that's interesting is if you don't get enough height and you get axial and you deploy the brim, you can almost be in position right away and it'll block flow. And so you have to be ready to deploy right away. So when we get ready to deploy, unlike with the transapical, you can deploy the brim and shove it way in the atrium and look at it and talk about it and go smoke a cigarette and come back. But with this one, when you deploy the brim, you need to be ready to deploy the valve. So when we deploy the brim, we have everybody ready saying, okay, if we're really close and it starts to obstruct flow, we're going to go ahead and advance and deploy the valve. So I think that is one of the nuances of this. But I will tell you, having done a lot of transapical and now a lot of transfemorals all went to the ICU. These go to the recovery room and go to the floor. Transapical stayed in the hospital 4 or 5 days. These are ready to go home the next day. We usually don't send them home the next day because they're trial patients. They're sitting up asking when they can go home. Physiologically, it's a huge difference for patients.
Thank you very much, Dr. Rodron. So actually, we were the part of the Apollo trial before COVID, but unfortunately, it was terminated in our countries, and hopefully in the near future, we are very much motivated to be the part of the Apollo trial. Thank you so much for your fantastic lecture.
Call me and we'll work on this for you.
Okay, thank you. The next topic will be the TAVI, the new and emerging indications that will be presented by Dr. Bernard Prendergast. He is the consultant cardiologist and the director of the cardiac structural intervention program at the Guy's and the St. Thomas Trust. He's also the honorary secretary of the British Cardiovascular and Cardiovascular Intervention Society and chairman of the European Society of Cardiology Working Group on vascular heart disease. He's a well-known national and international key opinion leader. So Dr. Prendergast, please.
Thank you very much for asking me to join you for this important meeting in Taiwan. It's a great sadness that I cannot be with you personally, but it's a great privilege to join you by virtual link with this recorded lecture. My name's Bernard Prendergast. I'm a cardiologist based in London, and I'm speaking to you today from the Cleveland Clinic in London, a brand new large high acuity hospital which is addressing all aspects of cardiovascular medicine. And today I want to speak to you about the new frontiers in TAVI and the new and emerging indications for the use of this fantastic technology in larger groups of patients. The journey in the last 20 years since the first TAVI procedure in a human has been breathtaking, exhilarating, and exciting. And over that period, TAVI has emerged as an extremely patient-friendly contender with the previous gold standard of surgical aortic valve replacement, such that in most developed countries, certainly in the West and including the USA, the number of TAVI procedures far exceeds those of surgical aortic valve replacement. This has come about firstly as a result of an accumulation of robust evidence, and secondly as a result of demand from patients who see the obvious attractions of a minimally invasive procedure in comparison with open heart surgery. This evidence has led the international guideline communities in the USA, in Europe, in Germany, in Japan, and elsewhere to understand that TAVI is now an evidence-based treatment that is applicable to patients in advanced ages, defined as greater than 65 or 75 in different parts of the world, and a procedure which is growing and accumulating as a result of this large evidence base. Such that in 2023, we have a procedure which is now associated with a very low risk of inpatient mortality, 1% or possibly less, a very low risk of important complications as our experience with the procedure has grown, and a procedure which can be performed in 1 hour or less in the majority of patients using local anesthesia and conscious sedation. A procedure that allows the patient to come in and be discharged within 48 hours in the majority of cases, such that the demand for the procedure is now our greatest concern and our greatest strain, with waiting lists in the UK now growing very rapidly, and the challenge facing us of potential deaths on the waiting list as a result of our inability to cope with growing demands. And looking to the future, it seems very likely that that demand is going to increase considerably. And even though, as this slide says, predicting the future is very difficult, it seems certain that the early success of TAVI in its first few decades of application is going to extend into the future. And that is as a result, so then as a consequence of the fact that the current indications are going to be superseded by expanding indications, not only in younger and low-risk patients, as we have discussed frequently, but also by addressing new patient subsets, as I shall describe. The important point is that we now need to turn our focus away from the procedure itself. We have a procedure which is simple, straightforward, and streamlined, and associated with very, very reliable patient outcomes in every centre across the land. Therefore, we now need to extend our consideration, we need to extend our thinking to access to the procedure at earlier stages of the natural history of aortic valve disease. And we also need to focus on aspects following the procedure in relation to ensuring the durability of TAVI devices, to ensure that we are offering patients the appropriate adjunctive pharmacology, and that we are also thinking about the second or even the third procedures at the time of the index TAVR implantation procedure. Because we need to recognize that aortic stenosis in particular, it is a disease not only of the valve, but also of the myocardium. An insidious progression of the disease in the absence of symptoms, particularly in elderly patients, is associated with insidious impact on left ventricular myocardial function. If we therefore have a procedure which is minimally invasive and safe, we should start to think about offering intervention at earlier stages in the natural history. The first group of these patients, of course, is those who are free of symptoms. Historically, guidelines have recommended a watchful waiting approach in such patients, delaying and deferring intervention, usually by means of surgery, until the point of symptom arrival, when left ventricular dysfunction is already established in many, many patients. These two randomized control trials, largely evaluating the role of surgery in asymptomatic patients, generated positive results supporting an early interventional strategy, albeit in relatively small patient numbers. Nevertheless, achieving publication in the New England Journal of Medicine and Circulation, indicating the importance and the clinical relevance of this preemptive approach. And we're now beginning to gather data, which is looking at the role of TAVI in a precisely similar way. There are a number of trials ongoing. The first I would like to highlight is here, the EVOLVED trial from the UK, a precision medicine randomized control trial evaluating pre-procedural propensity by means of ECG screening, measurement of troponin assays, and use of cardiac magnetic resonance scanning to determine the presence or absence of very early left ventricular impairment, and randomizing these patients to an early interventional strategy by means of surgery or TAVI in comparison with so-called standard of care, in other words, conservative watchful waiting. This trial has completed enrollment and analysis is ongoing pending publication and presentation within the next 12 months. Similarly, the early TAVR trial from the USA, a much larger industry-sponsored trial looking at the role of TAVI in asymptomatic patients, has completed enrollment and is on a similar timeframe for publication and presentation. There is an ongoing study in Denmark looking at all comers, a large number of patients approaching 2,000 sample size, looking again at the role of surgical aortic valve replacement or TAVI versus expectant conservative management. And finally, the pragmatically designed Easy As study, coordinated again from the UK in Leicester, which is enrolling patients not only in the UK, but from international enrolling sites, and examining this important question in a similar randomized fashion. Similarly, we need to understand that moderate aortic stenosis is not as benign as we have felt in the past and associated with adverse prognosis. These data from the large Australian National Echocardiographic Database demonstrated for the first time the adverse outcomes associated with moderate aortic stenosis, generating data that indicate an equivalent mortality, which is very close to that associated with severe aortic stenosis, and suggesting that preemptive intervention in this cohort is also worthy of assessment and discussion. This concept is being evaluated in a series of randomized controlled trials, which are summarized on this slide, and they will use not only conventional clinical endpoints, but also incorporate novel endpoints addressing left ventricular myocardial function in both systole and diastole, using novel echocardiographic parameters as well as biomarkers. Finally, we have the enticing prospect of TAVI for aortic regurgitation, an indication which has been examined in observational studies, as illustrated on this slide, from multiple centers, from multiple countries over the past few years. recognizing, however, that current TAVI devices are not suitable for many patients with pure aortic regurgitation as a consequence of the lack of calcium in the annulus of the aortic valve, and also the association of bicuspid aortopathy in many of these patients, resulting in valve embolism and instability using conventional accepted devices. The stage is set, therefore, for dedicated transcatheter heart valve systems designed specifically for the anatomical challenges associated with aortic regurgitation. You see here the Yeno-valve trilogy system designed in Europe and currently enrolling patients in ongoing studies, which I will cover briefly, with a very novel alignment and anchoring system using anchoring to the native valve leaflets to ensure valve stability and accuracy of deployment. And data from the first experience has been presented recently at EuroPCR, demonstrating very promising and very positive outcomes in the first cohorts receiving this particular device. Similarly, from China, we have the J-valve transfemoral system dedicated to the treatment of patients with pure aortic regurgitation. And this is similarly generating very promising data in early cohort studies. So taking account of our existing knowledge and looking into the future, we can conclude that TAVI is a safe and effective treatment that is applicable across the spectrum of surgical risk, as evidenced by the randomized controlled trials. As I have emphasized, we now need to move our attention beyond the procedure itself. The procedure is safe and established, and we need to consider upstream and downstream questions which extend beyond the interventional procedure in isolation. As I have outlined, we have ongoing trials in asymptomatic patients and those with moderate aortic stenosis, and these will define the further expansion of indications within the next 5 years. We also have promising devices emerging for application in pure aortic regurgitation. And meanwhile, our main focus and our main attention needs to be on ensuring the delivery of TAVI to the vast number of patients now coming forward to avoid deaths on the waiting list. And the only way we can achieve that is by using our capital lab resources more effectively and more efficiently, and ensuring the adequate and complete training of the next generation of interventional cardiologists. Thank you very much for listening.
So, okay, so probably we don't have a discussion. Is there any questions or comment? Because this is a recorded video, so we have to proceed to the next one. Okay.
Okay, thank you very much, Professor Wei. And I'm Kentaro Hayashido, and thank you very much for inviting me to this great meeting. I'm quite happy to come back to this really great meeting to see you guys, our friends, in person. And I would like to introduce the next speaker, Dr. Hasan Jilaihawi, and he's going to talk about TAVR for the stenosis patient. Is it the right time? And this is a recorded lecture, so please.
Hello, my name is Hasan Jilaihawi, and it's my pleasure to speak to you today. Sincere thanks to Professor Yin and all the organizers for this kind invitation to the Taipei Valve Summit. So my title is TAVR for all stenosis patients. Is it the right time? These are my disclosures. So TAVR today has excellent outcomes. And this is a progress in both imaging and device. And together we have achieved very low mortality, very low stroke rates. So this is data with SAPIEN-3 over the multiple studies, treating not only inoperable patients, but high risk or greater down to intermediate risk patients. And now we even have data for low risk patients showing that TAVR has superior outcomes with surgery, with stroke rates 1% or less, and mortality at 30 days of 1% or less. This is the composite endpoint from the partner low risk study showing death, stroke, or rehospitalization that were significantly lower with TAVR than with surgery. So the question is, can we now treat all stenosis patients, even the young patients? So we have to, in addressing that question, think about bicuspid valve disease. So bicuspid valve disease in young patients is much commoner. We know that in the decade of the 50s, it's even close to 70% of patients seen. So increasingly, we're seeing this as we see younger and younger patients. We have to bear in mind that in the US, the TVT registry, 3 to 7% of TAVRs were bicuspid AS. Therefore, TAVR is being used selectively now. But is it the right time now, based on the data we have seen, to treat all aortic stenosis with TAVR, young or old, regardless of valve morphology, bicuspid or tricuspid? We have to consider that the low-risk data I showed you excluded bicuspid valve disease. However, I'll show you data that we have so far with bicuspid. And I put to you, if you are considering a bioprosthesis as opposed to a mechanical aortic prosthesis, perhaps it should always be considering TAVR as the first option until proven otherwise. So this was data published in JAMA in high-risk patients looking at TAVR with bicuspid versus tricuspid disease. So this was using the STS registry, looking at a population of over 2,500 patients. The median age was 74, STS score 4.9, and it had one-to-one propensity matching, and it showed these procedural outcomes. So the annulus rupture rate was very low, but it was higher than with tricuspid because that was 0%. The conversion to surgery was also statistically higher, but you are comparing 0.9% to 0.4%. Also, the need for a second valve, there was a trend to a higher percentage, but again, below 0.5%. The stroke rate was also slightly higher in this initial analysis, as well as the pacemaker rates. However, the one-year mortality in matched populations, both for bicuspid and tricuspid, and also one-year stroke, were equivalent. This is data from Evolute in the US TVT registry. Again, similar median age, STS score 5%, looking at 900 pairs of bicuspid versus tricuspid. The 30-day mortality and 30-day stroke were equivalent, with very favorable outcomes with Evolute as well. Raj Makar subsequently looked in JAMA at low-risk patients. So this was looking at low-risk bicuspid versus tricuspid, a similar analysis to that I showed earlier, but in low surgical risk, STS 3%, less than 3%. And again, one-to-one propensity matching of bicuspid versus tricuspid with SAPIEN-3, and more than 3,000 patients in each group, looking at death and stroke at 30 days. And in this low-risk population, there was actually no difference. And this also considering that this is with greater experience, a later study performing TAVR in patients perhaps with more experience in bicuspid valve disease. So in fact, looking at the primary endpoints, there was no statistical significance, but in fact, following propensity matching, the data for bicuspid looked even more favorable, but this was not statistically significant for mortality, and no difference with stroke, even out through to a year. So similar data with bicuspid and tricuspid using SAPIEN-3. So there were also continued access registries. So this is data we published from Partner 3 bicuspid registry, looking at 30 centers with bicuspid AS. There were a lot of anatomical exclusions, but importantly, the age was, again, as you would expect, relatively young. These are the other demographics shown here. And the in-hospital death was 0%. And the composite endpoint of looking at death, stroke, disabling stroke, or rehospitalization was essentially similar to what we saw in the low-risk study for tricuspid valve. So again, very low. All-cause mortality was low. Stroke, again, was very low. Disabling stroke, there was none seen. And rehospitalization around 5 to 6% at 1 year. So these are the other endpoints shown. So all in all, very favorable data from this selected population. Paravalvular leak was also extremely low. So similarly, the Evolute low-risk bicuspid registry was multi-center, and again, patients were screened. There were fewer patients excluded, but still a significant proportion excluded. From 220 patients screened, 149 were implanted. The ongoing follow-up is considered out to 10 years, and the mortality at 30-day was only 1.3%, with very low disabling stroke and stroke here, and the other endpoints shown as you see. So we do know that although the outcomes are favorable, we have to very seriously look at the morphology, and not all bicuspid valve anatomies are the same. This was a registry looking at 1,000 patients with CT-confirmed bicuspid anatomy from 24 sites. Median age was mid-70s with an STS score between 3 and 4. Type 0 were only seen in 10%, and the majority were type 1. Again, the majority were SAPIEN 3, but a good proportion were Evolute. The 30-day mortality from this study was only 2%, with a stroke rate just over 2%. So this was data showing aortic root injury. So it was stratified by high-risk anatomies. So both conversion to surgery, aortic root injury, or paravalvular leak were stratified by high-risk morphologies, and this included calcified RAF, but also the excess of leaflet calcification. And really, the excess of adverse outcomes was with the combination of a calcified RAF plus excess leaflet calcification. So I'll show you a bunch of examples showing progressive younger age groups. So this is an 80-year-old male treated, referred for TAVR with symptomatic severe bicuspid AS, history of diastolic heart failure, and post-multiple PCIs. Here's the anatomy. You see a horizontal aorta with severe AS. And SAPIEN 3 was implanted. There was post-dilatation required, but a subsequent anatomy, subsequent paravalvular leak was only traced to mild, with very good final result and very low gradient at 30-day follow-up. This is now a younger patient, again, a patient in the 70s, again, with severe calcific aortic stenosis, this time with calcified RAFI and severe leaflet calcification. These are the measurements showing a large annulus and heavy valve calcification. There was pre and post dilatation due to the severely calcified aortic valve, but with SAPIEN 3, again, there was very good result with trace paravalvular regurgitation. There was an oval shape noted on the stent frame, but now this patient has been followed to 3 years with very favorable hemodynamics and remains asymptomatic at 3 years. This is data I've shown at 2-year follow-up. There was a degree of paravalvular regurgitation, which we're continuing to follow. So again, this is a patient in 70s with severe AS, very high gradients, as you see here, no evidence of subvalvular stenosis, but there's more of a fibrotic disease. So patient was treated with left main protection. We have very low threshold for left main protection, and the patient did very well at follow-up with low gradients and no aortic insufficiency. So this is a yet younger patient, still patient in the 60s with severe symptomatic bicuspid AS, and you see here very high gradients, severely calcified valve, and there was a 26mm SAPIEN 3 Ultra with a very good final result with no significant central or paravalvular regurgitation. So now we come to the 50s. So as I've said, we have a very low threshold for coronary protection in the younger age group, but we felt we could achieve a good result in this patient with type 0 bicuspid. Coronary height was more than 10, but there were very tall and bulky leaflets, so we protected the coronaries. And a SAPIEN 3 was implanted with a very good result. You see a lot of space for the coronary arteries. So as I've said, the morphology matters. Having this severe calcium with a combination of excess leaflet calcification is really a concerning subset, but otherwise outcomes are pretty good. But there are patients where we still refer for surgery. This is a young patient in his 50s with evidence of aortopathy as well and a severely calcified valve. So this patient we referred for surgery. So in conclusion, TAVR for all stenosis patients, is it the right time? Yes, I think so, nearly all. Favorable outcomes with TAVR in bicuspid with those both SAPIEN and Evolute in real-life registries. Outcome appear at least as good as in tricuspid. CT phenotyping is important in patient selection and procedure planning, while bicuspid TAVR is justifiable irrespective of surgical risk and age. High-risk anatomical features or concomitant aortopathy should still prompt consideration of surgery in low-risk patients, and randomized trials, prospective registries are still needed, especially in the younger patients. But it's important to take into account the lifetime management, and we want to minimize the number of surgeries, especially in younger patients who are likely to require multiple procedures over their lifetime. So that concludes my talk. So thank you, and I wish you a very good and successful meeting. Thank you.
Okay, thank you very much. Fantastic lecture. And I think it's quite important to choose the right strategy for each patient, including both surgical AVR and TAVI procedure. And for the sake of time, so we're going to move to the next speaker. I'd like to introduce Dr. Jeffrey Popmer, and he's going to talk about the upstream therapy for aortic stenosis patients. So Jeff, do you hear me?
I do. Can you hear me all right?
Yeah, perfect.
Okay,
and
okay, good.
See your slides as well.
You can see slides. Okay, perfect. That's always important.
Beautiful.
Well, listen, we'll take 15 minutes. Greetings from Phoenix, Arizona. We're right in the middle of the transcatheter valve therapeutics course, TCT. There's been a lot of really important data that's been presented, but we're going to focus for just a few minutes on Evolute and talk about where we're currently at with our technology, where we're going to go, and talk about some of our trials. At this meeting, and probably at your meeting and all the other ones, it's all talk about the durability. For patients, how long do the valves last? As we've talked about at this meeting and others before, the Evolute valve frame was designed for durability, like a suspension bridge with long porcine pericardial leaflets to distribute the stress along the leaflet length. It's got a very strong inflow that will allow it to conform to annular calcium, a pericardial wrap to prevent leaking. The porcine pericardium is thinner, more compliant than a bovine pericardial valve leaflets. And in the lower right, some very important data from Philippe Pibereau showing that the Evolute valve itself has 40% less leaflet stress than the Sapien valve by FEA analysis. Well, what does that mean? Right? We do these preclinical testing and we test things for decades before we actually have data. We're going to show you 4 sets of data that we've had really that have come to light. The first one's the Notion trial. You're very familiar with that. Lars Sundergaard was the principal investigator. 79-year-old patients about a decade ago were randomized to either treatment with a core valve, legacy core valve, or to surgery. The 8-year data has been reported. Lower rates of structural valve deterioration with core valve than surgery. Numerically lower rates of bioprosthetic valve failure. And this coming year, we're going to have the 10-year data. The 10-year data of randomized comparisons between core valve and surgery. So we're really looking forward to that. In the interim, we've looked at our data from the high risk and intermediate risk trials. And we use conventional measures of structural valve deterioration, a change in gradient more than 10, a mean over 20, and shown that particularly in small annuli, there are substantial differences between core valve and surgery with respect to structural valve deterioration. And in the lower right panel, why is this important? Because structural valve deterioration is associated with about twice the rate of death, rehospitalization, composite endpoints at 5 years. The development of structural valve deterioration by echo criteria is important. Now, we said, okay, that's not enough, right? We need to look into things like bioprosthetic valve performance. The standard criteria for surgery and for transcatheter valves for performance is the absence of structural valve deterioration, non-structural valve deterioration, which includes severe PPM, thrombosis, and endocarditis. So we again looked at all of our data, total of 5,000 patients with our randomized trials and registries, looking at bioprosthetic valve performance, which manifest early within the first 30 days, lower rates overall, lower rates in smaller annuli, but also significantly lower rates in larger annuli. The lower right panel is the most important, the lower right panel. If one develops bioprosthetic valve dysfunction, whether it be in the surgery group or the core valve group or combined, that's associated with a 50% increase in mortality, rehospitalization. It's the real deal. It's a number that was created by our guidelines, tested in a randomized trial, and bioprosthetic valve failure, dysfunction, associated with a 50% increase in mortality at 5 years. We believe that's important. But, you know, we don't see a lot of those correlations, oftentimes because the patients are older, in their 80s, and they don't have, lots of comorbidities. What's really going to be important as we move into younger patients to see if there's clinical differences that begin to manifest themselves. This is the 3-year data from our low-risk trial, 3 years. Randomized trial, STS under 3, average age 74 years old. Lower gradients at 5 years, but look at that upper right panel. That's all-cause mortality and disabling stroke. And you can see that the curves continue to separate from year 1, year 2, and year 3. It's a 30% reduction. It's a P of 0.051, but we're beginning to see that Evolute compared to surgery in lower risk patients has an advantage. And most of that in that lower right panel is really due to better valve performance. So it's the real deal. And it becomes more important as you move to younger patients. So we've gotten a lot of data done. I mean, we've got a lot of data that we've put together. We published all this in our randomized clinical trials, and we've moved forward with it. But what's left? Well, we've got to improve the procedural outcomes, lower the pacemaker rates. And you guys are all aware of this with our cusp overlap technique. We need to understand better morphologies, the patients with moderate aortic stenosis. We need to understand different device comparisons. We've just now completed the SMART trial, which I'll tell you about. We need to understand how we treat TAVR failures, and we need to think about improvement design. So I'm just going to spend a few minutes on each of these topics. There probably hasn't been any as revolutionary improvement of procedural technique that's been as important as the cusp overlap technique. Promulgated by Hemgada, unforeshortening the left ventricular outflow tract, separation of the conduction system from the annulus, and with a better target zone, better, more accurate implants, and as we can see from our optimized pro registry, lower rates of pacemakers. In fact, if all the critical 4 components of cusp overlap technique were followed, the pacemaker rate was 5.8% in the optimized pro trial. You know, that included the use of a stiffer wire being embedded into the non-right commissure, no greater than 3 millimeter depth, and some good aortography to assure the depth itself. So cusp overlap technique now used by many of the different valve vendors now with different valves. Very, very important to provide a more accurate implant and less depth and lower pacemaker rates. We have a real dilemma. And that dilemma is in patients with moderate aortic stenosis, pretty simply defined. A peak velocity between 3 and 4, a mean gradient between 20 and 40, an AVA between 1 and 1.5, not part of our current guidelines as indications for treatment. But we know particularly symptomatic patients and patients who display evidence of myocardial damage have a worsened prognosis. And although we don't have guidelines and there's no magic number of 1 that defines severe aortic stenosis, we don't have the randomized clinical trial to date that suggests that TAVR, as compared to medical therapy, is beneficial and prevents myocardial damage. We know that the outcome is worse in patients with less than severe aortic stenosis than the natural population. And all of those lead to us to the fact we have to have better evidence. So certainly we, in our EXPAND-2 trial, which will evaluate this, have said, what's the goal? Well, the goal is to preempt bad outcomes, to prevent death, to prevent irreversible symptoms, to prevent irreversible loss of life, quality of life, and to prevent myocardial damage. And those patients who experience 1 or more adverse features, like an elevated PMP, like a hospitalization, like an E to E prime that's out of abnormal global longitudinal strain, all of those criteria are very important in determining who's high risk. So worldwide, we have 2 studies that are ongoing. The EXPAND-TAVR study, where we're looking at patients with moderate aortic stenosis by echo definition, symptoms, and any of the following: a heart failure event, an elevated pro-BNP, a global longitudinal strain less than -15, and an ED prime greater than 14. And if the patient has those, they're eligible for randomization either to Evolut, now FX, or to medical therapy. Similarly, the PROGRESS trial, a little different entry criteria, just losing any moderate aortic stenosis and evidence of myocardial damage, is also ongoing. And with these 2 trials, we'll understand what is the benefit of TAVR compared to medical therapy. Very, very important endpoints. You know, when I come to the Asia Pacific theater, we have to redefine what small means. And in the United States, we call a small annulus less than 430. In the Asia Pacific theater, very different, right? 380 or less. But we've performed now a 700 patient randomized clinical trial, randomizing patients with an annular diameter of less than 430 to either Evolut Pro or Pro Plus or to SAPIEN. The 1-year endpoint is going to be death, disabling stroke, heart failure, hospitalization. We think that may not be substantially different. The second endpoint, as defined as the criteria that I showed you before, that had a 50% increase in mortality in 5 years, is bioprosthetic valve dysfunction. And of course, we're going to follow all these patients out to 5 years as well. So a very, very important randomized comparison of an annular balloon expandable valve and superannular valve And we'll see two things. What's the clinical event rate? And secondly, what's the rate of bioprosthetic valve dysfunction or valve performance between these two, followed at 1 year and at 5 years. Tell you, one of the things that we're really thinking about in the United States is what happens when the TAVR valve fails. And there's lots of combinations, right? A SAPIEN valve can fail, and you can put another SAPIEN in it, or you can put an evolute in it. A evolute can fail, and you can put another evolute in it, or you can put a SAPIEN in it. And what we've done now is we're thinking about the fact that we need to collect this data in patients. In the TVT registry, the frequency of TAV-in-TAV is 0.4%. 0.4%, not very often. But we think it's going to happen more often. We think we need to understand how to treat it, and we think we need to do things to move better. And so the first of our studies that we'll be supporting in collaboration with Dan Blackman and the steering committee that's in the lower right is called the ReValve study. It'll take all patients with bioprosthetic valve failure, whether it be a SAPIEN or whether it be an evolute. And the clinicians will decide what the therapy is going to be. They'll decide if it's an evolute, a SAPIEN, or SAPIEN and SAPIEN, or whichever combination, SAPIEN and evolute. And we'll track people. We'll do a CT sub-study. We'll do an angiography sub-study. We'll do a registry of explants that have to come out by surgery. Very, very important data. We hope to extend this to the United States, somewhere designed, and maybe even the Asia-Pacific theater if there's actually interest in this. Now, we've got to know more about these valves and what happens to them when they fail. And you'll see incredible information that's been done now by Janar Sathananthan and Stephanie Sellers in Vancouver. Really important work. And what has been done is that diseased valves that have been surgically explanted are sent over to their laboratory. And then what we've taken is those valves, implanted them in simulators, and looked at how they open and how they close. And you can see the calcification and its distribution that's there. Very important for us because we want to be able to move forward and say, importantly, we can plan where the first valve goes, depth-wise, in order to understand where the second valve goes. And this is a simulation from from FEOPS that has looked now specifically about how you do case planning. We're very excited about that. Finally, we needed a better deliverable valve, and certainly we have this in Japan, and we so have to have that soon in the Asia-Pacific theater. This is data from Gilbert's Tang Multi-Center Registry. I just want to show this as a collage and just talk about what happens. Because of the single spine, because of the more flexible nose cone, because of commissural marker, because of an optimized stability layer, we get a more symmetric deployment with less movement with FX than the predicate valves. In fact, in the data done by Dr. Tang, 3 millimeter depth, appropriate depth on the non, and 4.5 millimeter depth on the left. 96% commissural alignment. Over 80% of patients had none or trace paravalvular regurgitation. Everybody had low gradients. We think this is going to be a big game changer for ease of use and for device performance. Same valve, so we're really hoping that that's going to move forward. So I think that where we stand today, just to finish, is the evidence base for TAVR continues based on the unmet clinical needs. And we need to figure out moderate aortic stenosis. We need to figure out small annuli. In patients who become younger, valve performance and durability are the driving factors, particularly those with a longer life expectancy. We want to put one valve in patients for the patient's lifetime. However, if the valve fails, we need to have options. We believe the balloon expandable option correctly positioned to preserve coronary access is the right way. And we believe the next generation FX will improve deployment symmetry and allow commissural alignment. And that's not all. We're going to do other things in terms of opening up cells in order to make our catheter systems more deliverable. So that's a brief update about where we are today in the TAVR world with Evolute. And I really want to thank you for inviting us. Sorry not to see you at TVT, but I know you're having a really good time in Taipei. Thanks for your attention.
Thank you very much, Jeff, for your fantastic lecture always. And any questions and comments? So actually, I have a very brief question to you, and we were quite happy with the initial result of the FX system.
Yeah.
With very flexible shaft with the gold marker helps us to adjust the position of the 3 to 4 millimeter depths to avoid pacemaker implantation. And we are also treating a lot of patients with very small annulus. You were talking about the size of the bioprosthesis. And do you think that the size of the bioprosthesis itself matters, or the severe PPM or moderate PPM matters to avoid the structural valve deterioration? And if the PPM matters, do you care about the only severe, or do you think the even moderate PPM might impact the durability of the bioprosthesis?
Those are great questions, and we have to redefine everything in the Asia Pacific patients because in big people like myself, I'm 6'4". If I have a small valve, I'm going to have problems. But in an Asian population, we have to go back and study, does that same smaller annular size have that same implication? What we've seen so far, and particularly with what we've seen so far in our randomized data, is that severe PPM does matter. We've not found it associated with moderate PPM. We do believe that that's associated with a clinical outcome. So we've got to restudy all this in your population. And I hope we can be able to do that together.
Okay, thank you very much for your fantastic lecture.
Great, thank you. Bye, everybody. Thank you. Hi, Angus. Nice to see you. Yeah.
See you. Bye.
Excellent.
Okay, thank you very much. And for the sake of time, we're going to move to the next speaker, Dr. Simon Lam. And he's going to talk about the novel TAVR device with active sealing technology. So Dr. Lam, please.
Thank you very much. Good afternoon. Good morning, dear Chairman, panelists, ladies and gentlemen. I'm Angus Choi from Hong Kong. It's my great pleasure to be here today. And the topic, my topic today is a novel TAVR device with active sealing technology. This is my disclosure. First of all, I would like to share one of our recent case with you. Our patient is an 88-year-old lady who has history of hypertension, hyperlipidemia, stage 4 chronic kidney disease. She presented with symptomatic severe aortic stenosis, with echo showed normal LV function, the EF 60 to 65%. There was heavily calcified aortic valve, with the calcium extending from the annulus down to the aortomitral curtain with severe aortic stenosis. The mean gradient was 53 millimeter mercury with calculated AVA 0.82. There was also mild AR and mild mitral stenosis. The coronary angiogram was unremarkable, and she was deemed extreme risk of open heart surgery due to her advanced age. This is the pre-procedural CT for her TAVI. The annulus perimeter was 68.6 millimeter, but there was chunk of calcium extending from the annulus down to the LV outflow tract over the non-cusp region. The sinus of Valsalva, boundary height, and iliofemoral system are suitable for transfemoral TAVI. But when we look at the CT again, there was a heavily calcified aortic leaflet, which extended down to the annulus and down into the LV outflow tract. With such big chunk of calcium, we consider this lady might have very high risk of having significant other TAVI. And from previous data, we noted that patient having significant PVL after TAVI will have very bad adverse outcome. They will have more than 2-fold increased risk of overall mortality in 1 year. So we decided to use our latest generation self-expandable device for this lady. The Navitor valve is a next generation intra-annular self-expandable TAVI device with active outer cuff to minimize any significant valve leak after the procedure. This innovative device is used with a flex neck delivery system, which is a low profile, very flexible system that enhances the stable deployment with excellent deliverability. From previous protocol entry approval study, which is a prospective multi-center international single-arm trial, the overall in this trial, more than 99% of the patient was having transfemoral TAVR, and the overall all-cause mortality at 30 days was 0%. And the major vascular complication was only 0.8% only. And thanks to the active sealing curve, there was very minimal valve leak after the procedure. At 30 days, 80% of patients have none or very trace valve leak, and only 20% of patients have mild valve leak. There was no significant valve leak observed, and there was also excellent hemodynamic parameter with the mean gradient 7.4 millimeter mercury at 30 days and calculated urethric orifice area of 2.0. These excellent hemodynamic and PVL result was also observed at 1 year's follow-up. So go back to our case. The baseline aortogram, you already noted there was big chunk of calcium extending down into the LV output tract. So we pre-dilate his per annulus with an 18 millimeter nucleus balloon, and then we deployed a 25 millimeter Nevada TAVI device using the cups overlapping technique. The end aortogram immediately after the deployment shows mild to moderate PVL. So we perform post-dilatation with a 20 millimeter true dilatation balloon. And the final result show only trivial valve leak only. It was also observed in both the aortogram and also from the transthoracic echo. And the mean gradient across the TAVI device was only 7 millimeter mercury, very close to what we observed in the protocol entry trial result. We would also like to share one more case with you. This is a 78-year-old gentleman, active smoker, who has history of diabetics, hypertension, sex sinus syndrome, stage 4 CKD with calculated GFR 20 ml per minute. He has bad lung with very bad COPD and also peripheral vascular disease. He recently got infected left toe gangrene with amputation done. And actually he was pending for the peripheral intervention for his bilateral peripheral vascular disease. However, when he was waiting for the surgery, he was admitted for heart failure. Echo showed LV ejection fraction normal LV function with EF 60%. There was severe aortic stenosis with mean gradient 40 millimeter mercury and AVA 0.88. Corneal angiogram was unremarkable, but his calculated ST score was 8.5%. And he was considered in another inoperable for open heart surgery because of his comorbidity. This pre-procedure CT, the annulus diameter perimeter was 65. There was no big calcium this time over his annulus, and there was big enough sinus of Valsalva. But when we go to his iliofemoral axis, there was significant very, very diffuse calcification from the abdominal aorta to both the left and the right iliofemoral system. This is particularly true of the right external iliac artery with luminal diameter 2.3 times 3.4 only. His left iliac artery also has circumferential calcification and also narrowing, but it's a little bit better than the right side. his left brachial artery was also too small for TAV-in. So after discussion with our peripheral interventionist, we decided to perform angioplasty over his left iliofemoral artery, plus or minus to perform the PAVE and crack technique. And then on the same stage, we will perform transfemoral TAV over his left artery, left groin. This is the baseline aortogram, which you can see very diffuse calcification and very tortuous left iliac artery with site of tight stenosis at the external iliac artery. We perform angioplasty with a 7 mm shockwave balloon and then further post-dilate with 7 mm NC balloon. However, despite angioplasty, a 14 French sheath did not cross. So we need to upsize the angioplasty balloon with an 8 mm shockwave balloon. There's still some waste over the iliac artery. And after therapy with the 8 mm shockwave balloon, the shockwave balloon ruptured. And then the aortogram shows some staining and extravasation over the left iliac artery. Therefore, we insert and deploy an 8 mm cover stent, and then further post-dilate with 9 mm NC balloon. However, even after PAVE and crack technique, which an 18 French sheath did not cross the tortuous iliac artery across the cover stent. To complete the procedure, we have a trial one with an empty flex nav catheter. This 14 French flex nav catheter with some manipulation actually did cross the tortuous iliac artery. And most importantly, we could retrieve it completely through the artery without damaging the cover stent. The rest of the procedure was relatively straightforward. We dilate annulus with a 16 mm nucleus balloon, and then a 23 mm navigator device can navigate across the left iliofemoral system, and then we deployed it using the Taksaudom technique. The finishing showed good valve expansion with no significant upper leak, and most importantly, the aortogram, final angiogram show good flow and no extravasation over his left iliofemoral system. So ladies and gentlemen, patients with significant PVL after TAV have adverse long-term outcome. The latest generation navigator valve has an active sealing cuff to minimize any PVL, even in calcified complex anatomies. It also has excellent hemodynamic performance with single-digit mean gradient and large effective orifice area through 12 months of follow-up. The FlexNav delivery system allows precise deployment with marked flexibility to allow advancement in tortuous vessel. Thank you very much.
Okay, thank you very much, Dr. Tsai, to highlight the feature of the new navigator device with the very nice hydrophilic coating and the good hemodynamic performance. And any questions or comments?
Great, great the section, great the lectures. So for the last case, I just want a general question. To what end you will stop to do the transfemoral? I know this is a great outcomes, and you can see the so calcified and the tortuous and the circular calcification. You can try every method you can, but to what end you think you will stop to do the transfemoral? Patient does not prohibit like a risk for the surgery or to the other alternative access. So that's my general comment.
Thank you very much. Very reasonable in the comments, and I agree with you. And I guess so. And I also have one question to you. And actually, we studied navigator program from last year, and we have very much better impressions than that of the portico device. And could you please tell us the potential reason for the very good hemodynamic performance of navigator valve, even though this valve is the intraannular SIP expanding device? And what is your thought?
Thank you very much for your comment, Dr. Jen-Yi and Dr. Kentaro. Actually, for Dr. Jen-Yi's question, actually, the use of the MT flex nav to see whether it crossed the iliac artery was our last resort. We actually, after discussion among our team, if the MT flex nav did not cross, we probably need to abort the transfemoral procedure and might consider to use the transcatheter approach to form CAVI or the transcarotid. Of course, we need to discuss it later on, even with the patient, because the risk will be very different. And for Dr. Kentaro's question, I think that the good hemodynamic result was because the designs of the stem frame of the device, because the device is both the inflow and the annulus is also strict. This unrestrained, this strict design helps to increase the flow across the TAVI device and improve the hemodynamics.
Thank you very much for your quite great answer.
Thank you.
Okay, thank you so much for all the speakers and all the discussions. And this session has to be ended, and we have to proceed to the session 3, the live demonstration. So thank you for watching this program. Thank you.
Exciting segment of our program, the live demonstration. We have 3 live cases will be performed by experts from 3 different hospitals. The first cases will be performed by Zhenxin General Hospital. I will hand over the reins to the expert present on site. Thank you.
OK， 没办法照相，我觉得那边太深了，所以它会掉下来。可是为什么我觉得，不然你就直接对齐，都不要，好不好？好 ，0， 好吧
Thank you. Let's get started of this session. This is a live demonstration session. There will be 3 cases in this session. Now the operator is dealing with a patient with failed surgical bioprosthesis, and the patient also have paralytics. So as I seen on the screen, the operator, Dr. Cao and Dr. Li have already.
你那个位置好像稍微调整一下，哇，拉回来，调整角度一下哈。
Occluder of the paralytics, and then they try to deploy a self-expanding valve.
The professor, we just done half, so we finished.
So you continue. I'm just introduced what you are doing.
Yeah, because the patient has more severe AR after the BAV. 往外推一下，往外推一下。哎，这个比较好，来180，这个比较好，这个比较好，我慢慢来，慢慢来。
Slow down.
对，往外送。啊，这是比较好一点。OK。OK， 好。
Maybe you need to lay over a little.
飞机 OPPO。 Oh,
just pop out.
oh.
I think a 4 millimeter below the metal is okay.
Oh.
The second, could you align the button of the metal?
Okay.
Yeah, that would be better.
在这，来，均线推袜，顶住，顶住，再顶住，再进行，再这样。
And you can be careful. You can use the dot of the occluder as a marker.
Yeah. 它有点高，嗯。160。哦，真可以，好。
Yeah, that's good. Use the dot as a marker.
180。慢一点，慢一点。不会，往回收，可以，小心。
Too deep.
背心停了，不是，背心140就好，准好。来。
Okay, great. Good position.
那高点像刚刚那样哈。
Deploy slowly, not too fast.
180。还是低了一点，这个。不会。
Okay, I think the position is good.
背心了。
Slowly.
小心呢。对齐，一个击，好。
Can we see the echo?
Echo. 整个 PT 进去，好像应该还好。你的最好是要照啊，有没有 corner 的问题啊 ？corner 不是问题。
I think the depth is
要照我们 PV a little bit deeper.
The other side. But if you put it up, I'm worried about another pop out.
There's some parallax there as well.
Probably we can try one more time. Yeah.
Up to you.
Okay. 回来对 base.
But maybe a partial retrieve will be enough.
OK， 好。为什么我觉得这瓣膜好像不够大的感觉？对呀。来，那个回收一点，非常大。180。
It's 26 or 28, or 29.
再多一点。好，可以够，太低了。不是，你不要再回收。我这样。我再拉这样，再多一点呢。啊，可以。再来。OK。
不要再拉了，不要再拉。
这样可以。进行那个对齐底。这样可以。
Lay over 一点点，
就 natural position 就好了吧，不用推，不用。
好，不要推，不要打。
对。
Don't pull or push, stabilize the system.
好，这样。
Lay over a little bit.
你这给我。你给我下去，整个推下去，不要太。
不要整个推，我只是 hold 着。
慢慢会弹开，这样。
In the mid position. Okay, that's great.
120。你要放了吗？140，放开。OK, perfect. OK， 那么向上来哈。对。开心老婆。开了哈。
OK。
留住啊，小心把。
Leave the wire there. Maybe you need a post tie.
OK， 出来。Pitfalls. So how about paravalvular leakage?
No, only minimal paravalvular leakage.
Okay, let we start from the case report. 不是要做 BAV 啊，要再做一次啊。First slide, please. Apostle 不是吗？
No. You can leave it and watch for maybe 5 minutes to see what happened.
Does a patient visit the clinic for this on exertion, and he had comorbidity of heat infection, endocarditis, and hypertension. He received aortic valve replacement with Edward SAV 25 millimeter in 2012. And the STS TRM with 10%, hematocrit was 12. You can see echo here. That's two jet is the middle one is the barbara leakage, and another jet from the septum to the apical is a barbara leakage. The pressure grade initially was 27/47, and after stress echo is 45/60. Next. Echo cardiac, the multi-site CT show here, the aortic parameter was the 69, and this is 25 millimeter SAV with true ID 23, stand high 17. Coronary high is okay, it's 16 and 17. SOV was 33. And virtual valve to coronary, it should be 9 to 10, so it's quite large sinus and high coronary height. Next. So our plan is right radial for sentinel brain protection device, right common femoral artery for main device, and with Avalon Pro, valve 2 for guide, and the pre-dilation with Atlas Gold. We break it and the power leakage with ADO2 6 millimeter and the left common vein for patient. Any problem for this case?
Yeah. Do you think a bigger valve would be better?
Bigger valve is no, it's because the true ID usually is not 22 or 23. It should be around 21 to 22 because some valve degeneration tissue inside there. All of the true ID say that's 23. However, it's denied 23. Then the later we can see the Atlas balloon is 22 Atlas balloon would still have some waste, so the true ID should be 21. And if we implant a 29 valve, it's too large for this patient, and maybe we'll have the pinwheel effect after the procedure.
Okay, we also have Jimmy and Zhang Qiren and Zheng Zhenyi 跟谢主任、谢总召主任 here. What's your comment on this case?
Sorry, I was trying to figure out. He presented 2 patients there. The case that we saw was which?
No. The same patient.
Oh, right. I see. Okay.
They did the procedure, so we let them finish the procedure, then come back to the case presentation. And this is a patient with surgical valve failure and concomitant with paralytics. Yeah.
That was a 77-year-old patient that presented. Right. I see. Okay.
So let's we see the procedure. And please, Miss Xu.
Oh.
So it looks that the echo is okay.
It's okay, yeah.
Dr. Lin, would you please telling us, or we start from the beginning, okay?
Yeah.
Please, please present the case.
This is angiography for we go to the barbara leakage. So the Y is cyan blue and with multi-purpose. It got easier to enter the left ventricle because we check the barbara leakage width should be 2 to 3 millimeter. So you can see it's very easy to pass in the wire. And the next. And then we push the caster into the LV, got a grip cord, and we change the guiding caster and use a balloon to let the guiding caster into the LV. So finally, we change to the 6 millimeter guiding caster, and then we shift to the confida wire. So you can see here there's a small waist over there. It's a 25 millimeter balloon and with small waist. And after balloon inflation, we check echocardiography.
You mean 2.5? 2.5 millimeter. Yeah, not 25.
Yeah, that's you can see that we use the confida wire here. And be careful because when you insert the split wire into LV, the mitral cordage sometimes is tear. So that's so we need to take care about the wire. And then now we implant 6 millimeter that's ADO2, and this is the first time implantation. And the middle part is too deep into LV, so we retrieve again and release again. So you can see here that the second balloon is too high initially, and this one is the second balloon. The second occluder is just in the middle, so we release the occluder. Next. Okay. The echocardiography check here is only minimal leakage. And the next. 下一张，再下一张，做到半模 break。So that we use a 22 millimeter atlas go to break the valve stop. You can see here is a waist over here. So that the bigger valve could not be enough, could not have enough room for the after implantation. So that I think the 26 is the correct size of the valve. Next. And then we implant the 26 core valve WR. So that's just you see it's quite slippery, especially with the pre-dilation with atlas gold. And I doubt that the valve is break. However, the balloon size become the flat. So sometimes we just compression the valve, but not the breaker valve. So that's Dr. Lin, please talk about the echocardiography after procedure.
After the procedure, okay. So now you are seeing the after the
please talk about the pre-operative.
Pre-operation. Okay, sorry. Wait for a second. So this is the pre-operation long axis view. You can see the surgical valve is become thickening and with restricted motion and partial pseudo prolapse. And this is the severe regurgitation with stenosis valve. And also here's the paravalvular leakage. Is around 6 o'clock over the right coronary cusp.
Can you measure the jet width?
Yes. Wait for a second. Let me introduce it. So this is the X plane. You can see it's a crescent shape as from the 4 to maybe 8 o'clock, because this is the stand of the valve. So this is a blind side from the echo. And so this is the 3D reconstruction view. You can see there's a crescent shape over the 4 to 8 o'clock. It's a so the paravalvular leakage. It came from this area. Yes, this is the paravalvular leakage. So after using the multiplanar reconstruction I only can measure the width. The length is because the length is a little bit difficult to measure. Yes.
Just the width.
Yes. So wait for a second. So the width is over here using multiplanar reconstruction. The width is about 3 millimeter. So we choose the 64802 occluder for this kind of paravalvular leakage. And So after the deployment, you can see the occluder is aligned over the 7 o'clock. And the paravalvular leakage has downgraded to only mild or minimal paravalvular leakage. Here's the occluder, and here's the residual paravalvular leakage. So I think this kind of paravalvular leakage the width is relatively narrow, and after the balloon fracture, I think this kind of paravalvular leakage will disappear. So after so we continue the procedure. This is the reconstruction of the paravalvular the occluder. This is a 64802 from the atrial side. And so we use I think it's the Atlas balloon to balloon fracturing. And so this is the severe valvular AR after the balloon fracturing. So now the final result after the balloon after the valve deployment, and I think it's still a little bit oval shape, but I think the paravalvular leakage have almost disappeared. And the gradient I just measured is about, the mean gradient is only 5 millimeter mercury, and peak gradient is 11. So I think the result for now is very successful. Yes, thank you.
So the valve is supravalvular valve or just in the intravalvular?
Because when I check, there's still wire in there. I think that is a valvular leakage, not the paravalvular.
The wire is removed, so you can check
now? Okay.
Yeah.
Sorry.
I think you should.
Is there a supravalvular valve? Okay. So the final angiography, play the final angiography. And you know that the chewing cup over the 8, so that the final position should be 6. So I think it's okay for this case, and we did not do the post dilation. And do you have a camera here? 能不能照相？放大 ，magnify.
The Sentinel captures some debris. Yeah. 过来点，进来点。你这边，你调一下啊呀。Okay.
It's always catch something over there, and I think it's the small debris of valve. And if this go into the cerebral artery, I think maybe it's minor stroke or even a very important vessel. It got the major stroke. So in the current era, we have device. We always talk to the patient and discuss about the brain protection device. And almost every patient hope that they can do the brain protection device.
It is final pressure gradient after the TAVR implantation is only 2 to 3 pressure gradient. So I think the result is quite well. Yeah.
I'm not worrying about the gradient because the gradient is okay, but I'm just worried about the valve opening at the valve level. It seems that there's still a void in shape.
I think that's fine.
It's okay. Up to you.
Okay, that's we cross now.
Go ahead.
Any comment from the panel or the audience?
Professor Lee, I'm Zhang Qizhen from Chang'an Memorial Hospital. Congratulations for a nice job. I have some question about plaque for PVL. In your initial plan that you plan to do plaque after TAVI implantation, I'm not sure whether I'm right, but on your initial plan, so any difference to do implant plaque before TAVI or post TAVI, and about the sizing I have some experience, but quite limited. So any concern about the interaction of the plaque with the either the surgical valve or the new valve?
Okay.
The version you use, I know the disc is quite big at both ends. So any concern about the interaction? That's my question.
For when we do the balloon crack, in the beginning, we do the pre-procedure and the post-procedure. Now we shift to pre-procedure because we almost use 90% of the self-extending valve, and we try to implant a larger valve, such as borderline case 19 ID, and the brake we use 26 core valve. So that we after brake we just use a larger valve, and we always worry about if we do post procedure. Sometimes we all migrate the valve because self-expanding in the beginning is not quite secure, order in the place, so that we do the pre-procedure. And you can see in this case the acute AR noted, so that the valve always prepare nearby, and after break we just put in the valve immediately. Don't wait too long, because sometimes maybe 5 millimeters it causes the hemodynamic shock. And the other problem, we do the pre-dilation because of the long-term effect of the post-dilation still remain unknown. So that it's in our experience is a little bit different to the TVT S3 Ultra trial. They do the pre-dilation or post-dilation and increase the mortality a little bit, but we did not notice that the balloon valvular break caused the increase the mortality. And it's always break the valve, cause some debris emboli to distal part. So we use the brain protection device.
Okay, can I ask Jinsing's experience? Two questions really. First of all, congratulations, very nice results here. So if you are going to crack the surgical valve, how much more VTC calculation? What kind of VTC calculation would you take into account?
It's a good question, because just a couple weeks ago we do a case that's there's a misalignment of surgical valve, so we did not crack that because the VTC is quite short. It's around 2. In that case, we do the basilica instead of the break. Even after basilica, we still worry about the balloon valvular fracturing. So that's a limitation. And it's always see the morphology of the VTC, but not the actual distance.
And so in our center, as a sort of structural guy and also a surgeon, we have moved completely over to a surgical frame that is expandable. And what by that I mean Inspirus valve. So in Jinsing's experience, do you think that a valve like that will carry some advantage for, especially in a structural field when you're planning for lifetime management?
Sorry, there's a question.
I think the valve is good, but as you said, when you do the valve later, the current issue should be taken into consideration in the first implant instead of the second.
Professor Yin has mentioned about the circular oval shape of the plane at the plane of valve. So what's your threshold? It looks not
just intuitive. No, I'm just for this particular case. If I did the case, I will break the valve after implantation of the TAVR valve, because it will compress the occluder, maybe get a better circularity after dilatation. Not necessary to break, I think. There is one case report. If you break the surgical valve and you implant the transcatheter valve, that might also seal the paralytics if the leak is less than 3 millimeters in size. To our experience, we have done an analysis on maybe more than 20 cases of paralytics in concomitant with aortic stenosis. And we found that if the jet width is larger than 3 millimeters, it won't be affected by the TAVR procedure, even you do break. There will still residual leak. But if the width is less than 3, you can get a very satisfactory result. That means if this is a borderline case, if the leak jet width is larger than 3, you almost always end up with occluder. Well, have you finished or any comment to be added? Professor Cao.
Hello.
Yes, yes. Any other comment? Yes.
No, now the echocardiogram, we can see the T image. Actually the expansion of the valve is quite circular. I think from this T finding, there's no more post-dilatation is needed, I think.
Okay.
Yeah.
Great.
So this surgical valve lasted 8 years, 7 years?
When did the surgical valve implant?
Okay. So Professor Yin, I think Zhongshan Hospital is waiting.
Okay.
For the transmission. Yeah. So maybe we cross here.
Okay, we move to Zhongshan.
Thank you.
Okay. Professor Wei.
Yes. Dr. Yin, Professor
you are
Yin.
online. Yeah.
Yeah.
See you.
Can you hear me
Hear your
well?
voice.
Okay.
Would you
Thank
please
you.
introduce your team and your case?
Yes, I will introduce my team. I'm a cardiac surgeon from Shanghai Zhongshan Hospital. This is my team member, Dr. Yang, Dr. Dong, and Dr. Wang. Yes. Sorry.
Sorry, we didn't see.
We're in hybrid cardiac surgery room, operation room. Yeah. Yes. Okay. You can see the picture. Doctor.
Yeah. Okay.
Yeah.
Please.
Okay. Thank you. My team member, Dr. Yang, that's Dr. Dong, echo physician, Dr. Wang, and maybe I will introduce today's case. Can you show the slides? The IT guy, can you show the slides to the audience? Very thankful for your invitation from Taiwan, and it's my first experience to have the live demonstration to Taiwan. Okay. I remember maybe about 10 or 8 years ago, I went to Zhenxing General Hospital to learn my first SAPIEN-3 case in your hospital, and thank you very much. Okay. Okay, can you show the slides? I cannot show my slides. 把幻灯打开，把幻灯打开。
Please show the case presentation.
Yes. 要共sharing, yeah. 要共享一下。
Okay.
Can you? Yeah. Okay.
Yeah. Now we can see it.
Yes. The next page. This is the device of the JC called 捷成 Medical. All you know that the first generation of the Japan TAV system is transepic, and we have done about 10,000 cases in mainland China, and some some patients in United States and Canada do the transapical JC J valve. Okay, now the JC Medical they have the second generation, it's a transfemoral one. The valve is look just the same, but is very suitable for the transfemoral approach. The next page. Okay, you can. This is the TA J valve, and the right one is the TF J valve. You can see the next page. You can see the demonstration. It can the small one is can the transfemoral 18 French, and the bigger one for example today's case we will use 20 French transfemoral sheath. It has a locator. I call it locator, but maybe you you can call it the anchor. The anchor down to the 3 sinus. It's very suitable for AI patient. And altogether, we have done clinical trial in mainland China, more than 100 cases, and more than 30 of the cases done by Zhongshan Hospital. The next page. Today's case is 80 male patient, a short of breath and dyspnea, and have the past history coronary disease, hypertension type 2, diabetes, and he's a smoker. Next page. The STS score is more than 8%. Next page. You can see the echo, and maybe next Dr. Dong, the echo physician, will introduce the TEE, and you can see the TTE. The left ventricle is big, and left ventricle infection, the injection fraction is 51, and the VC is more than 6, and the annulus is 22. Mild mitral regurgitation. Next. It's a aortic CT reconstruction, some calcification. Next. Next. It's an annulus CT evaluation. According to the parameter derived, annulus diameter is about 25.6. So the J valve transfemoral, we have 21, 23, 25, 27, 29, 31, and 34. Okay, and according to the CT scan today, we will choose the 27. Okay, the coronary, the left and the right coronary is okay, and no need to worry. Okay, the parameter of the annulus. The parameter of the annulus in CT scan is 80.4, and the echo showed us that the parameter is 87. Next. So we stimulate 27 valve implantation. You can see it's suitable for this patient. Next. It's angle, aerial 6, and CAU 3. Next. Okay. Today is a regurgitation, severe regurgitation patient. And Dr. Dong, can you 那个能够把那个超声机器放到屏幕上面吗 ？Okay. Dr. Dong will show you the TEE. And the patient systolic pressure now is 143, and diastolic pressure is only 34. So the pulse pressure is very high, more than 100. Okay, Dr. Dong. Okay.
Can I speak? Okay, today we have a patient. We have a male patient about 80 years old, and he is a case of severe aortic regurgitation. You can see today we have 3 leaflets aortic valve and no thickness, a little thickness, and no calcium. We have a severe aortic regurgitation and
some mild or moderate mitral?
yes, it's
regurgitation.
about
Okay.
more than mild mitral regurgitation, but I think it's a functional MR.
Yes.
And the diameter of the aortic valve, I think, is 25.
So regarding the sizing, are there any rules you base on area or perimeter?
Yes, we usually use oversize no more than 10%. Usually 5% or even the patient diameter of the annulus is very big. For example, we use transapical J valve, and the biggest transapical J valve is only 29. If the patient's diameter is 29 or even 30, we use 29 J valve. It's okay. So I don't think it's very you need to oversize use J valve. So we usually over no more than 10%, and this case is 26, and we only use 27. No need to use 29.
Okay. Any other comments from the panelists?
Thank you, Dr. Wei, for this very nice case. So personally, we don't have J valve in Taiwan, so I have a couple questions. So we know coronary alignment is quite important. So in this new normal device, how do you do alignment? And also, I'm wondering if we can apply this for degenerative surgical valve. Thank you.
Yes. Okay. Thank you for your question. The first is the alignment. Yes, the J valve has the biggest. I think the biggest advantage of J valve is valve the alignment, because it have 3. I call the locator. The locator will find the 3 sinus very easily. Okay. And if we do the transapical, I can turn the delivery system to see where is the 3 locator and down and pull down to the 3 sinus. And in femoral system, it's quite interesting. Before we start the clinical trial, I'm very worried about the 3 locator. I'm afraid that we cannot put the 3 locator easily into 3 sinus. But after more than 30 cases experience, I think it's very easy. No need to turn at all. And you can see when we deliver the system later. And the second question is about the valve-in-valve?
For surgical valve.
The surgical valve, yes. The surgical valve, now the transfemoral one, we cannot do the valve-in-valve procedure with the second generation because it's a clinical trial. We only can do the TAV procedure, and especially for the regurgitation. And the transapical one, we have done more than I have done more than 100 cases in valve-in-valve, include aortic, mitral, and even tricuspid. Use the first generation J valve. It's very easy because it's have 3 locator, and we can easily to pull the transapical J valve into the 3 sinus to do the aortic valve-in-valve procedure, and if we do the transmitral, the transapical mitral valve-in-valve procedure, we also transapical approach, and we can how to say, we put the valve in the another direction, and we can find the three signals of the mitral surgical valve, and maybe next time I can have a live demonstration about the mitral valve-in-valve. Okay, thank you.
Thank you very much, Professor Wei Lai. My name is Jimmy Horn from Singapore. I'm really looking forward to looking at this case. We wish we have J-valve in Singapore, but like Taiwan, we don't have it. But it's a real unmet need. But I do have a limited experience in the historical transapical system, the historical system of Engager and first generation Janar valve. Very much like this technology, you grab the leaflet and bring it out rather than push the whole thing out. So naturally, there are the two specific features that is very unique in this kind of system is that the three locators naturally align and coronary orientates your commissure. So coronary alignment is a natural thing intrinsic to the system. And secondly, is also that because it brings the leaflet out towards your valve frame rather than towards the aortic wall, then it's kind of mitigate the risk of coronary obstruction in those two respects.
Yeah, this kind of fixing anchoring mechanism can leave a space between the outer service and the coronary takeoff. And that's why I'm asking the sizing. So we don't have to oversizing in that case. So that will keep the coronary away from obstruction. Any comment from Kentaro?
Okay, thank you very much for the fantastic presentation. And I would like to ask you a question. And the first one is, what is your current indication of this procedure? The target is only for high risk for surgery, or are you enrolling everyone? And the second one is, do you need rapid pacing to deploy the valve?
The second question is yes, we need rapid pacing, but only 140 or 160. And I think maybe we don't need, but usually according to the old experience, I usually do the pacing, but I don't think it's necessary. Maybe we will try. We don't do the pacing in this case. This is the first case. This is the second question. Sorry, can you repeat your first question?
Yeah. So could you tell us what is your current indication of this procedure?
Okay.
For high-risk patient for surgery, or are you enrolling all the risk subset patient?
Yes, yes. Now, according to the rule of the clinical trial in mainland China, we can only do the high-risk patient. For this patient is 8 STS, and we now have include more than 100, and all the average STS score is about 6.5, I guess. Yeah.
Okay, thank you very much.
Thank you.
So this device also fit bicuspid anatomy?
Yes, bicuspid. It's a quite interesting question, and because we only include regurgitation patient, so now most of the case is tricuspid one. But I remember we have no more than 5 cases of bicuspid regurgitation. It's also work because this kind of bicuspid have 3 sinus. Maybe it's a fusion of this of the left and the right coronary sinus, and usually after implantation we need dilation for this kind of patient. But in the first generation transapical J-valve, we had lots of bicuspid. Some doctors may worry, may wonder how do we put 3 locator in 2 sinus. Okay. Yes, we don't. For a stenosis patient bicuspid, we don't need to put 3 locator into the deep end of the 3 sinus. If the 3 locator is like an arm and we don't care. We only care where we put the valve itself, not the locator. The locator only can prevent the valve down into the left ventricle. So we have done hundreds of bicuspid, because you know that in China, bicuspid valve patient maybe 50% of all the stenosis patients. Okay.
Okay.
Professor Wei, question about pacemaker. As I know from your report, the pacemaker rate is quite low for after implantation of J-valve.
Yes.
But, very interestingly, for Janar valve, which designed with quite similar concept, the pacemaker rate was reported maybe 20 something.
Oh, really?
It's much higher compared with your device. So, any explain for this?
Yes. Now the second generation transfemoral. Now we have no more than 10 because we using the regurgitation patient, and we only oversize. I just mentioned 0 to 10%. So the implantation the pacemaker rate is about, I guess, maybe 8 to 9% in the second generation. But the first generation is quite low, about no more than, I remember, no more than 5%. The reason, I think, we don't need to oversize. In stenosis patient, we only downsize, we even downsize. So I think it's the largest reason for why we can lower the pacemaker rate with J-valve.
Is that also because the radial force?
Yes, the J-valve is relatively soft.
Yeah. And I think that you're absolutely right. The radial force versus clipping the leaf and bringing it out. So in the historical Janar valve, where it truly was gripping the transapical system, gripping the leaflet and bringing it out rather than push it towards the aorta wall, the pacemaker rate was very low. When they switch over to the transfemoral system, it's a completely different valve. It's behaved more like a self-expanding valve, and you can correspondingly see that the pacemaker rate is different.
Okay. Thank you.
If you have been ready, Professor Wei, please.
Yes, we have put the temperate pacemaker and the pigtail and another pigtail in the left ventricle. Now we will exchange the silver stiff. Yes, guide wire. Today we use 20 French sheets.
Can you show?
Well, we don't have Safari guide wire in mainland China, so we use Boston Scientific stiff, silver stiff. Yeah.
Confida?
No Confida in mainland China. Okay, it's a silver stiff. We make a pigtail.
Got it. Handmade.
Yes, because it's a regurgitation, we don't need to pre-dilate. And you can see the J valve system. 我往里走。把那个镜头就给到这个这个这是手柄的地方，好吧？把镜头走。
Any tips or tricks in preparing the valve?
Oh, sorry, I don't know. Maybe the technician will know how to prepare it. Okay. Yes, they were. Yes. It will take about 20 minutes for them to prepare it.
Okay, thank you.
Maybe tips or trick on how to make such a nice curve. 又便宜又好。
But Kentaro have a special technique in doing that.
We did it before the launch of the Safari together.
Yeah.
Okay, it's like the Sapiens 3 have it have the turn system, and we were turn the knob and the tip or make the tip easily cross the arch. Yes, here. Okay. Yes, you can see the yellow knob. It's control the locator, and the gray knob is control the valve. We can move ahead or backward, backward or forward of these two knobs, and we can turn it. Yes, 小一点，就是63是吧 ？OK， 把它放到中间啊，再往这边来一点，差不多了，好吧，就这样，把机器再往下降一点吧，不能降了啊。好的，来，我们准备做一次造影。You can do the angel firstly. OK， 好，造影。OK， the coplane view is okay， 那符号了。And because we cannot see the calcification, there no calcification of the leaflet or annulus, so I like to draw the 右手 to draw the line of the three sinus on my screen. So you cannot see the screen, but I can see the figure of the three sinus. Okay. B 在哪里啊？啊 ，B 在那边。OK。啊，不动了。OK。你看，这个我是放的彩线啊，放的彩线。屏幕转过来啊，朝我转过来一点，再转一点，再转一点。OK。Now I will push the yellow knob and the green knob together. 彩线。And you can see the valve. Valve is now the locator getting out of the sheath, and I pull the pull the green knob. You can see the locator just behind the valve, and now the move forward. 整个再往里近一点，我再调个弯，调弯好像有点不够。往前，把毛往前啊，再整个往前。哎，不行，它打在那。OK，very good。好啊，the three locator down to the sinus. You can see, okay, the 3 locator very easily to find. You can find the sinus themselves.
Is the
I don't need
locator
to turn. Okay.
retrievable?
Sorry?
Is the locator retrievable?
No, no, no.
So you just have one chance?
Yes, yes.
So I'm
Yes.
just wondering how high you let the unsheath the locator in the ascending aorta or just above?
Ascending aorta, just above the sinus level, about 1 pigtail. Okay.
Another question is, when you bring the locator down, does it find the sinuses themselves, or do you have to twist? Do you have to twist the system?
I don't have to. I cannot twist.
Okay.
Because I cannot twist. It will find it themselves.
未来左不在，
So
左不在。
左不在是吧? Okay. The echo physician tell me that the left locator is not in the left sinus. So I will put it again and try it again. 往后退，再往里进，再往里进 ，OK， 再往里进 ，OK。好 ，now， 现在左已经在了吗？
左在了。
啊，已经进去了，好，哎，我再往后退一点啊，现在我再把那个调弯再往前一点，调弯再往前一点 ，OK， 我再调的厉害一点。OK， 然后把导丝往后拔一点。
So you will just find its way there, or you have to make some adjustment.
Professor Wei says that it just finds its own place.
Yeah. Just pull back and push again.
Yeah, that's right.
Yes, you can see that the locator is in the 3 sinus. Okay, very well. Okay. 然后把诸位把它拔出来。再往里近一点，再往里近一点。我感觉好像重了一点啊，再往后退一点，再往后退一点点。往后退了吗 ？OK， 差不多了，差不多了。我瓣膜再往后退一点，瓣膜好像也深了一点。哇，我觉得这个好像差不多了。丽丽，你觉得怎么样？
差不多可以。
你觉得可以吧？
我觉得可以。
好，现在瓣膜基本上在3个 locator 的中央了啊。OK， 那我 lock。我们再来最后一次造影，好吧？那丽丽往后退一点。
我退了。
我们把坐标再往里近一点，我们再来最后一次造影，看看情况怎么样。好，来先保存一下，先保存。
So Professor Wei, you move your valve a little bit more aortic. Was it from angiogram that you saw what you needed to do, or from echo that you saw your valve was a bit deep?
Yes, the echo can find the 3 locator. She can tell me if the locator is in 3 sinus, and also she can tell me if the valve itself is high or deep. So I rely on she.
Right, thank you.
OK， 现在好像浅了一点瓣膜啊，我再往里再深一点，好吧？差不多了吧？好吧，就这样，好吧？你们没什么其他问题了吧？那我们就准备好，好吧？哦，对，我前面说过，这个不用 pacemaker 的啊，因为我们前面都是用的 pacemaker 啊。我们今天就试试看，我们第一次不用 pacemaker， 看看放这个瓣膜怎么样啊？这个也是大家可能也很感兴趣。如果真的不需要用 pacemaker， 那我们今后真的可以在局麻下做，也不需要去放 pacemaker。当然可能放 pacemaker 是为了万一可能有3度。好，我们把灰机先关了。
灰机关了。
来，那我们就不放 pacemaker 了，好吧？
好了。
来，在线，我们就直接放瓣。血压有点高，血压高，血压160啊，血压确实高了一点啊。 我也不认为血压高有什么太多的问题，血压高好像是高了一点啊。那么我们还是用一下吧，好吧？来用 pacemaker， 我们放到120，不用那么快，好吧？我们打到120，你可以先控制一下血压，先稍微控制一下，现在血压160，高了一点。我们还是用个120的，稍微把血压控制一下，通过 pacemaker， 好吧？We use pacemaker to control the blood pressure. Blood pressure is relatively high, 160. Okay. 好，来，快速起搏120。OK， 好，来再见。好，就这样，好吧？啊，丽丽，你不要上来。
我走了。
OK， 来关起搏。
开呼吸。
来松脚保存，呼吸打开。
开了。
所以我也不认为他这个真的放不放，就是开不开 pacemaker， 只是我们一个习惯，感觉有点怕啊，其实没什么啊。好，那我们现在准备要撤了，好吧？我不撤。好，我们现在就是把这个黄色的这个，就是 we will turn the yellow knob, 3 how to say, the wire is still lock the 3 locator, and I turn the yellow knob and the lock will release。 对，然后我们往后退啊，旋转灰的。
可以把那个放到主荧幕吗 ？X 光。
把 X 光，要技术员把 X 光放到屏幕上，拉屏幕，对，然后我们把 yellow 往回退，往回退，好，导丝往里顶一顶，导丝稍微再顶一顶 ，OK， 我们就退出来了。OK， 我们全部退回合拢。好，来小，来，先保存，先保存。好，来再见。好。
节律慢，有人要不要带一带？
好，可以了，来撤出来。
零好像也
来导丝顶着啊，
也还好。
导丝有点出来了。来，猪尾巴准备好。好，转了，好，猪尾巴。好，超声觉得怎么样？
可以，很好。
有没有半周漏？
没有。
没有半周漏啊，要是 no leak。
会这样。
瓣膜是不是完全张开了？
我看一下。
你看看这个瓣膜大小，我们今天27的瓣膜。Today's valve is 27, and we are yes, it's 25.5, 25.5. OK。现在这个瓣膜我们用超声测的是25.5啊，它实际上是27，所以呢，有的时候呢，我们sometimes we will make the valve the leaflet fully expandable. I usually like to post dilate. 我们先做一次造影，先看一看，好吧？然后我们再决定是不是做后扩啊。来，你先拔掉。
拔了。
先拔掉。好。然后我们还测个压差，看看压差怎么样。我们 test 来排个气 ，the gradient， 来排气。
排气是这个吗？
来放大，
是这个吗？
瓣膜放大。先做一次根部造影。好，来，做。OK， no leak.
Very nice.
Very nice. Very nice. And what's your suggestion? Do you suggest that I will do the post dilate because the valve, the stand out the diameter is 25.5?
Yeah.
What's your gradient? Have you done the what's your gradient?
Gradient, yeah. So that's the gradient now. 来，左边排个气，主动脉根部主尾巴排个气。
有吗？等一下。这个。
Okay. The yellow pressure is left ventricle, and the red one is the ascending aorta. Yes, there's no gradient.
Congratulations, great result.
Yeah, great result.
Professor Wei,
yes.
I have a question about the location of the valve. The valve doesn't anchor at the annulus, so it is captured by the locator. So how to decide the location of the valve? What about the location in relationship to the locator and the valve?
Yes, the locator, there is a three very thin link between the locator and the valve, so we don't need to locate the level of the valve itself, deep or high, because if the three link, the very thin thread, how to say？ 我直接用中文说吧，就是可能大家都听得懂中文，就是这个有3根线是连接在这个 locator 和瓣膜中央的。我们其实放这个瓣膜放的深和浅，主要是受这个线的限制。这个线绷紧了，瓣膜就稳定了。如果现在没有绷紧的时候，你瓣膜放的再高，它这个瓣膜还是会慢慢往下滑，一直滑到线绷紧。所以这个是无论是筋心间的 transapical 的，还是现在这个 transfemoral 的，都是存在这个线。当然这2款first generation and second generation 这个线是这个位置有一些区别，但是它原理是一性，没有这种锚定，所以瓣膜是要往下滑，一直滑到绷紧了，它就滑不下去了。而这个要最终的瓣膜的这个受力点就在 three locator， 这个要固定在3个窦里面的这个力，让这个瓣膜就再也下不去了。OK。
Thank you。
好，丽丽，你现在再看看，瓣膜有没有再舒展一点？如果现在是已经到了26以上，我觉得也没有必要再去扩了。如果现在还是25，我觉得可能还是要扩一下。
我的压差是10和5。
你是什么时候？
10%。
这你的压差是the echo gradient, the average gradient is 5。现在你觉得瓣膜的外径有没有到26以上？现在就还是25.5。
对。
25.5是吧
？25.5。
25.5。那我们就扩一下，来拆一个26的球囊，我们来扩一下，让这个瓣膜的远期表现可能会更好一些。很多医生他可能不大敢扩一个反流的病人，怕反流的瓣膜因为扩了以后呢，可能会移位但是通过我们的经验，对于单纯反流没有钙化的这种瓣膜，要做后扩是没有，就是不会就是瓣膜肯定是不会跑的所以大家不用太担心。对，这个也是一个演示，就看看我们对于个27的瓣膜没有什么锚定的钙化，在做后扩会不会瓣膜会移位这个猪尾巴有点难看了，变形了。来26球囊，你拆了吗
？What balloon size will you use for?
26.
And Dr. Wei, congratulations on your great result of the procedure. And actually, this is my first time to see this procedure, and I was very much impressed with the very nice result. And could you please tell us the mechanism of the fixation of the valve? Is this just the clipping of from the both side, or is there any anchor or verb to fix the valve onto the leaflet without any calcification?
Yes, yes, the mechanism of the or what? Okay, 我们先做获客 ，OK。Sorry, let me to do the post dilate first, OK.
Okay, please proceed.
来放大。
So why did you decide to perform post dilatation?
Yes, because the valve, the outer diameter is only 25. So I think maybe we need a post dilate to let the leaflet to expand.
Great.
And maybe it's better for the durability of the valve. Okay. 好，准备好起搏器。
准备好起搏器。
准备好了吗？来，快速起搏180。
快速起搏180。好了。
好，在线。好，来打。打。哦，抽，来抽，来起搏器先关，显了。
先关。
抽。你看这个球囊窜来窜去，瓣膜也没有移位啊，所以大家不用太担心，说这个瓣膜可能会移位。我们再来一次啊，刚才血压可能还没有降到非常低啊。来，准备好了吗？
好了。
来，快速起搏180。
180。
我的血压几乎完全掉下来。来打。哎，还是滑啊，那就这样吧。我看好像是已经起来一点了，前面第一次它已经起来了。啊，好像是比原来是要大一点。好，可以。丽丽，你再量量看，看看这个瓣膜现在多大了，有没有到26？啊，来，因为这个球囊非常大，所以它可能受到的力还是大，会往远端窜。
Professor Wei, so this is really
26.
nice work. So I have one question regarding the etiology of the AR. So what if the patient have a prolapse of a cusp? So do we still can use J-valve for this kind of AR?
Yes, we can. I remember very clearly when I do valve-in-valve for stainless valve-in-valve. Yes, the right leaflet, we can see in the CT scan, the right leaflet of the surgical stainless valve is wholly how to say tiered and down to the left ventricle. We can do with the J valve, and because the 3 locator, I guess only 2 locator in the right position, the valve will keep in the right place. 8，慢一点，这不用测了，刚刚压力已经没有压力计。
And the leaflets for this valve is bovine pericardial tissue?
Yes. Yes, 是心包，牛心包。
Thank you.
OK， 我们再来一次造影吧，好吧，来放大，就这样，结束。 做一次最后的造影。好，来照。哎呦，没接啊，没接，车压管没接。啊，再来一次。好，照。好的 ，OK。
All right, thank you very
OK
much.
Thank
Great.
you，谢谢谢谢。哎
Thank you for your excellent demonstration.
，Thank
Okay,
you，Thank you。
we will leave you here. Okay.
OK
Thank
OK，
you. Thank you.
Thank you Thank you。
Very
This
successful.
afternoon I will do another Chinese made the tricepical mitral replacement.
Mitral replacement
Mitral.
device. Thank you very much.
Thank you。
For your contribution to the meeting. Yeah. Thank you.
谢谢谢谢。
Okay, let's move to Anzhen. Professor Song Guangyuan.
宋院教授刚才好像，sorry，有个这个光线有点奇怪，好像上线了。我稍等一下，我 call 一下他，抱歉啊。
好，谢谢。
Of this live case，尊敬的殷教授，我先来汇报一下因为是一个特地为台北哇录播的病例，我先来 share 一下我们这个病例的情况。待会儿那个宋主任很想跟各位专家一起讨论这些病例的一些要点，可不可以？
可以。
因为我刚才
对，我们总共大概有25分钟哦，25到30分钟，大概就拜托你们先 present case， 然后我们等一下再讨论。OK。
哎，好，Thank you。
Thank you。没有放声音。
没有，稍等。各位老师听不到声音是吗？
对，要不然您做旁白还是什么？
我稍等，我看看，我也可以翻译，但是我看一下，因为宋主任还特地问候了您，我不知道这个问题出在哪里，稍等一下啊，马上，抱歉，是特别的不好意思。
没事没事。
您可以听到我说话对吗？但是您听不到这个 record 里面的声音是不是？
对对对。
听不见是吧？
还是没有听到。
好，那我来那个。
好，就麻烦你。
Okay, dear professor, first I introduce the baseline characteristics of our case. This is the 59-year male. He was admitted due to the exertional dyspnea more than 3 years. He has past history of the smoking for 30 years, so the pulmonary function is not very good. The STS score is about 4.4. So after deciding with the heart team, we decide to do the TIR for these patients. First, we looked at Echo Collab, the report for these patients. The etiology of these patients is mixed, actually. It's VFMR and partly AFMR. He has the severe mitral regurgitations by PISA method. Okay, now we can review the mitral valve anatomic characteristics of these patients. His mitral valve annulus is dilated not very significantly. The leaflet length at the 3 scallop is enough. We can see that at the scallop 1, anterior leaflet is 17. The posterior leaflet is 12 millimeters. At scallop 2, the anterior leaflet is 29, and the posterior leaflet is about more than 12. So at 3 scallop to the anterior leaflet is 26, but the posterior leaflet is about 9. And the mitral valve area is about 6.64, and the coaptation gap, the biggest is 3.4 millimeters. And his left ventricular astonic diameter is dilated significantly of the 67 meters. The left ventricular injection fraction is about 38%. Now we can see the image from explain that. We can see that the left ventricular is dilated significantly, as well as the coaptation gap between the anterior and the posterior leaflets is very extensive from scallop 1 to scallop 3. We can find that the MVA is 6.6 centimeters, and the total length of the atrial septum is 46 millimeters. That's enough for our transcatheter pictures. Because these patients is the functional mitral regurgitation, so we decided to choose the NTR to trace this pathology. First, we can see that we use the NPR to guide our transcatheter puncture procedures. From 3D in-fast view, we can find that our puncture point is about at 3 o'clock. Usually, we now tend to use NPR to make the height of transcatheter set very accurate. For these patients, we first want to put the first clip at the central lesions. It's at P2 scallops. So we want our the height of transcatheter is about 40 millimeters. Okay, this patient is about 4.2 centimeters. After successful transcatheter punctures, then we enter the SGC into the ALA. We can see that after SGC is at the left atrium, we evaluate the pathology of mitral regurgitation again. We can see that very extensive areas involved. So we decide first we use the NTR to put at the scallop 2. We also use the NPR to do the procedures. Now we can see that we put the first clip carefully into the left ventricular. And we adjust our orientations in this multi-view. We also put this clip at the significant mitral regurgitation areas. Now we found that the posterior leaflet tethering is very significant. In fact, the effective grasping leaflet length is not very sufficient. The most challenging for these patients when we do this procedure is that because tethering force is very significant, so we grasp the posterior leaflet is very difficult. So we try several times to try to get more, get enough posterior leaflets. It's vertical, like it's tethering to the ventricular directions. So after we adjust our device several times, we clearly see the two leaflets that is on the arm. So we closed our clip. Now we see that this clip is closed now, and the mitral regurgitation is reduced significantly, but there's still residual mitral regurgitation at the lateral side. And the area is also very extensive. So at these patients, we determine the residual pathology of the mitral regurgitation and found the most serious area to put the second clip, not side by side, alongside the first clip. Now we see that it's a little bit away from the first clip. We found the biggest gap. So we wanted to put another clip at these positions. Now we checked the residual regurgitation again by 3D with color Doppler. We also evaluate the mitral valve transgradient. It's about 3. Okay, now we can choose the second clip. We evaluate the pattern of systolic pulmonary vein. Still has reversed systolic pulmonary vein. Okay. Now we implant the second clip. We want the direction, the orientation of this clip is parallel for the first clip, but not very close. We want to put the gap. So we adjust our orientation of the clip both with the DSA and the 3D. This is our grasping procedure. We put up the gripper and the stick bouncing, wearing confirm. Then after the grasping, we see that the mean gradient is about 2. And the 2 clip is parallel. And now we see the pulmonary vein is all positive pattern. This is right pulmonary vein also improves compared to in baseline. There is a little, still have some residual mitral regurgitation for these patients. we use the PISA to evaluate again, see that the EROA is about 0.14 centimeters, and the mitral regurgitation volume is about 22. It's a mild mitral regurgitation. And after the 3D with color evaluation, we think the bridge tissue is very stable, and there is a mild mitral regurgitation. So this patient is we want to present in this meeting. We want to discuss with the professors now the technical consideration for TEER in mitral regurgitation. First, what is suitable for TEER? In FMR, maybe EROA ratio to left ventricular and diastolic volume is indicators. Second, the device choice. Usually we want to choose the NTR or NTW to reduce tension on the leaflet. First, what's the target for the functional mitral regurgitations? We think we want to the hemodynamic improvement. The blood pressure is improved, the air pressure is reduced, and the systolic pulmonary vein pattern is changed. So the most important target is is general strive for residual mitral regurgitation is less than 2 grade, and the most important is functional improvement in these patients. Reduction of the severity of mitral regurgitation has to be balanced with the increase in mitral valve gradient. So we think residual mitral regurgitation prevails over transmitral gradient for this kind of patients. Fourth, I think the most difficult challenge in our procedure is the posterior leaflet is severe, restricted, and tethered, which makes our grasping is very difficult. Sometimes we will use anterior LV with a slight ultra-hugger trajectories may help to get clip arm under the posterior leaflet. And we can use G4 independent grasp with the anterior and the leaflet independently. And we think, okay, after mitral regurgitation correction with TEER, some patients, especially in the injection fraction, is reduced significantly. Their hemodynamic change will very significantly. Sometimes we can use IABP and heart rate catheterization to evaluate hemodynamic changes. So we think FMR is dynamic, and we should evaluate considering his loading conditions. Okay, this is what we want to bring this topic for this meeting. Thank you.
Hey, Professor Yin.
Yeah.
Yeah, this is
Professor Song. Yeah.
Yeah, I'm sorry because I'm in Guangzhou. You know, we have Southern China.
I know.
Yeah, meeting. But I recorded the case because, you know, this case we can discuss a lot because we can do many difficult cases with anatomic considerations. Also, we can do commercial, we can do cleft and preparation. But I think, you know, for the function MR, I still don't know, you know, how we can treat, you know, which patient will benefit after the procedure. Just like this case, you know, we can choose from the, you know, this preparation, like we have the EROA, you know, divided by the every volume, and we can check, you know, if the index is bigger, I think we can have better result, but not for all the patients. Yeah. So the first question is, you know, how to choose the right patients for the function MR. Yeah.
Kentaro, would you like to comment on this?
Okay, thank you very much for the present very nice demonstrating case, and congratulations on the great, beautiful result. Actually, you pointed a very important point, and choosing the right patient for the TEER is quite important. And I think that this case is quite good candidate for the TEER procedure, and who may merit from this procedure. And for me, the functional mitral regurgitation could basically be the candidate for the TEER procedure, as far as it doesn't cause any procedural complication like mitral stenosis or tear or the mitral leaflet. And if the patient had really reduced ejection fraction, like lower than 20%, we should be careful. And the titration of the medication after procedure, like the increasing the beta blocker or ARNI or some medication, could also contribute to the longer life expectancy and better clinical outcome after procedure. That is my opinion. Thank you.
Yes, thank you, Kentaro. I think this is really important. You know, every injection is less than 20, we should be very careful, you know, about the patients we selected. Yeah, because why I, you know, left, you know, maybe 2+ mitral regurgitation after the procedure. The reason is we have one colleague from Sichuan province. He reported one case, the ejection fraction only 18%. He really did a very good result, but the patient died after 10 days. Yeah. So that's what I worried about, you know. Yeah. So this is the first question. And the second one is, will you choose, you know, the shorter one or the longer one, you know, for the function MR patients? Because if we choose, you know, a longer one for this kind of case, should be easier, you know, to grasp, you know, the tethering posterior leaflets. And also we have a very wide gap. Maybe, you know, the coaptation is not in the same plan. So if we choose a shorter one, should be very difficult. But if we choose a longer one, I worried about, you know, because this patient has a circular like valve. Maybe we can increase the tension after, you know, we grasp. So what's your opinion about this? Yeah, Professor. Yeah, and
Jimmy, you wanna comment on this?
I must admit, I don't do a lot of mitral at all. Support our instructional cardiologists, but of course, the tension created on the leaflet is something that you have to be very cognizant, because it's well documented that if the increased tension is too much, then tearing potentially can happen. And of course, if you are putting too many clips and also using the wrong clips and needing to put an additional clip, using a wide clip and putting additional clip, then gradient goes up. So it's a trade-off. I think all these are experience-based. The more you do, the more you encounter what to do and what not to do. And I think Abbott provides very, very strong, robust support to guide new implant centers for this sort of, especially the low volume centers for this kind of difficult cases. And the previous question, I concur with what everybody has said, particularly your last slide mentioned about loading condition for these cases. And I think best medical therapy before attempting a TEER procedure, that's a very important part of the management strategy before putting a patient forward to TEER, because a loading condition is such an important part of the management. And I think the guidelines after the 2 big trials was published, changing guidelines does help implanters with selecting the right patients and not fall into the trap of mitral FR kind of end stage burnout heart. Thanks.
Yeah, Dr. Chen.
Thank you, Professor Song, for your very excellent mitral clip procedure. So for the size of clip, in this case, we can see the length of post-leaflet is very short. On the contrary, the anterior leaflet is very long. And if we can see from the 3D echo, there's a big gap between the 2 valvulets. So I would like to choose NTW, normal clips, but with whites. And my first attention, we try to focus on the posterior leaflet. And once the leaflet lit on the clip, and then I will try to grab the long anterior leaflet. So that will be my answer to your second question. So for your first question, I think I always adapt to the criteria for the COAP-like patient. So if the EROM more than 0.6 or regurgitation volume more than 45, I think they will be perfect candidate. Sometimes we also will check the NT-proBNP. Usually those patients have very high NT-proBNP, even after we use all the guideline recommendation therapy. So in this situation, I think TEER is less frontier to benefit the patient. Thank you.
Yes, thank you. But I think we still need to face, the patients outside of COAP study, just like this case. Yeah, we don't know, if he will benefit or not. But until now, we have 1 month follow-up. The patient still, the quality of life changed, but the ejection fraction still keeps the same situation. Yeah.
Okay. I think for this kind of patient, we need vasodilatation and even inotrope support after the procedure. The patient may experience a hard time, and we have to use that to support the patient to overcome the acute period after the procedure. I also agree that maybe independent grasping would be a better option because the discrepancy of the leaflet length. Yeah.
Yes, because we don't have, mitral clip G4 system. Yeah. In China, we only have, NTR and XTR. We don't have a wider one. I do like, to NTW to treat function MR, because you can see in my procedure, I keep the 2 clip, not close, not too close. We keep the distance because I think there is no prolapse. We can make it even wider to get a better result and to minimal the gradients after the procedure. Yeah. So will you keep, maybe 2+ mitral regurgitation after, less than 2+ after the function MR TEER procedure?
Sometimes we can accept that for functional ones. But in degenerated ones, I think everybody agree that we should keep the mitral regurgitation as small as possible.
Yeah. But I think for COAP study patients, we should keep it, maybe the less the better. But for the patient with low ejection fraction, so what's your opinion? Maybe less than 20%. So maybe we keep it a little bit residue MR is better, or less than maybe trivial is better. We don't know. Yeah.
We don't have guideline on this.
Yeah.
Okay, because time is up, so we have to close this session. Kentaro, can you make a brief closing?
So thank you very much for attending this session. And in this session, we have really a nice lab demonstration for the TAV-in-TAV procedure as well as the mitral procedure. And I'm very much impressed with the TAV for AR patient. And thank you very much for all the doctors who contributed to this presentation as well as lab demonstration. And we also thank the moderators and the expert panels to make the very nice educational comments. Thank you very much for attending this session.
now proceed to the next topic, recent advances and the future perspective of the TAVR. Wishing you have a pleasant and informative lectures.
Okay, I'm Dr. Yin. I will start the session, and together with me will be Kentaro Hayashido, who will co-chair the session with me. And we also have distinguished guest from Eric Frankenstein from Israel. And we also have Dr. Park, Dr. Parma, and Dr. Kim. Dr. Pa and Dr. Kim from Korea, yeah. And the first talk will be delivered by Professor Kentaro Hayashido from Keio University Hospital. His topic will be OCEAN-SHD registries, current status and future perspectives. Please.
Okay. Thank you very much, Fuishan, for the kind introduction. And ladies and gentlemen, I'm Kentaro Hayashido from Keio University, and I'm very much pleased and honored to come back to Taipei in person to this very important meeting. And today I'm going to talk about our OCEAN-SHD family, the current status and future perspectives. This is my disclosures. And first of all, we had a history of the TAVI procedure from 2013, and we usually have the late approval of devices in our country. And we started from SAPIEN-XD, followed by COVAB, and we have the SAPIEN 3 and Evolute series. Nowadays, we are using the 3 TAVI devices like the SAPIEN 3 Ultra Auxilia, Evolute FX, and Navigator from Abbott. We are also using the Mitral TR system, and we started from the G2 system. Now we are using G4 system. We are also doing the appendage closure system with the Boston Watchman Flex system from 2021. And our OCEAN-SHD family includes 28 centers with 280 members from the north to the south of Japan, and regardless of the university affiliation of anything. And if the center is really willing to join the registry, they're allowed to join our registry. And this is the total number enrolled in our registry. We have the over 14,000 cases of TAVI procedure at the end of the 2022. We also enrolled the more than 3,600 cases of mitral clip, as well as 1,400 cases of appendage closure. And we have published the more than 100 papers so far, and these papers are accepted for the also the several guidelines, including not only Japan but also the American and European guidelines. And this study demonstrates the impact of the clinical frailty scale. If the patient is too frail, it might be associated with the higher mortality after procedure. That is accepted in circulation in 2017. That is led by the Masanori Yamamoto from Toyohashi Heart Center. And we also published the impact of the prosthesis patient mismatch in our Japanese cohort. And notably, severe PPM was noted in only 0.7%. On the other hand, the American registry demonstrated the incidence of severe PPM to be 12%. That is much higher than that of ours, presumably due to the very low body surface area of cohort that is also accepted in JAK intervention. And our friend Yusuke Watanabe compared the warfarin and DOAC using our registry. And our registry demonstrated the better performance of DOAC compared to the warfarin, presumably due to the lower incidence of the bleeding event. And we are very much pleased and honored to be the part of the MPSH-TAVI-AF trial led by Dutch Sankyo Company. That is the multi-center and multinational randomized control trial. And this trial demonstrated etokisaban was not inferior to warfarin that is accepted in New England Journal of Medicine. And our fellow Dr. Yusuke Kobari compared the clopidogrel and aspirin. And the clopidogrel was better than aspirin, regardless of the indication of anticoagulation therapy. That is in line with the result of the coronary intervention. And he also performed the research on the totally zero antithrombotic regimen after TAVI procedure. And you may experience that some people are too high risk for the any antithrombotic regimen. And in our registry, we demonstrated that there is no increase of the thrombotic event, even though the patient didn't have any antithrombotic therapy. And that it might lead to the idea of the randomized control trial. And now we are leading the NAPT trial. Actually, this name is given by Yohei Ono. Thank you so much for your idea, because we usually use SAPT or DAPT, and NAPT could be reasonable for this trial. And we are comparing the 360 cases, no antiplatelet therapy or aspirin, if the patient doesn't have any indication of the anticoagulation or coronary artery disease, and the way we see the result in the future. And Yohei also demonstrated the impact of the pre-procedural pulmonary hypertension on outcome after TAVR procedure. And if the patient have the increased the pulmonary hypertension, they may have the worse prognosis. That is also published in JACC last year. And we started from the 4 centers, and we become bigger and bigger. And nowadays they reach to 28 centers this year. And they're our PIs of our OCEAN family. And we also demonstrated our data on the patient on hemodialysis. And our data demonstrate the in-hospital mortality of 5% if we perform TAVI procedure on a patient on hemodialysis. And especially the emergency procedure was associated with increased mortality of 17%. That is, the patient selection and meticulous screening is quite important, especially in this cohort. And Yohei also demonstrated our initial data on the TAV-in-TAV procedure. And the Carpenter-Edwards device was predominantly treated, and followed by the Mosaic device. And the internal diameter of the surgical valve is quite small, like 17 or 19 in this cohort. And transfemoral approach was used in the more than 90% of the cases. And in hospital, all-cause mortality was noted in 1.5%, including the cardiovascular death of the 0.6%. And disabling stroke was noted in 0.9%. It was quite acceptable result for this high-risk cohort. And incidence of severe PPM was noted in the this 20% in small bioprosthesis and very low incidence in the large bioprosthesis. Therefore, if we treat the patient with small surgical bioprosthesis, and the optimal procedure and device selection was important to avoid severe prosthesis patient mismatch. And now, as I said, we're using the SAPIEN Ultra Resilier. We're quite happy with this device with the better performance in terms of reducing PVL, as well as the expected better durability of the leaflet. And we are quite happy with the Leaflet effects that is more flexible than the Leaflet Pro Plus, which provides also the very nice marker with the gold marker to position the valve at the better position to of the pacemaker. And we're also quite happy with the performance of the Navitor valve with quite nice hydrophilic coating with the good hemodynamic performance. And we are quite happy to have the recent update and evolution of the TAVI devices compared to our old previous days. And we are also using the G4 device, including the XD and XDW. And I personally like XDW to use is for the functional mitral regurgitation because it may lead to the annuloplasty effect to reduce the mitral regurgitation. And our colleague, the Dr. Shunsuke Kubo, demonstrated our initial result of mitral creep from our OCEAN registry. And you may read some Chinese letter, but the 22 centers are included in our mitral registry. And mean age was 78 years old, and the functional mitral regurgitation was 70% in this cohort. And acute procedure success was achieved in 94% of the patient, as well as the SLD single leaflet device attachment. The attachment was noted in 1.5%. And in most of the cases, the reduction of the mitral regurgitation was achieved, as well as the improvement of the symptom after procedure. And notably, the 2-year mortality was 22%. And that is interesting. The even moderate residual mitral regurgitation had impact on the late mortality after procedure. Therefore, the mitigating the degree of mitral regurgitation as far as possible is quite important to achieve the better result with this device. And we are also using Watchman Flex device, and we also published the data of our OCEAN appendage closure registry, and led by the Masa Asami from Mitsui Memorial Hospital. If we treat the really elderly cohort, the bleeding risk will be higher, so we should be careful. That is published in JACC this year. And we are also we have already finished the clinical trial for the TriClip device, G4 device, and we are quite happy with the result. And now we are waiting for the approval in our country. And the Evoke device is also very epoch-making and very innovating. And we have done the first case in our country at the end of March, and we are now enrolling the patient to this trial. And this year, I'm quite happy to announce that we had an on-site meeting in Tokyo in February 2023 with the more than 1,100 attendees from all over the world. And thank you so much for attending, and thank you, Wei-Shen, for coming over to this meeting. And next year, we're gonna have the bigger venue with the more and more attendees, so you're most welcome to visit our meeting. And thank you very much for your attention.
Thank you, Kentaro. We can allow one short question. Eric, would you like to make a comment or?
Well, Kentaro, as a matter of fact, I know this lecture not because I heard this lecture, but because I know almost the vast majority of those papers and the ocean. You're doing a tremendous job there in Japan, and I'm following you quite a long time. I got just compliments, really, the way that you implanted the structural and the aortic valve and mitral valve interventions, as well as the other structurals. It's truly amazing. It's inspiring. I got no remarks, just compliments.
Yeah. Thank you so much for a kind words.
Praise instead of comment. Thank you so much for your very wonderful, informative talk. Thank you, Kentaro. The next talk will be delivered by Dr. Palmer. Dr. Palmer is an intervention cardiologist from Poland. He is currently the chair of a training committee of the European Association of Percutaneous Interventions of the sub-society of European Society of Cardiology. He's very experienced in structural heart re-intervention of transcatheter procedure, CT analysis, and even endovascular thrombectomy in ischemic stroke. Is that Dr. Palmer?
Dear Chairman, dear audience, I am Radosław Parma, interventional cardiologist from Katowice, Poland, and it is my great pleasure to share with you current status of knowledge and experience of Redo-Transcatheter aortic valve implantation. All TAVI and surgical aortic valves have limited durability. Most of them will fail sooner in younger patients and in patients with renal failure. Most of these devices will degenerate with calcification and stenosis. Some of them, especially TAVI devices, are more prone to regurgitation. We have to decide whether to treat and save the lives of these patients by repeat operation, or we can actually qualify these patients for Redo-TAVI interventions. As you can see, based on this largest international registry, most of these patients experience structural valve degeneration of the leaflets of these devices, and is more than 60% of these patients. About 4% of these patients experience the valve thrombosis. Based on this experience described in the registry, the explantation, surgical explantation of these TAVI devices happened about 1.5 years after first TAVI implantation. The repeat TAVI procedure was done in patients who experienced the TAVI degeneration about 4 years after the first TAVI implant. The outcomes of Redo-TAVI procedures versus TAVI explantations were significantly different. The difference in 1 month mortality and 1 year mortality was almost 100%, with a 1 year mortality for surgical interventions going as high as 32%. The safety of Redo-TAVI procedures was confirmed in several selective registries, which proved that 1 year mortality varies between 11 and 15% in this patient population. Based on these outcomes, we can expect that in elderly population, the first procedure for aortic stenosis will be TAVI, followed by a repeat TAVI procedure in the future. However, in younger patients, we need to carefully choose between the aortic valve implantation by surgery or TAVI procedure, because we do not know how many reoperations or repeat TAVI procedures the patient will experience in the future. Most likely, it will be another TAVI intervention followed by probably a repeat TAVI intervention in patient with a long lifetime prognosis. Redo-TAVI procedures feature very specific terminology. We need to know the characteristics of TAVI devices, and these characteristics differ between the types of the devices, balloon expandable, self-expandable, and mechanically expandable, and also between the different sizes of the same type of the device. All these shown characteristics are included in a recently published paper on the consensus of Redo-TAVI using SAPIEN 3 in another TAVI devices, which was published in February this year. And please consult the appendix of this publication, where you can find all this data on most of the valves which are available and implanted in European market. The TAVI device skirt, together with its fully opened leaflets, create a barrier for coronary flow. The risk plane is defined by the top level of the opened leaflets after second TAVI device implantation. As you can see on this picture, it may be the shortest for the small low frame TAVI devices as SAPIEN 3 and Lotus. It is medium for Evolut R device and Navitor, and the highest for the Accurate Neo devices. The risk plane depends on the implantation of the TAVI device. In low device implantation, the top of the leaflets is also low, which facilitates coronary access. However, in a very high position, which is specific for the treatment of bicuspid aortic valve anatomy, we bring these leaflets even higher, meaning that in narrow routes, we may cause a risk for coronary access in the future. Such coronary access will be difficult in patients in whom the distance between the valve frame and the STJ, which is VTA, and the valve frame and the coronary artery ostium will be small, meaning smaller than 2 millimeters. In such patients, we cannot cross with a catheter from the outside of the frame, and it will be difficult to cross within the frame because of the presence of the skirt or expanded leaflets of the first TAVI device. In patients with large aortic root anatomies, which usually the VTA distance or VTC distance is more than 4 millimeters, we can expect that it will be possible to pass to coronary arteries outside of these frames, and the coronary obstruction risk is low. Just like we could define the height of the risk plane by low or high implantation of the first TAVI device, we can define the neoskirt height by low or high implantation of the second TAVI device. On the left, you can see the SAPIEN 3 implanted low into evolute R. On the right, you can see a high implant of the SAPIEN 3 in this device. The difference is not the skirt is the same. The difference will be in the top level of the leaflets, which are lower on the left than on the right. During valve-in-valve implantations in surgical devices, we usually do not see overexpansion of the surgical device, apart from its cracking. In Redo-TAVI interventions, it is quite different. In self-expandable devices, the frame can be expanded by balloon or by the second device implanted into this in the low or high position. On the left, you can see that by low implantation of the SAPIEN, we can expand the frame of the evolute R by about 1 millimeter. If we expand it higher in its evolute waist, the waist can be expanded by more than 1.5 millimeters, reducing the distance to coronary artery. In patients with small aortic root anatomy, that may increase significantly the risk of coronary artery obstruction. The coronary obstruction risk may be defined by playing with a neoskirt height. If we implant the SAPIEN 3 in evolute R quite low, which is shown on the left side of the slide, then we bring down the level of the degenerated evolute R leaflets, but at the same create a closed space between these two layers of leaflets, where because of turbulence and impaired hemodynamics, the chances of thrombosis may be higher. On the right side of this slide, you don't see any leaflet overhang and only this newly implanted leaflets function. This is an example of a low implant versus high implant inside accurate neo device. On the left, there is a alignment of the top of the SAPIEN 3 with a crown of the accurate neo, and this is called low implant, leading to some degree of leaflet overhang. Currently, we think that this is an optimal positioning of the SAPIEN 3 because it reduces the height of the neoskirt, allows coronary access and coronary flow, while causing just an insignificant leaflet overhang, which we think will not be disturbing the flow and also does not provoke increased gradients in these patients. In our opposition, a high implant fully opens the leaflets of a degenerated accurate neo, which reduces the overhang, but also increases significantly the neoskirt, which is the highest for the accurate neo across all TAVI devices. In summary to all this terminology, which is specific for Redo-TAVI procedures, while screening the patient, we have to take in all these characteristics of a risk plane, the design of the first device, the implantation depth of the first device, and also its commercial alignment to decide on the risk of coronary access and the risk of coronary obstruction in patients who we are going to treat. Computed tomography is mandatory before all Redo-TAVI procedures. The reasons are that we can assess all the previously mentioned terminology, starting from the type of the device implanted, its size, its effective size in the aortic valve anatomy, especially different from nominal ones in bicuspid aortic valves. We can assess the TAVI device implantation depth and also the VTA, VTC, and try to play with a reconstruction of the neoskirt height. Quite recently, there is also this possibility of simulation of Redo-TAVI procedures, and we have been cooperating with DASI for the reconstruction and coronary obstruction risk prediction, as you can see in SAPIEN 3 Inside Accurate Neo implantation, which allows us to choose the proper size of the second TAVI device and also to define its positioning, either low or high, to reduce the risk of coronary obstruction and also to allow a third TAV-in-TAV procedures in the future. In patients with projected high risk of coronary obstruction, we can use a TAVI device leaflet laceration in order to guarantee coronary flow and also future coronary access. However, this balloon-assisted basilica method is quite complex to do and also requires commissural alignment of the first TAVI device to be clinically effective. In the published consensus document, we have included advice on the sizing and positioning of the SAPIEN 3 inside degenerated TAVI devices. Here you can see a scenario of a degenerated SAPIEN 3 in which we recommend to use another SAPIEN 3 which is positioned outflow to outflow for best outcomes in these patients. In case of Lotus devices, we recommend using balloon expandable valve sized to true ID measured on the CT in these patients, especially important in patients with bicuspid anatomies, where Lotus sometimes is distorted with a significant waist, which will prevent SAPIEN from full expansion. And also, as you can see, and previously, we recommend positioning outflow to outflow in these two valves. The most common scenario in Europe of treating self-expandable degenerated devices is also the most complex to recommend on, because we advise to oversize SAPIEN 3 to the first THV, but based on the characteristics identified on the CT. The reason is that we may find low and high position of the evolut R, also sometimes constrained by the highly calcified leaflets of bicuspid anatomy. And then we need to tailor also the position of the SAPIEN 3 to the evolut R, allowing for maximal expansion of the waist of the evolut R to guarantee full opening of the leaflets of the second TAVI device, so that we prevent pinwheeling and also guarantee the lowest gradient across these valves as possible. For Redo-TAVI procedures, there is lack of evidence in many areas. We do not know short and long-term safety of these procedures. We still don't know procedural risk factors, the durability depending on the matching of the valves, and we do not know how to define the risks of future coronary access apart from the analysis of the CT, which I shown before. We also would need to compare the Redo-TAVI to explant surgery, which currently is much more in favor of Redo-TAVI procedures. Just to cover some of these fields, we included the Redo-TAVI recommendations in this publication, where you can also see the checklist for pre-procedural planning and a kind of chart for presenting and referring the patient for Redo-TAVI intervention. To answer most of these uncertainties, we designed a prospective Re-TAVI registry, which will be ongoing in the countries of Europe, Israel, and Canada. It will observe 150 patients with a degeneration of the first TAVI device of any kind. And after the local heart team decides that Redo-TAVI should be the treatment of choice, they will be offered the treatment with a SAPIEN 3 family THV. To summarize main points of this presentation, I would like to say that TAVI patients are expected to live longer in the future, and most of them will experience degeneration of their TAVI device. The surgical explantation of the TAVI device is much riskier than repeat TAVI. All we know about Redo-TAVI is based on previous case reports or selective retrospective registries, and that Re-TAVI is very different from pelvic valve, and we cannot extrapolate evidence from surgical devices to TAVI devices. What we need to learn is how to do the CD screening of the TAVI unique sizing and expansion, especially in bicuspid anatomy, and also to learn to know how to prevent coronary obstruction, to guarantee a low gradient after Re-TAVI, and also increase durability of the second device, allowing for a third or even fourth intervention in the future. Currently, we have the first consensus on how to perform these interventions published, and also we are running a Re-TAVI multicenter registry in Europe, Israel, and Canada to prospectively observe and identify the risk factors for these interventions. I hope that together we'll gather this evidence, and together with you, we will learn on how to guarantee the best interventions possible to treat our precious patients. Thank you for your kind attention.
Thank you. I think Dr. King is online. Dr. King, would you like to make a comment on this talk? Oh. Okay, no problem, Area.
I understand this was recorded, right?
Yes.
Radek is not online.
Yeah, he's not
right.
online.
That's a pity. Well, I think it was a truly outstanding, phenomenal overview on this topic. As a matter of fact, as he always do. But I think it emphasizes two things that I got to recall. One, I've seen the program yesterday, and I think that you gave a talk about cusp overlap, or cusp overlap technique, etc. Right? Now, you know, for years, I'm saying again and again, like a broken record, that TAVR should be implanted in two different, but not necessarily the cusp overlap. And cusp overlap became the holy grail. Like, this is the only way to implant in order to implant as high as possible. And this is the big mistake, because only now, when we all woke up to the necessity of a TAVR-in-TAV, we just understood that high implantation is not the target. Any patient should be recommended differently. There is a patient that the cost benefit of low implantation and the risk of pacemaker is nothing as opposed to the high chance of his life expectancy to have a TAVR-in-TAV, etc. You know, I'm not going to tell the whole story. So I think that it emphasizes it again and again. And I think that above all, it emphasizes the need to put now all the energy that the industry can do in order to do valves with a longer durability. This is truly the main issue today, because if there's going to be valves, and there is a huge work in Israel, at least I know, of longer durability, then the question of whether TAVR or surgery will have a huge shift. Otherwise, be humble.
Yeah, I agree. I think the risk of Re-TAVI should be incorporated in the valve choice the first time and also the shared decision making. Yeah. Okay. Next talk will be delivered by Yohei Ono from Tokai University, Japan. His topic would be commissural alignment, importance of a valve design. Thank you.
All right, so thank you so much for your kind introduction. Once again, I really appreciate this kind invitation to this great meeting. So for the next several minutes, I would like to make some comment about commissural alignment, which is nowadays very relevant and important topics. So for this low-risk era procedure, not only the procedural success and safety of the procedure, but on top of that, we need to provide excellent and superb hemodynamics, which eventually leads to better durability. Obviously, the pacemaker is still an issue. And as Eric nicely gave his insightful comment, we need to consider really about this potential re-intervention for the valve itself as well as the coronary intervention. So each valve obviously has unique features. The sapien valve has shorter frame, intraannular valve function. Navitor has longer frame, still intraannular function with open cell design. Evolute has long frame, supraannular, accurate Neo2, longer frame, supraannular, but with open and wider cells. So each valve has each design and has each advantages and obviously some disadvantage compared to the other device. So when it comes to single valve, obviously we can almost have access to the coronaries. However, if you have the second valve inside, the story could change. And in most of the cases, or even with a longer frame and even with a supraannular design platform, we can still perform coronary intervention as shown in this slide using a rotoblader. But if the patient has misaligned valves shown in this left picture, let's say B, it could be quite difficult to gain enough support by the guiding catheters. So the question we want to approach is, can we control this commissural alignment as a technical aspect? So the previous literature has shown that as for SAPIEN 3 valve, whether you crimp the valve in various directions, as shown here, there's unfortunately no impact whether you achieve a better commissural alignment or not. In other self-expandable platforms, as shown here in Evolute and Accurate Neo, there's some ways to navigate the valve implantation in order to achieve better commissural alignment, but not always the case. And for we are nowadays using this cusp overlap and also the LAO both ways. In Evolute series, we see actually we follow the head marker from the descending aorta to the arch and ascending aorta all the way to the cusp. In this cusp overlap view, we see the head marker as center front, as shown in this slide, and the other device also has some marker to follow, but for me, it seems to be a little bit difficult. When we open the valve fully, the C paddle, which is the commissure part for the Evolute valve, comes in the front side of the aorta. And for the Accurate Neo, the post, as well as the Navitor valve, we can appreciate the post in the middle of the left and right commissure, which means that the cusp commissure alignment could be achieved in these populations. So if we can meticulously control this orientation of the valve, there's a high chance of achieving commissure alignment. I would like to share one example. 79 years old female presenting with symptomatic severe AS, had a history of coronary intervention. So obviously we need to take care of the commissural alignment. In this specific case, the patient was relatively active and was not frail. STS score-wise, it was a intermediate risk score with no baseline bundle branch block. Had previously a history of coronary intervention, high gradient severe aortic stenosis. This shows the CT scan of this patient. The annular size was maximum diameter of 25, shorter diameter of 20.6 millimeters, area of 434, and the perimeter was 74.9. Sinus of Valsalva, the patient had a little bit of, not even, a little bit big non-coronary cusp. LVOT size was more or less similar to the annulus plane. ST junction was quite wide. Valve calcification was, I would say, moderate. Oops. Okay, it doesn't work. Sinus of Valsalva was sufficient. Coronary height was okay, 12.9 for the left and 18.9 for the right. Annulus aortic root angle was okay. Has some mild tortuous aorta, but otherwise minimum calcification, and the iliofemoral was very nice. Membranous septum length was 6.9. So we decided our strategy for this specific patient using 29 millimeter Evolut FX from right femoral artery using the inline sheath. So this is the baseline aortogram for this patient. So for FX, we have nose cone, which facilitates the delivery as shown in this slide. And as I mentioned, we follow this Hutt marker that goes to the outer curve of the aorta, which usually facilitates the coronary commissural alignment. So from this FX system, we have the gold marker, 3 millimeters at the inflow part of the valve. So we can clearly see that the valve is the depth as well as the commissural alignment is clearly visualized in this slide. So if the gold marker as shown in this specific case in the right-hand side, which means that it lies between the left and right coronary cusp, we can almost achieve the commissural alignment as shown in this case. So we confirm the depth of the NCC side with the cusp overlap view and LCC side using the LAO view. And this is the final depth and orientation of this case. So we nowadays try to cannulate the coronary arteries after valve implantation to see how quickly we can achieve coronary cannulation. And most of the time, since we can achieve commissural alignment quite nice, the coronary cannulation is quite easy. Post-procedure ECG shows no additional conduction disturbance. Hemodynamics is superb in this supraannular platform. This shows a post-procedure echo with no significant PVL and no patient prosthesis mismatch. And we tend to take post-procedure CT to check, number one, commissural alignment has achieved or not. Number two, the potential valve thrombosis. And in this case, we were able to achieve, as expected, a very nice commissural alignment. Post-procedure course was eventful. Patient was discharged 3 days after the procedure. So, so far we have some small studies regarding the commissural alignment after Evolut FX implantation with minimum incidence of moderate or severe commissural misalignment using this new iteration device. So we started from beginning of the March, and this is till the mid-April. I haven't updated our data, but even with these 16 cases, we have achieved in 93.7% of the case, only one moderate commissural misalignment. And the implant depth was quite stable. NCC side and LCC side with this new device almost in the similar depth with no significant conduction disturbance. So I guess to summarize my talk, essential tools for low-risk TAVI, we need to provide optimal hemodynamics, which correlates to good durability. Reproducible implantation is mandatory with potential commissural alignment. So commissural alignment can be highly achieved with a self-expandable platform. Each valve has obviously unique feature, but I guess the more controllable device is now Evolut FX, since we can navigate with the head marker orientation. This one facilitates the commissural alignment with Evolut platform, easier to confirm with gold markers. Thank you for your attention.
Thank you. If the head marker is not at the right position, what's the next? How to adjust?
Yes, we don't want to cross the arch back and forth to avoid risk of stroke. So I basically check the orientation of the head marker in the descending artery using the LAO projection. If the head marker, let's say, is front or going towards the inner curve, we try to slightly pull the device and rotate either clockwise or counterclockwise, and we can achieve the outer position of the head marker in most of the case.
Okay, thank you. Yes, sure.
Thank you for your fantastic lecture.
Thank
always. You. And sometimes we find the commissural misalignment after putting the valve before releasing. That means the gold marker tells you that this is the commissural misalignment. What would you do next?
Well, this is a very nice question, maybe $1 million question. Nobody has the right answer, but for our practice, if the patient is, let's say, over 80 years old with no history of coronary artery disease, and potentially there is no need, I wouldn't say no, but a low incidence need for coronary access, we wouldn't go, let's say, recapture and go back and do rotate, because it just potentially increase the risk of stroke or whatever. If the patient has, let's say, 2-3 stents in both sides of the coronaries and relatively young, and then we will have some discussion. But in the real clinical practice, we tend to implant in that direction. Maybe we will reposition a little bit lower, maybe, but most of the case, as I mentioned, we go for the full release, but we can consider for recapture in those patients, I guess.
Thank you so much. Okay, so thank you very much for your fantastic lecture. And let's move on to the next talk. I'd like to introduce Dr. Duk-Woo Park. And his talk is about antithrombotic therapy after TAVR, lessons from ADAPT TAVR trial.
Okay, thank you for inviting this year Taipei Valve 2023. I'm very pleased to present my invited lecture about antithrombotic therapy after TAVR and the lessons from the ADAPT TAVR trial. My name is D.W. Park from Asan Medical Center. So our ADAPT TAVR trial was presented in the last year ACC late-breaking trial. This is edoxaban versus dual antipress therapy for prevention of leaflet thrombosis and potential cerebral thromboembolism. The ADAPT-TAVR trial absolutely, I believe, provided important insight about how can you treat the prescribed antithrombotic therapy after TAVR procedure. So, and leaflet thrombosis, and everybody know where, but there's many portion we don't know where. And the leaflet thrombosis reported is 20%, but still the causal relationship of leaflet thrombosis with the cerebral thromboembolism still uncertain. Also, absolutely we know oral anticoagulation significantly reduce the presence of leaflet thrombosis, and it is still unknown OHC can reduce the leaflet thrombosis related cerebral thromboembolism. So our trial was still, and the rationale was a causal relationship of leaflet thrombosis with the cerebral thromboembolism, and also neurological neurocognitive dysfunction in patient undergoing TAVR is still unclear. Prior trial, including Galileo trial, some trial tested the NOAC-based strategy is most effective than conventional antithrombotic strategy for prevention of leaflet thrombosis and thromboembolic risk with or without OH indication after TAVR. So ADAPT-TAVR trial primary hypothesis is to investigate the effect of edoxaban compared to dual antiplatelet therapy for prevention of leaflet thrombosis and potential risk of cerebral thromboembolism and neurological outcome in patients without OH indication after TAVR. In secondary, and we also evaluated causal association of a subclinical leaflet thrombosis with the cerebral thromboembolism and neurological or neurocognitive dysfunction. ADAPT-TAVR trial is planned to include 220 patients without OH indication after successful TAVR. And the patient were randomization, one arm is a no edoxaban-based strategy versus DAPT as aspirin plus clopidogrel. At the time of enrollment, DAPT therapy was default strategy in patient without OH indication after TAVR procedure. And we do mandatory evaluation 6 months for dimensional cardiac CT, also routinely do and the serial follow-up of MRI and neurological assessment. Inclusion criteria, we included the symptomatic AS has a successful TAVR procedure, and the key exclusion criteria was any indication for OHC like atrial fibrillation, and any absolute indication for depth like ACS or recent PCI. And also we exclude severe renal insufficiency prohibiting CT imaging. And the primary endpoint was incidence of leaflet thrombosis on 4-dimensional CT at 6 months routine follow-up. Secondary endpoint was the presence or absence and the number and volume new cerebral region of a brain MRI, and the serial change in neurological neurocognitive assessment, NIH stroke scale, modified Rankin scale, and MOCA. Also evaluated the safety and efficacy outcome and the serial echocardiographic parameter. And our trial, 5 centers in 3 countries participate, and including key center in Taipei and the Chengxin General Hospital and the National Taiwan University Hospital. And we very much thanks for Dr. Yin and Dr. Karl. And our trial initially evaluated 769 patients, and finally randomization 235, and 115 patients assigned to edoxaban, 120 assigned to DAPT, and finally 111 were eligible for analysis in ITT population in edoxaban group, 118 were eligible for analysis in ITT in the DAPT group. And this is the baseline characteristics in ITT population. Edoxaban group and the DAPT group is overall age is 80-year-old, and the male gender is 44 and 39%. STS score is mean was a low category 3.1, 3.5, and creatinine the clearance in the 61, 59, and the use of low dose edoxaban in edoxaban group is 61%. And the procedural characteristics and balloon expandable type was used approximately 90%. And the transfemoral approach was used more than 90%. And the new permanent pacemaker approximately 10%. So, and this is a very interesting and very, dramatic, our completeness of imaging and neurological assessment. Cardiac CT scan performed is 96% overall patient, and brain MRI in the baseline and the follow-up was serially completed in the 96%. NIH stroke scale 94%, modified Rankin scale measured 94%, Montreal cognitive assessment was performed in 94%. So, and the primary endpoint in ITT analysis, overall instance of valve leaflet thrombosis, and edoxaban group 9.8%, depth group is 18.4%, p-value was 0.076, is not the significant in the statistical analysis. And however, PP analysis was a p-value 0.047, but the interpretation should be provisional, and the ITT is most important. So, and this trend was consistent in about reduced leaflet motion grade more than 3. So interesting finding is by contrast of CT finding MRI endpoint in ITT analysis and presence of a new cerebral region, 25% edoxaban, 20% is no difference at all between two groups, and the median number of total new region was no difference. Median volume of total new region was also no difference between two groups. And the neurological and neurocognitive endpoint is worsening of NIH stroke scale, worsening of modified Rankin scale, worsening of Montreal cognitive assessments comparable between two groups, no difference at all. And one of the key findings in the severity of halt and the number of halt, any amount of halt, there was absolute no association of extent of new region on serial brain MRI is measured the DW MRI and the FLAIR imaging and GRA imaging in the Spearman law, and the p-value was not statistically significant. This is also same in the according to severity of the halt and the decline of neurological assessments, no difference at all in any group, and we didn't find any statistical association. And the overall clinical outcome at 6 months is quite low, and the death was no difference. And also, and the systemic thromboembolism is quite low, and the safety bleeding outcome overall is any bleeding is no difference at all between two groups, 11.7%, 12.7%, and the major bleeding was quite low. And our ADAPT-TAVR trial was key finding the overall instance of leaflet thrombosis on CT scan was less frequent with edoxaban therapy than TAV therapy, although it did not reach statistical significance. The instance of new cerebral embolism on brain MRI and new development of neurological or neurocognitive dysfunction were not difference between two groups. There was no causal association of leaflet thrombosis with a temporal related change of new cerebral thromboembolism and the neurological outcome. So this is absolutely published in Circulation. And at this moment, I would like to remind this is editorial after publication of the Galileo trial. In Galileo trial, triple hazard with rivaroxaban, mortality, bleeding event, ischemic event was high. So, and Dr. Nishimura is to point out at this moment, and when he prescribed NOAC in the fragile, in the TAVR patient, we think about is what should we clinically do? Is this discordant data? And even though we are do a NOAC therapy, significant reduction of leaflet thrombosis, patient outcome was hazard. This is recalled in the nearly 30 years ago, CAST trial, cardiac arrhythmia trial, and nearly 30 years ago, absolutely misconception about the VPC after MI. And at the time, we think about, many physicians think about VPC after MI could be associated with ventricular fibrillation. So, and the VPC risk factor for sudden death and non-sudden cardiac death after MI 30 years ago. So they do randomization. It's one arm is a active anti-arrhythmic drug. It's one arm is a placebo group. But by contrast, our initial expectation, active anti-arrhythmic drug was associated much higher instance of the mortality and primary endpoint, absolutely misconception refuted by RCT. Absolutely, we think about the TAVR trial is same trend. You know, clinical key message, subclinical leaflet thrombosis has not been proven to affect clinical outcome for patient underwent the TAVR, and thus, therefore, this imaging phenomenon should not dictate antithrombotic therapy for its prevention of TAVR. The absence of temporal related adverse clinical event associated and the leaflet thrombosis imaging detected subclinical leaflet thrombosis do not support, first, routine imaging screening test for detection of this phenomenon should not be performed. And the second, imaging guided antithrombotic strategy, it would be not recommended in cases, if without hemodynamic or clinical significance. Thank you for your attention. Thank you.
Okay, thank you very much, DW, for a fantastic lecture. And it's quite interesting topic, and the result was so interesting. However, because of the sake of time, so we need to move to the next speaker. I'd like to introduce Professor Hyo-Soo Kim from South Korea. And thank you very much for attending this meeting. And today he's going to talk about issues of coronary access in TAVR. So Professor Kim, please start.
Okay. I'd like to briefly introduce the issue of coronary access in TAVI situation. Thank you very much for inviting me to Taipei Valve Summit. I'm H.S. Kim from the Senior Hospital. How frequently should we perform PCI after TAVI? There are several courts reporting the instance of ACS or PCI. There's one center, they followed 780 consecutive TAVI patients for 10 years, and they found about 10% of patients presented at least one episode of ACS required PCI at median follow-up of 25 months. Thus 10% at 2 years.
Hello, Professor Kim. Sorry, could you please start the slideshow? Because the
I just do a slideshow. Can you see my slide?
We can see
the whole screen.
Yep. And now we see 12 panels of your slides.
You didn't clip the full screen mode.
Okay. Can you see my slide?
No change.
Did you push the full screen with the pump, Kim?
Yeah, I made
No, at the bottom of your screen.
So you can find the button on the right bottom.
Right open.
Sure. Yeah. So Professor Kim, can we come back to you after the presentation by Eric?
Okay.
You can agree?
Okay, try to fix it in the meanwhile, Kim, and meanwhile I'll give my talk.
Thank you so much for
Thank you so much.
understanding.
We are not going to give up your talk, don't worry.
So, okay, so next speaker is Dr. Eric Finkelstein, my good friend, and today it's quite great to see you here in person. And today he's going to talk about 20 years of TAVR, past, present, and future directions. So Eric, please.
Okay, thank you for having me. As a matter of fact, I'm hardly standing because I woke up at 2 o'clock in Korea in order to come here. But this is important enough. I love this meeting and thank you for inviting me. My name is Eric Finkelstein. I'm from Tel Aviv Medical Center in Tel Aviv, in Israel. Now, I got, I think, the hardest task to squeeze into 15 minutes my experience of almost 20 years of TAVR procedure. So I'm going to fly through a few words about the history, our frustration later on, what have we learned, and a few words about the future. Now, you all know the history started here with this wise person, Leonardo da Vinci, that more than 500 years ago knew how to paint the aortic valve, even the bicuspid and tricuspid. This is the first paper of aortic stenosis written by Sylvester McGinn and Paul White back in 1934. But the paper that we all know and remember is this one by Ross and Braunwald back in 1968 that showed us the grave prognosis of symptomatic severe aortic stenosis. We all quote this paper, we all read it, but I don't know how many of you know that this paper is only on PM and 12 patients. Anyhow, the beginning started with Ruud Anderson that tried to create the first transcatheter valve, but the real deal was given by this person, Alain Cribier, with Martin Leon and Ellen and Khaninov, that made the first implantation in November 2022. They did this in retrograde, as you know, in a very, very sick person with very nice results. Quickly after them, my friends Eberhard Grube and Jean-Claude Le Baudet did the first core valve implantation, and all the rest is history. We were introduced to this first generation, the Evolut self-expandable and the Edward, and then we started to work. And we started the frustration. And the frustration were because unlike the PCI, we called it the unfair play of TAVR, because unlike PCI that we started with a very low risk patients, very accessible and easy type A lesions, in TAVR, it took us 7 years to get to the real patient. And for 7 years, we were struggling with very, very old patients with very severely depressed LV function and a lot of comorbidities. We were frustrated because the mortality was huge in the first days when we started TAVR. We were frustrated because there were strokes and because of this paper that shows us that 80% of patients undergoing TAVI has new lesions in the brain by MRI. We were frustrated because of vascular complication that was in 2 digits, the major ones. But I think that mainly we were frustrated because of those 2 pieces of calcium that were just like bones. Oops. That when we inflated the valve, we see this piece of calcium here, nothing happens to it. It's just moving to the wall of the aorta, just as we implant the valve, and we see nothing happens to it. It's just moving along to the wall of the aorta. So sometimes it stayed there and we're satisfied there was no leak, but sometimes we're not so lucky and this piece of calcium created this huge paravalvular leak. And the paravalvular leak in the first days was 2-digit number with increased mortality. So what have we learned so far? Well, you know that we learned from randomized controlled trials, from registry, and from small observational studies. And TAVR is probably the most evidence-based topic in medicine, well, as far as I remember. I'm not going to run through all the papers of the partner trials in the New England, etc., and not on the Evolut trials of high risk and low and intermediate risk, and that was those 2 beautiful papers of low risk patients. So those were all the early hurdles that we had, that the vast majority of them were slowly but surely resolved partially. It was improved in the mortality for almost neglectable numbers, and all the other complications, the major bleeding, the pacemaker, the stroke, all went down. The PVL went to like 2% or a little bit more. And here in my center, the pacemaker rate of implantation went down recently to around 6%, and the length of stay went down to around 2% mid. So if we went down from paper to paper, from study, from the high extreme to the intermediate to the low risk patients, we saw that TAVI was either superior or nor inferior to surgery. And this changed the whole way of thinking and the guidelines, and the operative risk is not a criteria anymore, but rather others. But we have to remember, the clinical trial finding of TAV trials apply only to the patient population studied. Specifically, it does not apply to younger than 65 years old patients. Unfavorable TAV anatomy like non-transfemoral access, calcification, coronary obstruction, complex concomitant coronary artery disease, severe LV dysfunction, etc. And then we learned some accessories like the cerebral protection, the MANTA or other closure devices, and the Safari or Confida dedicated wire. Regarding the protection of the brain, we have learned that we do not have the end result yet, at least statistically. Raj Makkar have shown us the halt and the valve thrombosis. And that's why Philippe Généraux created with others the VALC-3 definition regarding the valve failure. The good news were that in the new generation, the valve failure is not faster than the surgical ones. Not in the notion, and definitely not in these last papers by Michael Reardon that have shown that it's definitely not inferior, maybe even superior in some aspects. Then we learned the topic of bicuspid aortic valve. And if this is the way that we learned it by receivers for many years, the classification, well, Hasan Jilaihawi created a new, very smart and much more suitable classification for TAVR. Now, Yoon and Raj Makkar have shown us that TAVR for bicuspid, when truly selected without heavily calcified RAFE, has got the result just as the 3 cusp as well. And Raj did it with the huge TVT registry as well. I ran over it. And then we had the valve-in-valve. Well, so many people talked about it. But the beginning was Danny Dvir and Ran Kornowski from Israel that published those papers, and later on Danny Dvir and John Webb when he went to Canada. When we learned that, and it was so fast, and then we learned the TAVR-in-TAV, like valve-in-valve, but in the TAVR. And again, this is Uri Landes, used to be our fellow, and went to do this with John Webb as well, and showed us that it is feasible, it's doable, but it raised another questions that you have shown here just a few minutes ago. And they've shown that any aspect that you can check is just the same, like valve-in-valve. And this is gave us a glimpse to the future with TAVR-in-TAV, like this case that was done in our center. I'm ashamed to show it, but this is true. Now, this was truly mainly because this paper of Winnie Buffett that have shown us the explantation of TAVR valve is not that easy. So the good news is that, yes, maybe you should do TAVR-in-TAV. The bad news is that if you think that you're going to need a TAVR-in-TAV, think again, because explantation might be very, very difficult. Then they had with the issue that were spoken before of the coronary access after TAVI, the commissural alignment and the coronary alignment, emphasized beautifully by Tarantini, and now with Radek Parma that gave this talk. And then we extended it to a TAVR in the mitral. And this is a case that I'm ashamed to show as well, but it was down in our center. And now we just went very, very deep into the antithrombotic trial that started here and went again and again, and then changed the whole way of thinking, which maybe you are going to now change again with no need for any antithrombotic. I don't believe it. Anyhow, these are the new guidelines. And then we started the minimalistic approach. And I'm not going to count everything because you know it all and you're doing it. But that's the way that I looked when I was proctoring here in the beginning. And that's the way that I look today in Tel Aviv Medical Center when I'm doing TAVI procedure. And the whole way of thinking changed. Not who is not for surgery, but rather who is good for TAVI. And who is good for TAVI, I mean with humbleness. Not every patient is good for TAVI. But if he does, as Michael Mack said long time ago, when two procedures are equal, the less invasive procedure wins. A few words about the future. Well, I'm going to run over it quickly. The way of thinking is going to change. Like Philippe Generoy taught us many years ago, the staging of aortic stenosis. We're probably going to use this prognostic aspect in order to decide whether to start and treat people with moderate or asymptomatic aortic stenosis, because we have the valve pathology and in parallel we have the cardiac consequences, and they are going together. And that's why probably, and we have learned from the recovery study of the surgery of asymptomatic patient, as well as we learned from the AVATAR surgical AVR trial of asymptomatic patient that early surgery might have benefit, and why not to extend it into TAVR procedure. And that's why we're having now few trials that are running. The early TAVR by Philippe Generoy and Martin Leon of asymptomatic severe aortic stenosis. The upload, the TAVR upload, unload, of Nicolas Van Miggen and Martin Leon of moderate AS and heart failure, and even the progress trial as well of moderate and calcific aortic stenosis. We had progressed with the TAVR devices. We all remember the Sapien, the XT, the Sapien 3, the Ultra, etc. We know the introduction of the new FX. I don't know what's your experience, but for me it's a game changer regarding the implantation is, etc. These are what we have now. This is what we do not have but are running around the world today. And I just want to tell you that this is a valve that I had the honor to do the first in human with Ran Kornowski last week. This is a valve of that was developed in Israel by Medinol, and this is built of two different pieces. One of them is the valve itself, and the other is just the basis. And the valve is made of one piece and not three pieces. It goes down, and since it comes with two different pieces, it now is being deployed as 12 French outer, and is going to be 9 French pretty soon. If this will show long-term a nice result, it will be a real revolution. We're going to have this hologram that is being developed in Israel by Elchanan Bruckheimer as well, and the valve is going to float, just float in our room in order to decide how to put it. Now, more than 1 million procedures have been done so far, but I want you all to remember, TAV is becoming a default treatment and will represent growing population of all TAV AVR procedure in the future, in parallel with increased global demographic needs and prolonged population longevity. The TAV revolution was the inevitable result of decades of progressive iteration in transcatheter therapies, progress made in open heart surgery, cardiac imaging, and better overall diagnosis and awareness of aortic stenosis disease. Clinical research effort should shift from late-stage reactive AVR to early-stage preemptive AVR and other complementary therapy approaches. The availability of less invasive, low-risk transcatheter technologies combined with more durable heart valves, which is a work in progress and probably the most important one today, coupled to enhance easily accessible early diagnosis, will transform aortic stenosis patient management paradigm in the future. And last but not least, I think that, you know, Darwin said that it's not the strongest, not the most intelligent, but the one who is more responding to changes. And this is a slide that I'm showing my chief of surgery, who is those days doing with me TAVR procedures, because he should understand, like all surgeons, that surgery has got its place, but they should learn how to do TAVR as well. And then all the debate will be more equal and much more reliable. Thank you so much for your attention.
So thank you very much, Eric, for your fantastic lecture. Actually, that you studied the procedure from the beginning of the history and you know everything, and your lecture was so impressive. So we have a lot of questions to you, but because of the time, so sorry for the not be able to accept any questions. So we're going to introduce the final speaker, Professor Hyo-Soo Kim from South Korea, and the slides seem to be much better. Thank you very much for the waiting, Professor Kim. So could you please start your presentation? Professor Kim, can you hear me?
We prefer to hear him and not see the slides, right? Professor Kim, do you hear us?
Professor Kim?
Can you hear me?
Yes, perfect.
Okay.
Yep. So now it's your turn. So thank you for waiting. And could you please start your PowerPoint?
Can you see my PowerPoint slide?
Not yet.
Not yet. Let's see.
And please start slideshow.
Okay. Can you see?
Perfect.
Okay. Okay. Great. I'm sorry for the technical problem. Previously, the instance of PCI after TAVI is about 10% at 2 years follow. And another big cohort, Medicare cohort, about 142,000 TAVI patients, about 5% of patients experience ACS requiring PCI, 5% at 300 days. And another TAVI trial, the PCI after TAVI was about 2.2%. the median time of PCI after TAVI is about 2 years. Thus, we recognize the incidence of PCI after TAVI is from 2% to 10%. It increases as follow-up duration is prolonged. Here is the post-TAVI angiography PCI success rate that ranges about 85 to 100%. Thus, about 10% of patients we cannot get successful angiography or PCI. What's the factor that influence cannulation success rate? There are unmodifiable anatomical factors as well as device and procedural factors. Anatomical factors, as the junction dimension, the bigger, the better. Sinus height, the taller, the better. Leaflet length and bulkiness, the lesser, the better. Sinus valsalva width, the bigger, the better. Coronary height, the higher, the better. Device and procedural factors include commissural tab orientation. This is commissural alignment. It's a very important issue, emerging issue that we have to pay attention to. Ceiling skirt height and valve implantation depth is kind of one factor that interact with each other. Thus, we have to pay attention to the depth, implantation depth, and the commissural alignment. In re-access study, they analyzed predictors of unsuccessful coronary cannulation after TAVI in the real-world cohort. 3 factors emerges as predictors of unsuccessful coronary cannulation. That is transcatheter down to valve per sinus valsalva relation. If sinus valsalva is narrow, coronary cannulation gets difficult. Implantation depth is shallower, it gets difficult. Avlut is difficult. In this analysis, they compared the success rate of coronary cannulation among 3 valves: accurate, avlut, SAPIEN, 100%, 82%, 99%. Thus, I have to pay attention to avlut, coronary access, TIV, and later. Align access study, they check the coronary cannulation and angiographic quality in SAPIEN, avlut, accurate. Here is the left coronary artery and right coronary artery. Green bar is selective angiography, yellow, non-selective, red, unsuccessful. After SAPIEN, most of cases we can see selective good images, but supraannular TAVI valve, such as avlut, it is not perfect, but improve when we make alignment, as shown here. Without good alignment, failed case increases. Thus, commissural alignment improves rate of selective angio after TAVI with supraannular TAVI valve. Nevertheless, aligned supraannular avlut carry higher risk of non-selective angio than SAPIEN. In this study, they also checked the multivariate predictors of impaired coronary access after TAVI. Once again, sinus valsalva height, sinus valsalva space, and coronary implantation depth, and misalignment. Thus, alignment is very important for the future coronary access, especially in avlut system. This is good alignment. Post is just natural commissure. It is far from the coronary ostium. This small aligned case, neo commissural post imposed on the coronary os. Thus, how much can we modulate alignment? In this aligned TAVI trial, they checked the impact of initial orientation of valve on the future severe overlap between post and coronary ostium. That was defined as less than 20 degrees apart. Here is a SAPIEN with various orientation, avlut, various orientation, accurate, various orientation. In SAPIEN, orientation does not have any impact on the later overlap. About 1/3 of case showed severe overlap, but SAPIEN is very short. Even though there is overlap, that does not impair the coronary access. But in avlut and accurate, initial orientation made huge impact on the future coronary accessibility. There's more than 40% of cases had overlap between post and coronary ostium. Initial orientation of Sapien 3 had no impact on alignment. Initial orientation of Avalot and Accurate improved alignment. Thus, let's dive in Avalot system. They prepare Avalot system with such a kind of maneuver. CTAP is nail commissure, is 90 degrees apart from the center of head marker. Please remember, 90 degrees between center of head marker and CTAP. Usually, head marker is outside curve. That the head marker center usually passes through the commissure between right and non-coronary cusp. The CMOD usually located in the commissure between right and non-coronary cusp here. That's usually in three-cusp view, CTAP is right upper side. Here, CTAP is between right and left coronary sinus. That is a well-aligned case. For example, in the under cusp overlap view, right and left coronary cusp are overlapped. In this view, Avalot, the head marker is center front, looks like this. But we cannot recognize CPAP because it is crimped. When we see such a scheme, we can easily understand. Eye is here, we can see the head, center front, and 90 degrees apart, there is a CTAP. That is coincide with commissure between right and left coronary sinus. As before implantation, head marker is center front. After implantation under cusp overlap view, C paddle is right side, between right and left coronary cusp. In this case, we can easily get a good coronary angiography. How about commissure alignment in accurate nail 2? Here's post. Post coincide with the site of free cell. Thus, even under crimped condition, this cell is exposed out of the valve frame. Thus, we can recognize the location of the rotation here. So free cell is post site. It is exposed from the valve frame. We can recognize it under fluoroscopy. In three-cusp view, RCCZ is front, then we can see the both sides free cell exposure. In the right-left cusp overlap view, we can see only one free cell on the right side. These two cells are overlapped with valve frame. We also recognize the post site as well as the free cell. Here, in the cusp overlap view, we can see the free cell on the right side with one post right side, two post left side. Thus, when we deploy the valve, we can get such kind of imaging. One post is just right side. That coincides with commissure between right and left overlapped cusp. Two posts are left side that sits in the commissure between right none or left none. This is well-aligned image of accurate nail. And three-cusp view here. How to achieve the commissure alignment using accurate nail system? Step 1, we insert this valve at the 6 o'clock port with 6 o'clock. Then advance the valve in around the aortic annulus. When we see the free cell on the right side, you have to turn the clockwise, or it is appear on the left side, you have to rotate the counterclockwise. Then you can see such kind of imaging. Free cells on both sides. Three posts are evenly distributed under three-cusp view. Then you have to change the projection angle to cusp overlap view. Then you can see the one free cell on the right side. One post on the right side, two posts on the left side. That is well-aligned equinox. Then you can deploy the system. Once again, cusp overlap view, you can see the one free cell here that corresponds to commissure between right and left. One post in the right, that is commissure between right and left sinus. Two posts left side, that sits on the commissures between right none, left none. After deployment, you can see such kind of figure. Even before deployment, we can recognize such kind of free cell and alignment of rotation. Finally, I'd like to introduce the tips of coronary access in patients having avalute TAV because actually there's no problem in coronary access in patients having SAPIEN or acute. The first is perform autography in LAU projection for left coronary artery and right coronary artery. If necessary, left lateral projection may be required for RCA to visualize ostia and desired target cell of avalute frame. May use pigtail catheter to ensure that catheter is within the frame's positioned at the avalute leaflet. Remain within frame, exchange to Judkin left or right catheter, downsize by 0.5 centimeters, as shown here. The frame provides support and allows the use of standard-shaped guided catheters such as JL or JR, which may assist manipulation within the TAV frame. 3. Select concepts of interest with wire, aim for frame waist and cell of interest, and go coaxial. Downsizing may allow more maneuverability within the TAV frame and flexibility to reach coronary ostia. Recommended coronary access zone is the open cells between the narrowest portion of TAV frame waist to the top of the ceiling skirt, node 3. The smallest open cell on core valve avalute TAV can accommodate 10 French catheter. 4. Do not struggle to engage ostium with the first line guide catheter. Move to step 5 to 6 as needed. For small SOB, consider JL3 LCD or AR1. For large SUV, consider AR1, 2, and the multipurpose catheter. Here is the example. 6. If still non-selective, find vessel with wire. Utilize ancillary equipment as needed to rail guide into place. For example, guide extension catheter, balloon support, etc. Guide extensions can be used to provide additional support within coronary anatomy or when the guide catheter is unable to actively engage the coronary ostia. 7. After PCI, disengage, remove the guide catheter cautiously over the guide wire. Always utilize a wire to remove the guide catheter to minimize interaction with the top of the frame cell. Slightly rotate the catheter as retracting can help reduce interaction with the top of the frame cell. Here's two examples. PCI after avalute implantation. RCA is a problem. The angle coaxiality is not good. After balloon, another DS. I use the JL. And RCA ostium is treated like this. It's not impossible, but it's not simple. But SAPIEN is simpler because it is short. Osteum is calcified and stenosed, balloon, and a little bit expanded. The stenting, a little bit better. Before, after. In conclusion, coronary access issue after TAVI, anatomic factors is not modifiable. Thus, we have to pay attention to the procedural factor because it is modifiable by operator. Implantation that commissure alignment is very important, 2 factors. Device factors gets improved. Abler effects with 3 commissure dots, sub and X4 with rotable C marker and dots. We have to pay attention to special tips for coronary cannulation in patients having abler TAVI. Thank you very much for your attention.
I think it was really one of the phenomenal talks I've ever heard on TAVI. Really, Professor Kim, I've heard many of your talks, really. This was the best of all. That's amazing. I think this this explanation is so basic, so nice, should be taught again and again. Really, congratulations. I just one comment. I think, and you will probably agree with me, that TAVR becomes more and more patient-tailored therapy. And the energy we're doing in the alignment and the height of the device implantation, etc., should be according to the patient treated. And just as you said before, an old lady without coronary artery disease, the alignment is much, much less interesting than a young patient with coronary artery disease.
When we decide to retrieve and realign the valve in case of abler defects, there are another factors that we have to consider before decision. If the patients have a really large SOP and high acid junction, and high coronary artery, we don't care about alignment, just release. But such kind of other factors are not so good. We may repeat, recapture, and realign and deploy. There's other unmodified factor, even it is not modifiable, but we have to remember those factors in deciding recapture or just release.
You're absolutely right, but I want to remind you that we have some patients that are giving now the revenge of our insisting implanting the Evolut so high without any reason. So we don't have to think on any patient the same. Some patients can have the Evolut a little lower in order to think of later consequences. But thanks again, wonderful talk, really.
Yeah, thank you.
Thank you.
Thank you, Dr. Kim.
See you in
I'm
really sorry
meeting. It's okay. So we have to finish this session. Thank you for all the participants and the speakers and the moderators. Thank you very much.
Let's move on to the next live demonstration. We have 3 cases. Will be 3 live cases. And the first case will be demonstrated by Zhenxin General Hospital, and the last 2 will be demonstrated by the Zhongshan Hospital affiliated to Fudan University.
So good afternoon. This is the session 5 live demonstration. And we have 2 moderators, myself and Tim Bin Chao from Zhenxin General Hospital, And the one beside me is Dr. Chen Yi-Chen, and he's cardiosurgeon. He's also from our hospital, Zhenxin General Hospital. We also have a moderator, Professor Junbo. He's a very famous cardiologist. He's from Zhongshan Yiyuan, Shanghai, China. So, and also we also have a very excellent experts, Professor Pan Xiangping, and he's from Fuwai Yiyuan, Beijing, China, and also the Professor Mei Ju. He's a surgeon from Xinhua Yiyuan, Shanghai, China, and also Professor Xie Yongquan. He's from Fuwai Yiyuan, Beijing, China. So I think the sequence is a little bit changed. The first case, mitral valve in ring, they has already completed. So they are doing the final part. So probably they will record all the steps, and then we can come back to see all the steps. So firstly, we go to the Zhongshan Yiyuan, Zhongshan Hospital, Professor Wei Lai. Can we go to the Zhongshan Hospital?
我先把把轮贴出来，外往前推，外往前推。
现在是
，compress 不重要。
导播，下面他们已经我听到了，他们已经要直播我们的了。他们第一个台湾的那个说已经做完了，只要。
哦，魏主任你好。
哎，你好，你好 ，Can you hear me？
被你说过了，那你就先演示，我们再来那个，
好的，好的，ladies and gentlemen, this is Wei from Shanghai Zhongshan Hospital. I'm a cardiac surgeon, and this morning I have live demonstrate J-valve transfemoral second generation, and afternoon I will do another live case called the MySource. It's a Shanghai-made transapical mitral replacement system. And now I have finished the epic the preparation, and maybe I can introduce the case first. Okay. Can you see the slides?
Yes, we see the slides. No, we haven't seen the slides. We haven't seen the case slides. Please show the slides.
Okay. 要共享一下。Share the slides, please. Okay, moderators, can you see the slides?
Yes, we saw the slide.
Okay. Thank you. The next page. This is I just mentioned the MySource transapical mitral replacement device. It's a double dual stance. The inner stand is circular, and the outer stand is D-shaped to fit the native mitral annulus, and it has rows of protruding barbs to better fix the native mitral valve, and the delivery system is a 36 French transapical. The leaflet is made by bovine pericardium and have sealing skirts. Okay, that's some markers. And next page. You can see the animation. Okay, transfemoral transapical one, and the guide wire insert into the left atrium, and the skirt first open in the left atrium and pull, then the valve delivery. 下一页。来下一页，先帮我翻下一页。你不能跑掉了。Okay, and today's patient is 82 years old female. The ST score is 16. 15 years ago, the echo diagnosed mitral insufficiency, but not very severe and no obvious symptoms. But now the mitral regurgitation is very severe and have some surgical history. And the next page. The echo. Later, maybe our team member, Dr. Dong, echo physician, will show you the live TEE. And the left atrium is 51. The left ventricle is not so big, so it's dangerous for the LVOT, maybe caused obstruction. And I will show you the CT scan next. The EF is 59. The mitral regurgitation is from A3 and C2, prolapse and rupture of the cord. The VC is 12 millimeter, and the ERA is 0.8. Yes, the mild pulmonary hypertension. Next. Yes, this is the CT scan. We test the parameter of the annulus anterior to leaflet diameter and intercommissural diameter, and the parameter, the average parameter of the annulus is 124. So according to the oversize, we plan 10 to 15% oversize. So we decide to choose mitral 47. The mitral 47, the parameter is 140, correct? 140. Okay, next. This is another very important LVOT, near LVOT. You know that the most dangerous result for the TMA procedure is the obstruction of near LVOT. And this patient maybe it has some danger, because we test that the end systolic period near LVOT is only 120, and the end diastolic is safe. It's more than 300. Before this case, I have performed. This is the 21 case for mitral to cure mitral insufficiency, but this case is the most dangerous one. Last month, I have performed patient near LVOT is 148. The patient is safe, and but it's the first time I have only 120. Next. This is the angle we planned before operation. The deploy angle shows that we must choose RAO 27 and the CRA 37. Okay. Next, we have next page. No, okay. Okay, thank you. This is my introduction, and I have placed the pacemaker from the left femoral vein, and then I cut the chest in the fifth intercostal space, a very small incision, about 4 to 5 centimeter, and make a punction now. And do you have any question about the case or about the system, the device?
Professor Wei.
Yes.
So the anterior leaflet is prolapsed. Is there any coda rupture in the anterior leaflet?
Oh, rupture? No,
yes.
no.
No. Dr. Dong, can you show the TEE 那个导播把超声图像切到现在的这主要画面上。
OK。
好了吗？切过去了吗？好了，可以了。Dr. Dong。
Okay.
好的，好，你先打角度。
Today we have a patient, an older female.
先打一个
We have anterior leaflet prolapse, no rupture cord, and a severe mitral regurgitation, no stenosis. This view show us the A3 area, anterior leaflet prolapse, and a severe eccentric mitral regurgitation. This is the only one we have. We have a VC about 8 millimeter. And no undertrace aortic regurgitation. We have a dilated left atrium and a normal left ventricle. Yeah. Okay, thank you so much for this.
Okay, thank
for
you.
echo.
Professor Wei, I thought that the mitral system, the anchoring will be the hook on the stent, right?
Yes. There are two lines of hooks.
Yes. So if the leaflet are prolapsed, are the hook secure? Will be the device secured when you deploy it?
Sorry, pardon?
他说你可以治疗那个
When
prolapse
when the leaflet is prolapsed and then it's not stable, when you deploy the device, the mitral, the hook will the whole device stable on the annulus, will not rocking up and down?
Yes. It will fix the leaflet, and the leaflet cannot move up and down. Yes.
The stent is stable.
The stent is stable. The stent is stable.
Okay. So the risk of the embolization of the device is very low?
Yes. No patient. In China, we altogether performed about 30, and no patient have the valve embolized.
Okay. So what is the profile of the device? The sheath
Sheath is 36.
36. Well, that's quite big. Huh?
Yes, quite big. Yeah. Mm-hmm.
Okay. Can you proceed your procedure?
Yes. I puncture the epic. 好，来拆线。
主动脉啊，主动脉。
然后有没有先进猪尾巴？
So Professor, according to the measurement, the neo LVOT is around 120. It's the borderline case of the risk of LVOT obstruction after the procedure. So if it happens, what will you do?
Yes, if happened, I should open the chest to do the surgery.
How about do the arc operation of the septum? Is it?
Yes, I have not do that before, so I don't have the experience to do the ablation. But I know that there's some case that have reported, but I don't have the experience. So as a cardiac surgeon, I think maybe open the chest and replace or repair the mitral valve, maybe it's most
主动脉
safety choice.
要屁一点。
我们先来做个导引，准备好啊。不对，这个是你是进个导丝啥？我不用进导丝，我不需要进导丝。我看到在超声下面，我以为是看到导丝这个圈圈的啊。就放这个扶好，接导引机。已经下过肝素了吧 ？ACT 多少 ？OK，ACT 是 more than 400。来放大一点，食道超声往后拔一点点。
好的，拔了。
来超声，超声你就看不见了是吧？
我拔过了。
那你还是进来吧，我还是要看着这个猪尾巴的圈圈在哪里。
哦。 圆圈在1。
现在在哪里啊？
在主动脉，主动脉。
主动脉去了。哎，这个左心室确实是不大。好，这个在半下了，对吧？
对，这个是。
这个在2点半下。那个是偏前半了，所以我要往后半去一点。啊，大概这个位置好扶好。杨烨把它放到中央去。我现在猪尾巴是在左心室的中段了已经。再往这边来一点，对，再往我这边，对，再放大一圈，看看行不行？哦，太大啊，小一点，好吧，来，我们来准备造影，啊，好，可以了。
It's very
yes,
yeah, very severe.
Yes, very severe MR。对，来侧线，在这吧，侧线，我现在准备要立体，我要跨半了，我就直接准备用猪尾巴跨半，好吧？
可以的，那P一点，要P一点，朝P的方向去。
过去了。
这是3。
没过去对吧？I use the pigtail to cross the mitral valve。
P 一点，要P一点，1、2、3不动。
You don't use wire.
Yes。
过了，没有3还是3？
没过是吧？Usually I use wire, but I think this patient the regurgitation is very severe, so I think maybe it makes simpler.
现在对
，close
过了，
好。OK，侧压管有了吧？侧压管，我 test the pressure of left atrium， 给个注射器给我。看一下左房压啊，来排气，已经对过0了吗？现在不是很高啊，现在血压多少？90多啊，血压不高。来看看左房压多少。The pressure of left atrium, is high. Okay. Okay, you can see the yellow line. The left atrium pressure is 48, and the average one is 28. So it's high.
Yeah,
very high. Yes. I guess after the implantation, I wish the pressure will decrease from the 50 to 30 or 25. Okay. Then we will use the super stiff wire.
So you have inserted a temporal pacemaker. So when deploy the valve, you need the rapid pacing.
Yes. Okay. 在这吗？想想啊。好，走。来，我们把角度打过来。角度，the angle will be the 27, RAO 27 and CRA 37.
So this device can be used in failed prosthetic valve. Can it use it?
No. If it's a V mitral, I use SAPIEN.
Okay.
Because this valve is not designed for the mitral, for the valve-in-valve surgical valve. It's the outer stand is relatively big. The smallest one is 29, and 29, 33, 37, 41, 43, 45, 40, 47, and 51. Okay, 你再找过来一点，对，稍微拉高一点。那把床放低一点，床放低一点。
How about the rate of paravalvular leak?
Seldom leak. Only one case. I have done 21. This is my 21 case, and only one case have mild to moderate leak, and after 7 months later, increased to moderate to severe, and I opened him and to do the repair. Not take. I didn't take out the muscles, and I only to repair the leak, and the other 20, no leak at all.
No, that's very good result.
Yes.再来一点 ，OK。我们再来做一次造影，我们直接从这个鞘里面做一点造影。哎，那个谁进来吧，你进来，哎，我们直接通过这个鞘做一次造影，哎，符号鞘，啊，符号导丝，对，你接好了是吧？我再看一眼这个鞘头的位置，紧身一点点，这个好像往后退一点，这个还能再往下压一点吗？低头压一点，对 ，OK， 来再先。来，我们看到那个有点钙化，可能是回旋枝的位置啊。我们基本上就在这个位置了。来，造影。OK， 可以，蛮好。它可能不是回旋，它可能是，好像就是回旋枝啊，有点钙化的啊。There are some calcification, maybe the L6 maybe. So it's another marker for us to give the position, the right position. Yes. And now, yes, and now we will take out the sheet and insert the muscles. Okay, 准备好了吗 ？Okay.
So what is the wire? What is the guide wire you use?
Use. I use guide wire. 哎，准备好收一点荷包。
Wire?
It's a super stiff, Boston Scientific, and Plaza super stiff. And the guide wire only help us to deliver the system into the left atrium. And then when I open the valve, I don't see the flow anymore. I will see the echo. 好，正好退一点，看。
So so you use echo guide to deploy the valve?
Yes. Okay, the 36 one, insert into the epic. 好，准备收啊，我准备进去了。好了 ，OK。
左房啊。
现在进左房了，对吧？现在不在中央啊。
不在中央。
OK， 我们现在是偏前半了，对吧？
偏 A
我要往后半去一点。
A 偏3啊。
那个小黄，把那个屏幕再稍微转一点，稍微转过来一点。对，再来一点。好的，可以了。现在我是偏前半，偏3区，对吧？
对。
我要往2区去一点，往后半去一点，好吧？
可以。
这个基本上到中央了啊。
可以。
Yes, we will make the system in the central of the mitral annulus. Okay. Then we will turn the system because there are some marker. Can you see if your screen is big? You can see 3 markers on the valve, and one marker is like 8. Okay, I will put this marker in the central of the system. Okay, 哎，踩线，反了。Okay, like this. Okay, like this. And then this is our the P2 of the artificial mitral valve system. Okay, 现在你觉得我在中央了吗？你给个3维，看看。好，现在不用踩线了，我现在就看超声了。现在还是偏前半，对吧？
对。
偏前偏3。
是的。
我再往2和后去一点，好吧？
2可以再后一点。
还要再后一点。
对。
这位置可以吗？
可以
把声音关掉，把手机关掉。你们谁的？
这个位置可以，就是还是可以再后一点。
还要再后一点。
哎，好的。这个位置又散了一点点。
好，这个位置可以。
这里很好，
这里可以啊。
对，这里很好。
好，来再踩一脚线，我再看看。
魏教授，
看看我有没有旋转掉。
你这个整个 device 需要在整个瓣膜的正中间吗？还是就是在偏后面？
我们是需要在正中间，当然它有一定的容忍度。你真的不是在中间的话，那么瓣膜这个要打开了以后，它也会自动会被推到中央去。但是我们还是希望从一开始就尽可能的做到正中间。另外，如果你实在是做不到正中间，待会儿这个拉那个，因为它在左方面，会把上面的那个散盘先打开，慢慢往回拉，也能够将来会回到正中间。但是我们还是希望尽可能的在一开始能够做到同轴性是最好的一个状态。好，那我们现在就准备要在左方面要开花了。So we will release the system step by step. 先开花了啊，先给个
给个。
好，对。好，我现在旋转。哦，里面有气泡。Some bubbles. Okay, okay. I will wait a second to let the bubble disappear. 我首先再打开一点，
可以，
让它的 bubble 再跑得快一点。
所以魏教授，当你在 deploy 的时候，你是用3D 来看它这个 deploy， 还是用 2D 在看 echo？
我现在是用的是3D， 但是待会儿我要看高度的时候，只能通过 2D。现在我只是大概看一看它是不是同轴性在瓣膜的最中央，所以这个时候用3D 是比较直观。但如果要看真正的瓣膜要打开了以后，要拉的高度是高了一点，还是要更拉得重一些，这个就只能看 2D 了。好，我现在觉得气泡差不多了，来彩线，我再看一下我的旋转，那要反复确认旋转。好的 ，OK。好，我现在好，现在已经上面的那个
还有哈，
胆盘已经打开了。哦，还有气泡，你们今天这个气没有排好啊。
air bubbles，
我们把这个去掉吧，把这个去掉，拿掉，转掉。好，我们给一下2D。
2D。
Yes, you can see 2D。
Yeah。
我现在继续打开，好吧？
好。
So can this device can be retrievable, reshippable?
Yes, if it's a half retrievable. Now I can retrieve now.
Okay.
If I think it's dangerous and I can retrieve, but you can see the marker, the dot, just on the tip of the sheet. There is a relatively big dot. If the sheet is open down the marker, I cannot retrieve again.
OK，
好，现在我觉得差不多了啊。我慢慢往回拉，准备好起搏器，小黄拿好起搏器。丽丽，你觉得我现在这个位置还需要怎么调整一下吗？
你的位置是可以的，就是有一个倾角，就是有一个角度。
就是靠前半后半的问题，对吧？
对，就是前半后半这里。
前半有点高，那个位置，对吧？
有点横角，是的。
这左右1、2、3还行。
1、2、3还蛮好的。
好，你准备好起搏器，我慢慢往回拉了啊。160，待会儿好吧？好，我现在慢慢往回拉，我已经拉上去了，我已经有一点手感了，我继续拉。好，来快速起搏160。Pacing。
碰到半叶了，你注意后叶快要。
你觉得后叶不够是吧？
我觉得后叶不够，就是后叶这里。
我已经感觉拉上去了。
前后差不多了。
左右呢？
左右的话，这个位置好像看上去还可以再靠一靠。
现在好了吧？
好了，可以。
好，那我就放了啊。
好的，好的。
没问题，我就放了啊。
可以，
好的。
可以。
看起来 anchor 的不错。
好，来，先踩着是吧？好的，起搏关。哦，今天这个 bubble， 来把起搏器打开，开了80次。来哦，你在好踩线。好，我现在已经把 release 掉了。好，导丝稍微往里进一点点。好，这你不服，你不服。
来看一看啊。
血压怎么样？
我现在合拢 ，close the sheath， 准备收荷包。准备好了吗？啊，我出来了啊。好，出来了。那走。第二个荷包也收起来。好，丽丽看看，现在血压有点低。
那 LVOT 是不是？That LVOT seem to be quite。
是啊，就是 LVOT 的问题。
是有一点。
LVOT 好像是有点问题啊。
是的。
我们把血压稍微提高一点，用去甲，不要用那个，不要用肾上腺素。
48。
丽丽，你测测看 LVOT。
峰值48。
多少？有峰值有40。
40。
volume 是不是不太够？因为这个
我们再给点容量啊。
对，
我们再给点容量。
把 LV 撑起来的话，大概这个轨点可以下降一点。
leak 倒没有什么 leak 啊。
Mitral 是没有问题。
靠1的地方好像。稍微高一点点，就是靠1的地方略高一点。
因为我们现在看这个角度，看上去它确实是 LVOT 小，但它是一个新月形的这么一个结构，所以有的时候从一个角度看上去，并不是它真正的 LVOT 的这个真实的面积。但是我们还是待会儿我们再测个压差，我们待会儿再测一个主动脉的压差，就是跨 LVOT 的压差。好，现在血压上来了，丽丽，你觉得现在怎么样？压差多少？
差不多。
来，我们先进一个猪尾巴进去。啊，你先细子可以。啊，走，啊，辅助细子。来，侧线。好，辅助导丝，看。我们进一个猪尾巴。好，现在血压100几了。我们容量要补足一点啊。哦，哎，你出来了，大哥，你出来了。
这个病人 LV chamber 好像也比较小一点哈。
是，他的左心室只有50几的，来踩线。好，来往后拔一点导丝，我们看一下左房压。好，拔掉。好的。好，我们来测一下左房压。啊，不用收太厉害，收太厉害反而，那你抽一抽。我们看一下左房压多高。好，来接。来排个气左房压。好。好，来，我们先来看一下。哦，这个左房压，哦，左房压高啊。啊，不是哦，这可能出来了，来踩线，可能跑到左心室去了。我抬高一点，不，它因为它有侧孔，它在左心室里面。啊，这个是左房压。
左房压50几。
好，左方向30几啊，34，基本稳定在34。好，我们再来做一次左心室造影。来，彩线，我们退回来，来断开，把这个断开，做一个左心室造影，血压有点低啊。来，我们先做一次左心室造影，直接造。
看起来不错啊，
位置是不错的，现在的这个问题就是 LVOT 的问题啊，我们先把这个先退出来，今天先退出来 ，LVOT 的事情我们慢慢评估来，好，来把机器先回位，先来把心尖处理一下，当心他的脚，好走。来，剪线准备好，剪刀，剪，给我，好，来打个结，你来打结，好，我加住了，好 ，OK。丽丽，你现在觉得压差多少？你来压住它。
看50、60，都是小的。
这个有50啊？
有。
就是你觉得压差还是有50是吧？
我觉得压差大。
哦，今天这个压差是高了。所以他心尖他容易出血，压差高。
是。
压差高。是，来给我纱布来，纱布。
现在左心室不太行，看。
行，一下。
对，
好，你先出来，你人先出来。
左心室不大跳了。
好，杨毅，你先把机器先移走，对。我们把心尖这个血线处。
你们慢慢做，那我们
好的，
先到别的 room 去哈，你们慢慢做哈，不要紧张。
好的待会儿有什么情况，我们再跟大家再汇报啊。
OK， 祝你们成功哈，
谢谢。
好的，把灯光打开，灯光打。
Okay, we let Professor Wei to deal with this patient and to stabilize the patient. We move to next case. We are going to also the Zhongshan Hospital. Professor Dr.Junbo.
葛院长。
葛院长你好，有听到吗？
听到那个葛院士今天不在，他正好有个会议哈。我是周主任也在南方会，我是张小春医生。
好，张教授你好。
你好。
你好。
那个是转到我们这边了吗？
对。
好的，那首先我这个非常高兴来这个参加台湾的这个瓣膜的高峰论坛哈。还有呢，就是我首先简单介绍一下我们今天参与的我们团队的一些医生。这边呢是我们的新超的潘翠珍潘老师潘主任，还有我们新超团队的孔德宏教授，然后呢还有我们这边有这个我们摄像头，我们团队的陈莎莎医生，以及我们麻醉老师，还有我们的护士团队哈。好的，那我下一步我先来给大家介绍一下我们的这个病例一些情况，请打开我们的这个病史资料哈。这是一个77岁的老年女性啊，是个瘦小的老太太，有高血压，然后呢有一个阵发性的频发的一个湿早。是一个长程的持续性的房颤，病史呢有12年，然后呢还伴有一个Hyo-Soo支传导阻滞，以前是有一个 COPD 的病史，肺功能呢不是特别好，但平时呢需要用一些雾化的药物，肾功能也有一些问题 ，eGFR 大概在40左右，是一个这个房颤相关的一个严重的3尖瓣反流， 在心超来看呢，还有一个轻度的二尖瓣反流以及轻度的肺瓣的一个反流。从评分来讲呢，他还是一个中高危的一个手术风险的一个病人。下一页。那这是我们术前的对他的一个测量，我们测出来的一个平均的一个VCW 呢是11×8个毫米，EROI 的一个披萨法测的一个反流的这个面积呢大概在0.49，然后我们平均的这个瓣环直径呢是41个毫米，栓系不严重哈。右室呢是一个基底段的一个轻度的一个扩大，右心的功能的指数呢，TAPS 还有 FSC 呢都是正常的，左心的功能也是好的，二尖瓣轻度反流，EF 值呢是60，肺动脉的收缩压呢是这个心超估测呢是43，从我们临床研究入组的这个标准来看是小于55个毫米汞柱。好，下一页。这是我们在术前的一些不同角度的一个评估。最上面这2张图呢是我们的四相亲的一个切面，就是我们在后隔的一个反流，这个反流的测量的这个反流井呢，反流数呢是有大概后隔在4个毫米左右，然后在前隔，这是中间一排呢是我们的一个类似于一个流入流出道的一个 commercial 的一个切面，我们是前半跟我们靠近我们的是前半跟后半，然后隔半呢是在中间对面的地方，它的反流呢还是一个混合性的瓣釉，在前隔、在后隔以及在3个瓣叶的中央有一个比较大的一个反流的状况。然后最下面的图呢是我们的一个短轴的切面，就是我们类似于我们的这个外科视角，从我们房侧来看呢，它还是偏向隔侧，再从前隔到后隔之间都有一个广泛的反流，并且在3个瓣叶的中央也有，所以这是在我们这个中国呢比较常见的这种房颤相关的三尖瓣反流的这类病人的一个特点，就是反流呢是多处，第二个呢多处在中央，随着瓣环的扩大它有多处反流，而且呢它是右心室的功能呢多数还是不错的，所以这是我们心超的这个一些术前的评估。再往下一页，我们 CT 呢还会再去评估它的一些这个瓣环的周长，以及前瓣环、后瓣环以及隔瓣环的这个它的一个长度。那这个决定了我们需要用多大的夹子。一般来说，我们有12、14、16、18，开 clip 呢有这么多4、5个类型的这个夹子。如果是14毫米的夹子呢，它2个臂张开，它能覆盖的范围呢是一般来说是28个毫米左右，所以我们术前呢会做这样的一个评估。那当然也会去测量右冠跟瓣环之间的这么一个距离。那右冠离瓣环呢，我们要求呢就是至少要有3个毫米以上是最安全。当然也得看它右冠呢是跟我们的3尖瓣环是不是在一个平面，如果在一个平面它的风险性就高一些，如果不在一个平面，那我们这个距离呢稍微短一点，我们也是能够接受的。那在下一页，这是我们的一个策略，往倒数第2页，往回一页。那我们可能对于这样一个再下一页，就是对于这样的一个病例，我们可能会是在后隔的位置以及在前后交接的位置，因为我们从超声也好，从 CT 也好，我们可以看出它的扩张呢还是从前瓣到后瓣的一个整体的一个扩张。当然它的从超声来看，瓣叶的质量还是不错的， 然后呢，它还是有部分呢是有一些对合的。那这个是我们做半环成型，对于我们这类病人的解剖影像，它的一些要求，所以也是这个病人的一些情况。好的，主持人。
教授，你们这个 K clip 它这个 screw 它的深度是锁下去多深？
锁下去是4个毫米。
锁下去4个毫米。
是4个毫米。
它有特殊的位置可以锁吗？还是说只要是在这个半环上面都可以锁上去？还是说是在交界的地方才能锁？
它只要是在半环的任意一个位置都可以锁。它有一个保护机制，就是你超过4个毫米就拧不下去了，有点像我们的电极起搏电极，你就不可以一直往下去这个铆定我们的半环。当然你在半环的任何位置它都可以去铆定住的。
那我们知道说，在2间半的话，这个半环是比较明显；3间半的话，它的半环的这个影像，或者是说它实际上它不是很明显的一个半环在那边。当我们在锁这个铆钉的时候，它会不会没有锁到这个半环的部分？
对，这是一个很好的问题，因为3间半环呢，它的显微基数呢非常的少，它不像2间半环，所以呢，我们在超声影像上呢，就特别难判断如何来判断哪里是半环。那我们这就需要从三维来看，它有一个稍微凸起来的地方。第二个呢，我们从2维来看，就是在半叶、冠脉、右冠以及它半根的那个角有一些半根组织的这个肌肉的这个角连的这个地方，我们一定要是在凸起的地方，那就是我们的半环。所以这是我们从超声上来去判断，因为手术过程中来判断半环的位置，多数是靠超声影像了。所以我们一般从2维、3维这样去判断。一会儿我们也可以给大家来看一看我们如何来定位我们的半环的位置。当然你螺丝攻进去半环之后呢，我们的这个夹质开 clip 的夹质呢打开之后，我们从3维立体的角度还可以来判断你这个夹质打开跟你的弓的位置，那对于跟半环是不是都在一个平面上。那如果3者都在一个平面上，那我们就可以确定这是我们的半环。
那假如说这个螺丝不是锁在半环上，是锁在这个肌肉的部分，它这个夹子还可以夹吗？还是就一定要再重新锁到这半环上？
它是可以夹的，但是呢，这个里面如果你是偏房侧的位置，你夹的时候呢，我们通过 DSI 造影，你就会发现冠脉受影响的程度就比较大。因为我们往往右冠的位置呢是在半环的偏房侧一点点的位置。那当然你夹子是可以收，但是你的效果呢就会差一点。螺丝可回收。
教授，让您来演示一下这个手术。
好的，那我们来这个大家看不看到我们这个系统哈？先那个摄影师帮我把这个探头呢对着我们的这个操作系统。我们是一个经右侧的颈外静脉入的这么一个这个系统，因为从这个系统下去呢，它就是对着我们的半环。从后格的范围到前后交界的范围都在我们这个可调弯的控制范围之内，所以从颈静脉下去呢，对于我们半环成型它是非常友好的。那对于我们的原队员可能从股静脉上来，对于前格位置它可能更友好一些。然后我们的这个系统呢有一个固定架，然后有一个外鞘的外径呢是18个 F。所以基本上我们的股静脉只要穿刺，然后呢这个皮肤呢稍微做一点小的切开，那我们这个鞘呢就可以直接进这个颈内静脉了，所以它的创伤非常小。第二个呢就是一般来说它的止血也好，我们操作也好，它的张力也好，我们从颈静脉下去基本上它是对着后半环的，我们只要调一点点的角度。 所以这是我们的一个系统哈。您讲。
基本上成一直线呐，所以
是的，
上应该是蛮方便的。
是。好了，然后我们在这个手术的时候呢，我们会第一步呢会是要测量他的肺动脉压力，因为有一些严重的三尖瓣反流的病人，他的肺动脉的压力跟心超呢测量会有一些误差。对于右心功能极差的病人，他会出现一些这个低估我们的这个情况，就是我们肺压的情况，所以我们要保证肺动脉压力，在我们导管来测它的收缩压也不要超过55。所以第一步我们要测量右心导管右房压、右室压，然后呢，我们要做一个右冠的冠脉造影，我们要看它的右冠的冠脉造影。大家都知道半环成型的右冠呢非常接近，最早期 cardio bond 也好，咱们在做的时候呢，就有一些冠脉受影响的情况，所以我们就会做一个这样的一个造影。那这个造影呢，就是把我们的右冠，能放一放吗，莎莎？
老师，你过来一下，把我的耳机给莎莎。
冠脉造影一开始的初始的冠脉造影 ，OK。
好，另一个体位。
一开始的
三尖瓣的瓣，这个瓣也
好，这是偏头位，然后看一下左前斜的那个冠脉造影。
对，这是我们的头位的右冠的造影，然后我们还要再做一个左前斜的，左前斜呢，我们相当于
冠脉造影
这个三尖瓣环的一个横切面，就是它的一个最展开的一个切面，一般我们都会从术前 CT 上来判断。所以我们从这个上面就可以看得到，我们这个前后交界一般都在第二锐缘支，然后呢后三叉在偏后一些的位置呢，在就是我们的后隔交界的位置，所以我们会有一个导丝放在右冠，我们来判断，我们在手术过程中来判断你对我们的右冠有没有影响。第二个呢，也会来判断我们这个螺丝弓的位置是不是就是在瓣环上。那通过这两，然后我们还第三个呢，也是跟心超来 check 一下，你是不是我们螺丝弓的位置是跟我们超声要去到的那个位置呢是一致的。好，那我们就这个往下，然后我们请潘翠珍主任呢把那个之前我们超声的影像放一放，就是我们一开始，潘老师，我们那个一开始从大鞘进去哈。我们大鞘进去 ，OK。
好的，各位专家，那个下午好，我把刚才我们做的大鞘，这个是一个90度3心房切面，然后我们的大鞘是指向后隔的。这里是3维我们显示的一个，就是它的那个输送系统定向那个后隔交界处，然后我们就，同时我们也可以用血流看看这个输送系统是不是在后隔交界的那个反流最多的地方，然后我们就调整这个输送系统，调整好了以后。因为觉得这个位置对的，然后我们在这里再可以
的那个 DSA，
然后这个地方我们就看到这个输送系统就是已经要贴近瓣环，在后隔交界。
主要走起来。
好，然后我们就是说它位置，假如那个输送系统的位置顶到这个正确的位置，我们就用 multi-view 那个3切面。MPUR 切面，我们就来定这个公路的螺丝公路以后，我们看这个位置是不是在正确的位置。所以这是我们已经公路以后，然后做牵拉动作的图像。这个很好，就是在瓣环的瓣根的位置。然后同时我们3维也可以看到3切面。 封好以后，然后就是后面就是进行那个，这里也更清楚，这里都是，好。这个时候就打开夹合臂，然后要调整夹合臂的方向，要跟半环的期限要平行。所以这个时候我们用3维来调整夹合臂的方向，就慢慢调整。好，调整好了以后，我们可以看到这个图像基本上跟半环的期限是平行的。那么这个夹合臂就可以踢进这个半环进行夹合。这里就是在慢慢踢进半环，然后夹合的图像，这是夹合以后，这是夹合了以后的夹合臂的2个夹合臂，我们可以看到很清楚它是对称的。那么这个半环的周长，我们测了一下，缩小了大概1.3公分。然后我们就再看一下这个彩色，但是因为这个病人就是他是一个前隔、后隔加前后交界都有反流的，所以呢，就夹合以后，我们实际上前后的地方、前隔的地方，我们还是看到有反流。这是我们刚就是缩前的时候，我们半环周长是11.6，那么现在是10.0，所以减少了1.6。
好的，
超声汇报就到这里啊，谢谢。
好的，我们再切回 DSI， 因为我们第一个夹子呢，去到的位置在后隔，一般后隔呢，它会靠近冠状静脉窦，那这一块呢，对于我们的夹合的它的效力呢就会差一些，因为在后隔位置，冠状静脉窦跟半环呢，它在半环的边上就是冠状静脉窦的开口，那这一段呢就特别的软，所以它的这个收半环的效力呢就会低一点。但是这个位置呢，因为对于我们固定我们要收缩前半跟后半呢，它起一个支点作用。所以我们第一个夹子还是会放在后隔的位置，把它这个软的地方呢先夹住，夹住之后我们再去到第二个夹子呢，我们会在前后交界的位置，这个时候再收紧我们的半环呢，它对于整个半环的收紧，尤其是扩大的前后半呢半环呢，它相对的这个作用呢就会大一点。所以这是我们术前的一个策略。当然我们现在回过头来看呢，因为今天呢是前面的未来教授在杂交手术室，所以我们这个用的普通的手术室的这个导管室的这个房间呢，图像呢就小一些。但仔细来看呢，第一个夹子呢还是偏防了一点点，并不是特别正的一个半环的位置。那我们对于这种病例呢，我们一般来说不去多操作，因为你螺丝把夹子再打开，螺丝再反复拧出来，它可能螺丝上呢就会有一些半环的组织，对我们半环是一个损伤。当然我们从 DSI 来看呢，它对冠脉的影响呢很小，冠脉呢会有一些受牵拉的扭曲，所以我们能接受的情况下呢，我们就把这个第一个夹子释放了，释放完了我们复查冠脉造影都是好的。所以我们现在开始呢，就是我们要去第二个夹子，第二个夹子我们要去到的位置呢是在前后交界的位置。那我们切到这个影像的图像哈。
为什么今天怎么会变掉了呢？图像怎么？
张教授，那个我们医院卫生卫院长在几年前他有发表过一篇文章，是有关右冠状动脉跟这个3间半距离。它实际上我们是用移植的心脏取下来之后，把它解剖开来去看这个半环3间半环跟这个冠状动脉的距离，这个您可以搜寻一下，可以做一些参考。
我来打好了。
好的。
院长有发表出来。
是，我们其实也很关注这一块。 我们一般都要先做一个之前的筛查，它每个人的距离其实是不太一样的啊，
对，是
有的比较短，
但是大部分大概是距离这个半环的位置大概有将近快1公分左右。
好，那我们主要是要看我们在夹合的位置。那一般来说呢，在后半的终点，它的位置是最近的。你到前半的位置或者到隔半远端的位置，它的距离就非常远。
对，
就非常远，所以它的
我们当初的结果差不多。
是，它所以那个距离特别远的位置呢，是在前半的起始段，它有1公分多，但是到了我们一般来说夹子，我们开 clip 要工作的位置，一般都是在后半跟前后交界的位置，这一段距离就相对要近一点点。
好嘞的。刚刚挺好的。
好 ，OK， 现在我们现在第2个夹子呢，我们已经大体上的位置调好了，我们现在来要看它的，就是我们要攻螺丝了，就是在这个角度哈。
对，这个好像有点，我来看啊。
判断那个，您看我这个夹子是不是离半环的位置是比较远的？
对，比较远。
稍远，对的，稍远。
那我要贴近一点。
好。
太远呢，就会影响到我在攻螺丝过程中的稳定性哈。
确实对。
现在这个距离您觉得怎么样？近一点吗？
近一点了啊。
近一点啊。
对的。
好。
搿点可以看。
潘老师，您那个。
现在看上平面是吧？这上平面好的。
对。
上平面要打出来。对。好。就更清楚一点。
这个前后交界不是特别清楚。不是特别清楚的。那这里还是有的时候呢，食道大家都知道，对于3尖瓣呢，食道是一个非常远的位置，所以有的时候呢，对于后瓣或者后隔呢，它相对还是比较容易切到很清楚的2维的切面。但是对于前半前后交界的位置呢，有的时候呢，食道超声呢就不是那么清楚，就是你既要显示我们的半环的根部位置、根部的图像，又要显示我们的系统的一个长轴，有的时候呢就不是那么清楚。那最前后交界呢，可能是更靠胸骨，所以我们有的时候会用经胸的超声探头来找啊。那我们先试试我们的。
等一下，我能打清楚。这好像，你到3维再看看，好吧？到3维再看看，这个头应该显示对的。对，3维再看一下对不对？对吧？
来，我是把超声机器往那边推。
我看到了，我看得到了。
我也正好要看，就是往那边推一点。哎，对。安老师也看到，我也看到，对，我们的那个会场也看得到。
对的，好，你看啊，这里是，对，我觉得这个是，
我觉得位置还是挺好的，从3维来看。
对呀。
对吧？它就是很难切到你的这个。
看得清楚啊。
感觉是靠近半环了。
是，感觉靠近半环哈。
好了。
我们再往半环去近一点，好吗？
好的，好，再往前一点。
再往前一点，您看2个夹子，我需要保持一定的距离，因为我一个夹壁是4个毫米，您这样去量，我第1个夹子离这个夹子的距离至少要有14个毫米哈。
超过14
是没问题的。OK。那从3D 来看呢，我的方向应该是对着半环的方向啊。
就有，对，这转过去看看啊，对的吗？
对的
啊，对的。
好，那这个时候您看是要切到2维。
张教授，您再慢慢做一下，我们先切到另外一个房间去，好不好？
好的，好。
过来看您的结果。
好的，好。
先折一点。
好，那我们转到振兴医院的导管室。孕妇，你能听到吗？孕妇，好。
曹主任，你们有看到我的？
有。
哎，那个
你们
slide一下。
啊，对。
那我们这个是今天的最后一个 live， 然后也是今大会的最后一个 live。哦 ，This is a failed mitral repair. Next， 下一张。太多了，回去，再回去。好，64 years old male. He got leg edema and dyspnea on exertion for 3 months. He refused surgical intervention anymore because he was noted as a failed mitral valve. He had a comorbidity of hypertension, and that in the index surgery is 8-valve PCO2 30 millimeter valve, the PCO2 rim in 2014. STSP-RM was 4, and the case Pirelli score was 0. Next. Here we can see regurgitation more than just into the posterior, and that's the severe vegetation. It's in further analysis, it should be P3 tear at the repair site. Next. So the app is 30 millimeter, PCO2 is 471 area, and that's is 2926 borderline valve. In our CT measurement, its area is around 560. The septum length was 50, and the LA size was 500. It's quite huge because of mitral regurgitation. And the puncture size for this case, I think it's quite safe because at least for 40 millimeter. Next. Outer mitral angle is 140, and the neo LVOT is 206. However, you can see here the stroke to septum is quite short, and even the stent touch to the annulus. And this is a simulation for 29. So we decide to use 26, and the LVOT should be larger, and the implantation depth is 4. Next. So that's we initially attempt to use a 29 millimeter S3. However, because of neo LVOT, so we decide to use 26 8-valve SAPIEN 3, and also we plan to do Noppon procedure in this case, and use a 0.14 acetate wire, and the left common femoral vein for pacing. Now we move to the imaging. Sydney, please. That's initially we implant the Sentinel brain protection device, and then we puncture the inferior lobe septum. Here we can see that the Agilis, the SL1 and the BRK was down to the middle of ring area, and it's a correct side. After check the position and the tenting for the valve, so that we puncture that. Next. We change to the Agilis and then cross to the LV. Next. Then the Terumo wire curve into the outer. Cross to the aorta, and another snare was the stemma in the descending aorta. Next. So you can see here the loop, the snare loop was in the descending aorta, and we try maybe a couple times, and finally we capture the wire. Now the wire was internalized by the snare. So that you can see here the 300 centimeter Terumo wire was internalized, and then we use a 6-French guiding caster for the rendezvous procedure. So here you can see the two guiding caster was rendezvous. One is 6 French and the one is 7 French. So we can insert the acetate wire through the Redo catheter and the wire was internalized. Next. Then in this is a key point. Please show we pull up the wire echocardiography.
Okay.
So when we pull the catheter and the wire at the same time, we can see the A2 was pulled up by the catheter and the wire. So it is the correct side for the catheter and the wire. So that's the 7 French guiding catheter was into the LV. And this time you can check the pressure from the femoral artery catheter, and it should be the LV pressure, and withdraw the arteries and the guiding catheter from the LA side, and pull up the wire. Next. So here we start cutting the anterior mitral leaflet. Please show the anterior mitral leaflet.
Okay. You mean after the lap?
No, not just immediate. Do you recall the
during the
Lapun?
Yeah.
Yeah. It is one, right?
You mean after the lampoon?
Oh, that's just during the Lapun.
During only
no.
this ones.
Okay.
Sorry.
Okay. So when we do the Lapun, a lot of the debris evaporized, such as white red blood cell or some tissue. So you can see some limited tissue was pulled up, and then we check the echocardiography for the result of the Lapun procedure. So you can see here quite severe mitral regurgitation was noted, and you need to do quickly because the MR becomes so severe. Next.
It's a very successful Lapun procedure.
Yeah, should be.
MR became more severe.
Do you use the 3D echocardiography 3D for the Lapun?
Please. So,
Dr. Chao, do you see the image, the cut anterior related? Because
you can see it.
Yeah, quite successful for the Lapun procedure. So then we change the catheter, the wire and the catheter to the extra stiff, the subary wire. Next.
Dr. Lee, when we do the Lapun procedure, the cut of the anterior leaflet, you cut till the base of the anterior leaflet, or how do you evaluate how deep you will cut the?
It's protected by the mitral rim. So we do not worry about we cut any other way. So it's called a tip to base. So you cut all the way to the base. Don't worry about the midway or just a basilica from the middle of the leaflet. We just cut the whole leaflet.
The important thing is to protect the aortic valve.
Yes. Always watch the pressure from the aorta side catheter, because it should be kept in the ventricular pressure. If you have any doubt, just stop the cutting. Next. So let's stop here. And you can see we do the subary wire in reverse position, because we shaped in the middle of the subary wire. It's recommended by Binibata, and he said that the small curve can more go into the LV apex more, so that it's more control for the mitral valve involved or mitral valve in rim procedure. Next.
Sometimes we didn't shape this kind of a shape.
Sometimes.
What kind of shape you prefer? This one or previous one?
I think that this one is more easy. However, that maybe 1 in 10 or 1 in 5 maybe failed. So that you must prepare for another test wire for the conventional one. So next, so that's Sathananthan here, and then
that's the balloon. What's the balloon?
It's a 12 millimeter. Usually 12 millimeter is enough, and occasionally if the septum is sick or the have previous surgery, you need the bigger balloon such as 14 or 16. Next. So that the position for the valve is quite difficult. So initially we do a 50-50 implantation, and you know that here the valve is not perpendicular to the annulus. So we still adjust, but in this moment I cannot sure that it's too high or too low.
Too much in the atrium.
It's one side is maybe the 20/80, and the other side should be 60/40, but we cannot sure. So that's after deflate the balloon, and you see maybe some supravalvular leakage because in some areas 60/40 in the anterior levated portion. So we check the echocardiography. You can see that the A1 side is a supravalvular leakage because the valve is not occurred by the anterior mitral levator, so that it's called the supravalvular leakage. So we put in another valve for the TAV-in-TAV. So the second one is M higher, and to prevent the supravalvular leakage, and then the leaflet can prevent the leakage. However, we still push more to the left ventricle side. This time we inflate more slowly and push a little bit into the left ventricle and release deflate.
So this is also 26 millimeter valve.
It's the first one is 26 plus 3.5, and the second one is 26 plus 3 millimeter, because she will be oversized for 20%. Okay, then we see the final echocardiography.
Yes. So after the second SAPIEN 3 valve, the mean transmitral valve pressure gradient is 2 millimeter mercury, and the maximum is 4 millimeter. And for the LVOT obstruction, there's no LVOT obstruction, and the mean pressure gradient is only 1 millimeter mercury. So let's see the 3D reconstruction.
No. Could you see the stroke to septum distance?
Stroke?
The upper stroke to the septum distance.
The distance, okay. Yeah.
Any inference to the LVOT?
Yeah,
but this may be the because this is a 3D. This is only 2D, so maybe 3D there's a crescent shape.
Okay, you
yeah.
You can look at the floor. LVOT floor is any floor or
the LVOT flow is laminar flow, so
that's fine. Yeah.
Yeah, there's no clue of the LVOT obstruction. So,
Dr. Lin, can you show that if there's any residual paravalvular leakage?
No,
there's no residual paravalvular leakage.
Yes, do you
color
the LVOT?
I think the ring is more difficult to get the better position before the implantation, because this ring is settled in appearance, in shape, so it's not
in the same plane.
Yeah, it's not very easy to get the good position.
Yeah, that's Professor Yin suggests maybe in the middle of the implantation, maybe we can change a little bit the projection, the floral projection, and see if landing zone is good enough. And you see here it should be LVOT, all right?
Yes, this is the 3D true view.
So I think some part of the septum is very close to the stroke.
The stroke, yeah.
How about the Lapoon effect? Can you see the Lapoon effect, the flow?
Because now there's two SAPIEN 3 valve over there, so it's quite difficult to see the original valve. But I cannot show you after the valve deployment.
But on the first valve, do you check the Lapoon effect?
The first valve, okay.
After the first implantation.
After the first one.
你有做吗？
第一个。
But the advantage of this ring is that it's very easy to see. It's the visibility under the fluoroscopy is very good, so it is an advantage to get the position of the valve. But if you face a ring is very the visibility is very low, and under the fluoroscopy that would be challenging when you deploy the valve.
And for this case, if the BOT is not a concern, I think the 29 should be okay. And the 29 is more better for this case because the easier handle and it's a proper oversize. You can see here the waist is not quite much, so that's is upper part of the 26 valve inflation. And if we can use the 29 that's without any LVOT problem, maybe the 29 is just one valve, okay. And could you, I will check the sentinel. 在哪里呢？ So as a sentinel, please show the sentinel debris. Do you show the sentinel debris?
Quite a lot of debris captured.
Yeah, it's a lot of.
You saw it. Yeah.
Anyone could project the.
You want to show the sentinel?
One can show the picture.
Here.
Yeah, it's a lot of debris from the valve, and we call the anterior leaflet. So that's every time we should prepare for the sentinel brain protection device.
On the pathology finding, this debris including thrombus, including aortic wall tissue, valve tissue, and other debris. Yeah. So this is very effective.
Yeah. So there's any comment from this case, or that's maybe a better position method that we can learn from this?
The characteristic of the ring is very important because, for example, the ring is, if the ring is flexible or rigid, as if the ring is complete or incomplete. So, Dr. Lee, can you talk about this point?
Yes, I think that the complete ring is okay, and the incomplete ring is quite dangerous because the incomplete ring, you don't know how much you can expand. So the sizing is always a problem. Then the semi-rigid and the rigid, we use the valve ring before and in a rigid ring. However, that's some power leakage, and we also need the occluder for the power leakage because the valve cannot open and reshape the ring, and just near the commercial area is two hole over there, and sometimes it causes problem.
So the rigid ring cannot achieve better complete sealing.
Yeah.
Okay, so thank you very much. Very good case and nice presentation, nice lab demonstration. Congratulations. So we are going to move to the other room, okay?
Okay, thank you.
可以转到中山医院。
可以了。
哎，张教授，您这
喂，听到我们那个周主任来了，那个不好意思，刚刚那个我从那个广州回来，飞机晚了1个小时，所以就迟了，不好意思。
周教授，
那么现在我们那个张医生呢，已经把这个一个夹子已经加上去了，就是把环已经环束了一下。那么这个下降呢，3级坝反流的下降呢，还不是非常的满意，下降了有1个夹。我们呢准备呢在下一个夹子在靠第一个夹子呢是靠后叶隔叶这个部位，我现在呢准备在下一个夹子呢靠这个后叶前叶前后就在这部位，然后这样夹住以后，这个的把环环束一下呢， 使它呢这个前叶和髓叶呢背后的好一点，减少的反流。我现在在调整这个位置，现在我的那个夹子呢，那个弓的那个螺丝呢靠近半根部，对吧？有点偏心室是吧？薄平，
正好，
正好，正好，那我就准备弓一下看看，好吧？
好，
转过来一点，转过来给我看一下啊。
右边，
对吧？
右边，
这个部位对吧？好
啊，
贴上去了啊。怎么样？哦，位置正好。但是看不见螺丝头。
对，螺丝头看不到。啊，这里。
你木头给我看看。
那这里螺丝头在这，在这。
抓点影子看看呢。
在那了，是不是在半根？是不是在半根？
可以的。
是不是在半根？
可以的。我其他不怕，我就看，没有，那我们从照影图像给大家看看。
你看半根对的啊。
靠近那个嘛，靠近冠脉嘛，靠得很近嘛。上右线现在看看了，右线我们看看，
你说啥？
它跟那个冠脉的距离怎么样？右冠的距离情况怎么样？好。
我没在线，我来打好的，这样看一下上位。对，
照影。
对，看是不是半块？好像是在正叶二尾正叶低一点，你看是不是在半块？
有距离的，
是不是蛮远的？是不是在旁边？
正好在半环上。你看到吗？
偏房吗？
好像也在偏房侧一点，为什么？
偏房吗？
让我看一下。
我全照相给你看看。
是里面那个亮的，不是它那个。
我们现在
半环在里面那个亮的地方。
半环，
对吧？
那个潘老师啊，你跟大家说说了。
我现在就是图像，我没有打到很，就我的图像，等我来打好，等会儿，好，不要有的，你再看看这个，对，这是在半宽的位置吗？
在房侧。
对，看个体表。
看体表。
对，一旦攻进去以后再拿出
又
来。
很麻烦。要在这。
麻烦不麻烦？就是说我们要确认每一个动作呢，都要确认。
这个。我去一下啊。
我们做这个3节半、2节半呢，都是一个细活，慢慢的弄，不像那个主动脉，不像TAV，行，一下子就行了，这个要慢慢的做，不急，
慢慢的
看。刚刚这个反流的情况，大家可能也看到了，是吧？
所以周主任，您这个 K clip 的话，主要是做在这个半环扩张的吧？就是功能性半环扩张的。
主要是功能性
说半夜有问题，大概就没办法。
是。3节半的反流90%以上呢，它都是一个半环扩张起来。你比如来源于2节半、主动脉换瓣以后的扩张，那比如老年人的房颤引起的半环扩张，拉来看好吧？拉了？不，这我没拉，先不拉。
自动停掉。
好，那因为这个转播可能讯号的关系，
这
啊，正好，我觉得位置很好。
把这地方，
我觉得位置
没切，螺丝看不到。
等一下啊，
我把那个
螺丝在这，
我把那个中票往回撤一撤。小陈，
在这里。
哦，好，这样现在看到螺丝了，这个试看一下。
哎，我觉得这里是对的。
对的，那这是拉的，
拉了。
那在这，
正好就在这里。没问题。这是非常好的位置。对，这是非常好的位置。非常好的位置呢，这个呢要稍微要偏防一点，因为我们的夹子打开了以后它是直的，那直的呢，然后呢它而这个半滑呢是滑一些。
好像是我在朝那个防的地方对吧？然后我本来要在挡前上。
正好，这就是这个位置。
好的。
非常好的位置。
好。
那小陈，我扶着你打开那个夹子，这个要来，那上去。
好的。
左前一点，
手前斜位打开开夹，慢点看，不要急，慢点看，看看我们这个夹子呢跟那个第一个夹子和第二个夹子有多远的距离。好，我觉得还可以的，再开一点，再开一点
0度来，
再开一点，
感觉有点近哦。
等一下，我还没挡出来。
不要急，这个不对，这个方向有点不对，
要转一转
转稍微的这样转一转。
好，等一下。
对，非常好，对，这个非常好。
等一下啊。
可以了，不要张得太厉害。
就放90度。
这个上这个大环功能反流，它功能性的或者说是半环扩大的引起的反流，这样你去拉那个半叶的话，远期的疗效从理论上讲不是很好。有 T 虽然也有点取得了一点
第一个夹子
但是呢，真正的
你现在
应该是半环。
怎么会这个位置了嘞？对不对？对呀。
是的，这不是半环吗？
等一会周主任，等一会儿让我
是半环呀，半环是斜的，它圆的呀。
对，等一下
嘛我觉得是对的。那不是半环的因子吧？
但是
是。
孔老师来打，我来看一下。你等一会儿啊，我觉得现在好像。你在这个位置是哪里呀？
有一个靠近心室了。
好像不对啊。你这个位置在哪里啊？我觉得这个位置不对呀。
说为什么不对？
在这个地方对吧？那是前后吗？是前后的位置啊。
你这个夹子似乎那个人字形没展开的很好。
对。
图像转。
我夹子往回撤一点，让你看看，好吧？上下透个视。现在怎么样？
我们是不是要顺转一点？这一边偏防对吧？夹子转一转。
顺转对吧？
对，
这样转
顺一点。
不对，顺转不行，反掉了。这样转。
对，
这样转，对吧？转一点啊。好，不是嘛，正好嘛。正好嘛。同志们，正好吧？
好。
正好，我就夹着往上顶一点。小陈，你准备？夹
对吧？
我往前走，你拉，然后你来夹
你走。
这个走那个不要走，走那个不要走。走这干啥？
它两个要同步。
不是瞎扯什么？你乱来。那个大鞘不要走了，就走中鞘。
方向对吧，潘老师？
对不对？
可以下去。
我这下呀。
方向对不对？
但是方向对不对？好像
方向好像不大对。
我也觉得不对，你的半方向。
不是你刚刚好像动那个大鞘干什么，小陈？
没动啊，准备要一起下去，它这两个不同步，方向会变的。
那我好像有点不对，对吧？断掉了啊，好啊。
好，
现在怎么样？
周教授，因为转播的时间到了，还有下一场要上来了，那你们慢慢讲，那祝你们手术成功，非常谢谢，这么精彩的 case， 好，谢谢，谢谢，好，谢谢，
好，再见，拜拜啊。
好，那我们可以换场，谢谢。
我们的 demo 到这边，我们就准备下一个 section。
Ladies and gentlemen, we have reached the final leg of the second day of Taipei Valve Summit. So before we proceed to our last session, I would like to remind our esteemed guests and our staff who registered to attend the dinner party at the Renaissance Taipei Shilin Hotel after this event. Don't forget the post-meeting gathering. So now we proceed to our lectures. Transcatheter, mitral, and the tricuspid interventions. And welcome our renowned moderators and the panelists and all participating experts. Thank you.
Thank you very much for for attending this session. This session is focused on AV valve, the mitral and the tricuspid valve. The first talk will be given by Professor Simon Lam from Primary. Simon is an old friend of mine. This year you attend TVT, so you can only join this meeting online. The first talk will be in talk called App, Then and Now, Lessons Learned from MitraClip Landmark Trial and the Real World Practice. Simon, please.
Thank you for the invitation by Taipei Valve Summit 2023. My topic is COAPT, Then and Now, Lessons Learned from MitraClip Landmark Trial and Real-World Practice. I have 2 cases to share, and I will go over the COAPT trial 5-year results with you. So first case is a patient, 68-year-old with dilated cardiomyopathy, poor LVEF of 20%, severe MR due to tethering of posterior mitral valve leaflets, and it's very symptomatic despite medical treatment. So this is the echocardiogram showing the typical findings or appearance of the leaflets. You can see it's restrictive in the posterior mitral valve leaflets because of tethering, leading to a wide coaptation gap showing severe functional ML, and the LVEF is poor in terms of contractility. So the plan is to put in 2 clips for these patients, and we tend to put more than 1 clips in our theories to even out the stress on the leaflets by the clips. And usually the gradients will be less of a problem because of the severe dilatation of the mitral annulus. This is the results after putting in the first clip. And the second clip will be on the lateral side. So to target the very clear target after the first clip. So this is the results after the 2 clips. You can see the significant reduction in the mitral regurgitation. And along with that, usually you will see that the airway function, the contractility may go down, and which indirectly signifies the successful or elimination reduction of ML. And usually we will need some careful titration in the medication to tie over the patient, because the patient may have some hemodynamic instability, and rarely we may consider hemodynamic support measures for those patients. And in this patient, the patients have very good reduction in terms of ML, and also in terms of symptoms, the patient improves a lot. The hemodynamics is become better, the blood pressure goes up, we have more room to titrate our anti-heart failure treatment, including Entresto and SGLT2, with the patient entering into a cardiac rehabilitation program and recovers very well. The second case is a relatively sicker patient, as a 69-year-old gentleman with dilated cardiomyopathy for quite some time, poor LVEF, recurrent admission for heart failure. We tried everything to help him, including CLTD, some devices, including spinal cord stimulation. And the patient has a strong history, family history as well for heart failure. We see the patient in the ICD clinic, he complained of poor functional status, shortness of breath, worsening from the baseline, and also the blood pressure is just very borderline. We decide to put in mitral clip of the patient. This is a pre-op chest X-ray showing pulmonary congestion. ECG showing a pacing rhythm along with the CLTD. There's a wide coaptation gap. This patient, we tend to put in 2 or more clips, and you can see the appearance of tethering posterior leaflets with a gap here showing a functional severe MR like this. And the plan is to put in 1 clip in the medial first, and it's isolated to jet to lateral, and to put in a second clip. So the first clip in the medial position and the second clip in the lateral. So this is the first clip. After the first clip, it has some reduction of ML to moderate. And after the second clip, you can see before putting the colors, we can see also the LV function goes down. And comparing the pre-procedure ML, you can see there's a significant reduction, at least 2 grade to mild or 3 grade to mild degree of ML. And the chest ray improves a lot after the clipping, and you can see there's a CLTD, the spinal cord stimulation device, and now we're adding 2 small clips here as a part of the heart failure treatment. The patient stabilized after procedure, and still need a course of rehabilitation and hospitalization, and inpatient optimization of medical treatment, so the patient recovers well after procedure. So-called trial, we know about this trial. It's the largest trial that covers management for mitral regurgitation, with comparing mitral clip plus GDMT versus GDMT alone in a randomized 1-to-1 manner. Patients with 3+ or 4+ ML, EF is 20% to 50%. Below 20% is excluded. A patient with an extreme dimension of LV is excluded. So the LVST requirement is smaller or equal to 70 millimeter. They have to be on medical treatment being optimized. And the patient was excluded if they had severe pulmonary hypertension, severe comorbidities, severe LV dysfunction, for example. Comparing a mitral clip to GDMT alone, you can see that for 2 years, it had a significant improvement in terms of cumulative hospitalization rate. For the 5-year results, it's very encouraging to see that at 5 years, this difference still persists. The cumulative heart failure hospitalization rate for device is 33.1% per year, and the control group is 57.2% per year, and it's statistically significant. It's very safe. The device-specific events is only 1.4, with isolated cases of SLDA, device embolization, device complication surgery is very small number, and this number only confined to initial 30 days. There's no additional events beyond the 30 days period, so it's really a very safe procedure. So for death or hospital hospitalization, so the hazard ratio is 0.53, so which means that to patients who receive MitraClip together with GDMT, they have a reduction in the risk by 47%. Among different subgroup, the beneficial effect of the MitraClip at 5 years is very consistent. And you can see that no matter patient's age is below or 74 or more, or the female or male, is ischemic or non-ischemic cardiomyopathy, the baseline symptomatic profile, baseline risk score for surgery, MR grade, LV function, LVDV, no matter which subgroup the patients were put in for a sub-analysis, the effect of a device, which is the MitraClip, is still very consistent, showing beneficial results. For all-cause mortality, comparing the GDMT and the MitraClip plus GDMT group, it shows a absolute reduction of 10%, which is really very encouraging. So there's one very important phenomenon that was observed in the COAPT trial 5 years data, and you can see that. So this is a two-year data, which is the initial setting for the primary endpoint evaluation, and it shows significant improvements with the MitraClip. And all the beneficial effects appeared to be stayed within the initial 2 years. So after 2 years, they're still doing better with the MitraClip arm, but then for the control arm is just similar. So it's also, there's no definite statistically significant difference between the two curves. So this is more or less related to the setting of the trial. So we would elaborate further. So for the trial, after 2 years, for the control group, who is a medical only group, they are allowed to cross over to the MitraClip arm. So if there is a survivor after 2 years at the control group studies, there's only about half as 1/3 of them. And if they're eligible for the MitraClip, they will have the device prepared and implanted. And so it accounts for about 45% of patients among the survivor in the control group. So this is a very important summary slides. You can see that the blue line is the patients who receive GDMT along with a MitraClip, and you're very familiar with it. The outcome is worse with this group. So the green curve is the MitraClip plus GDMT group, as we know from the COAPT 2 years and 2-year and 5-year results. It shows beneficial effect. And for the orange curve is of those patients who originally belongs to the control group. When they cross over to the MitraClip, the time was set back to 0. Again, we reset the clock, and we follow up this patient in a time-adjusted multivariable analysis. The reduction, and it follows similar prosthetic pattern or prosthetic curve compared with the original device group. So it means for those patients, although they received the treatment as a kind of crossover strategy, they still showing similar prosthetic improved results comparing with those patients who only receive medical therapy. So the news is, if you receive it late, is to still have the beneficial effect. But unfortunately, we don't encourage the patients to receive the therapy late, because the patients in the control group, a large majority of them was died after 2 years. So these are only for the survivors. So we really need to work hard to let the patient have the treatment early on to prevent adverse event occur before, instead of thinking about maybe if they just survive, we may try something else. It's not a concept. So overall, is to treat the patient as early as possible. Symptomatic improvement, MR improvement is definite towards 5 years. And conclusions learned from our experience on the MitraClip result on our patient, and also from the COAPT trial. Symptomatic heart failure, secondary MR, despite medical therapy, receiving MitraClip is safe, reduced rate of hospitalization for heart failure, improved survival, improved symptoms, and improved quality of life. It's consistent across all pre-specified subgroup regardless of age, sex, MR severity, airway function, volume, cardiomyopathy, etiology, and surgical risk. Mitral clip should be an upfront treatment. It's also a key element to for the management of heart failure. It's not a palliative treatment. You can see at 5 years it's very durable. So we really think we should the heart failure physicians or general physicians should refer this patient to interventionists who can operate on patients with mitral clip to research treatment early on to show the even better outcome to prevent or to help the patient before adverse events occurs. Crossover agreement from control showing similar prosthetic curve as I've mentioned, but overall we still need to consider treat those patients early on. We have new generation of clip which improve efficacy and safety. We should have integrated care for heart failure and functional MR because overall for patients, even though they receive the mitral clip, the baseline mortality and hospitalization rate is still very high. So it should be the intervention technology advance goes hand in hand with the new pharmacological treatment strategies to help with the clinical outcomes for all these patients who suffer from heart failure together with the severe functional MR. So thank you very much for your attention and hope to see you in person soon and also in Hong Kong WAF 2023 in October 2023. Thank you very much for your attention.
Thank you, Simon, for your comprehensive review and talk. Do you think that mitral clip should be extend its indication for more severe patient or just stay with the COAP indication?
Yes, so this is a very good question because there are other studies showing if the heart already is burned out and the patient received treatment too late, they may not follow the similar prosthetic curve. They may have issues during the procedure. They are ultra high risk during the perioperative period. But we have experience treating those really patients really have a very poor LV, smaller than 20%, and heart dimension is more than 70 millimeter. They're still doing well, but it's in a named patient basis and case by case variation. We should not apply the COAP trial data directly to those patients, but in reality, we're treating those patients with good outcomes.
Okay, thank you. We have to move to next talk because of the time constraint. Thank you very much for your online participation of this meeting. Thank you.
Thank you.
Okay, next talk will be delivered by YY Lam. Is YY there?
Hello, everyone. I'm Dr. Lam from Hong Kong. First of all, I would like to thank especially Professor Yin Wei-Xian for inviting me to this very special regional valve summit. Today, I'm going to talk about advanced steering and imaging techniques for mitral clip procedure. There are 3 basic techniques that will be used in every single mitral clip procedure, which including first, torquing the guide here. When you counterclockwise the guide, the system will go anterior towards the aorta. And if you clockwise rotate the guide, it will go back to the posterior wall. The second steering technique is using the M knob on the CDS. If you bend more, using more M, it will bend down to the mitral valve and also go more medially. The third one is to use the stabilizer. By push in the stabilizer, then the whole system will go more lateral. If you pull out the stabilizer, then the whole system will go more medial towards the septum. And there are 2 special knobs that you don't use it in every single cases. You only use it in special occasions, which including the plus-minus knob on the steerable guide. The plus-minus knob is usually used for correction of aortic hugger. You apply more plus, you see the whole system will swing away towards the posterior from the aorta. That can correct aortic hugger. The second knob is the AP knob on the CDS. If you apply the AP knob, just like in these movies, the whole system can actually swing lateral and anterior. It is used partly during correction of height. So let's look at two common problems that you encounter during procedures that you need special steering techniques. The first one is like this one. Clearly you see the system coming, lying over the aorta. Why it happens? This often happen when you puncture it really high, close to SVC. Because if you puncture in the yellow circle here for the interatrial septum, very likely the aorta and it's just next to it, you very likely ended up with aortic Hugger. The more correct puncturing position is usually at the red circle, where it helps you get the maximum working distance towards the mitral valve. So you see what the problem with aortic Hugger is that you don't allow a perpendicular coaxial alignments between two valve leaflets. So it's very difficult to catch them at the same time and also catch them in even leaflet insertion. So it needs to be corrected. So how can we correct it? First, it's very simple. As I said, we apply the plus knob. So we will swing the system away to the posterior. And because of it, it's away from the central. Often you have counterclockwise rotate your guide like this, and then it will cause the whole system back to the central. And with this, sometimes you need some M-knob adjustment, fine adjustment of M-knob for the system to be returning to its intended position. And the second problem sometimes happen is when you puncture really too low. This happens if you puncture really in the lower half of this fossa ovalis, or in patient really having very small septum. You don't have adequate height. So like this, if you don't have adequate height, sometimes when you bend the system down, the tip of the clip already is below the left ventricle. So you need to correct the height in the left atrium before you proceed further. To correct height, as I said, it is also very easy. We know that when you clockwise rotate the guide, the whole system will go posterior and then you gain height. At the same time, you apply the A knob, which swings lateral and also anterior. So you can actually correct this lateral swing by applying M knob at the end to go back to the intended position. So it's very difficult to understand, right? But when you're doing more, you will understand more. So I'm giving you a case. So this is a case with A3 flail and also with medial commissural involvement. Apart from commissural disease, the patient also having some other issues, including relatively low, short maximal septal length, relatively borderline mitral valve area, and also very short posterior mitral valve leaflet length. So you need good strategies to do this procedure successfully. First, you have to maximize your transeptal puncture height. And secondly, after transeptal puncture, you have to use gain height maneuvers, which including the posterior torquing of the guide and using the A-knob. Of course, because it's zone-free medial commissural pathology, you have to make sure you reach the medial commissure. By using a small clip, sometimes you have to use more M-knob or even pull out the whole system through the stabilizer and sometimes get the guide maybe in the right atrium. So this is the case. So first we applied, we did a good transeptal puncture. We do the first clip, but after the first clip, there's still MR. And then we check at the commissural view, we found that the clip is actually not too medial. So that's why we have to optimize the whole thing by, as I said, pulling the system, really using more M knob, and also pull out the system. And part of the guide is actually in the right atrium. By doing that, we will be able to reach really the commissure and apply the clip. After the first clip, you see still there's residual jet medially, lateral to this clip. And the mean gradient was free, so we decided to put in another clip. So to put in another clip, the trick in this case that you really have to do it at zone 2 and then pull back the whole system again, try to align 2 clips side by side. And this is what happened after the second clip, trivial MR. And the patient still have a lateral orifice with mean gradient after procedure. All right, let's go to some of the advanced imaging steering techniques. So the advanced imaging steering techniques include basically 3D and its methods, which including a 3D on-fast view, explain, and also more people now love to use multi-view, which is basically acquiring a 3D data set and crop all the planes through 3D reconstructions. So let's use example to illustrate how to use all these 3D techniques. So this is a patient having a very simple P2 prolapse. So 3D on-fast view already tells you where the prolapse is, and its color jack will also give you additional information. And of course, this is a more conventional way using explain at different regions of mitral valve to assess where is the pathology. But of course, we noticed that for A1 and A3 pathology, sometimes explain does not give you very nice images because you really need to change the echo planes. Like usually the middle one is for the A2P2 standard LVOT view. And if you have lateral pathology, you might need to increase your scanning angle. And if it is medial pathology, you have to decrease your scanning angle. So you get a coaxial cut of the pathology. But with multi-view, basically you can actually get the whole 3D picture, and you can get all these planes by reconstruction. And with multi-view and with these techniques, it gives you additional information and make the procedure a lot easier. So this is the situation where conventional way of doing transeptal puncture by having a bicaval and short axis view, and also confirm the puncture height and 4-chamber view. And with 3D, you can actually see the tenting of the needle along the mitral commissure. So it allows you to have a better alignment of the system on top of the mitral commissure. And of course, with multi-view, you can basically using it during whole of the procedure, which including the passage of the wire, the passage of the big sheath across the septum. And one thing very important is that with proper alignment of 2 planes, like here, you see the red lines crossing align the image, and with the another plane using the green line aligned, you can basically easily measure how deep your steerable guide is inside. And of course, with more training, it can also gives you very detailed information and guide you every step, help you to steer it towards the mitral valve. And one thing my imager always like to use is that they would try to use the green line and the red line, try to make a cross, a middle at the position, so it would actually guide me to position my clip and also to make sure my orientation is correct. So this ensures better communication between the operator and the imager. And we can also use color Doppler with the 3D multi-view. But the problem with this is that the frame rate might drop. So sometimes if the frame rate images drops and the image quality is not good enough, then you have to go back to the 2D imaging mode. But with current state-of-art machine and new TE probe, this is usually not a major problem. Of course, we can also use multi-view to monitor how this clip enters the LV, and we don't worry about losing the echo plane because we can always fine-tune using the multi-view 3D data set. And lastly, of course, we can make sure the leaflet is properly sitting on the clip using this technology before grasping. And after grasping, of course, we can also see how the MR reduction, whether it is optimal or not. With that, I would like to conclude my talk, and hopefully I would be able to see you in person for more detailed discussion. Thank you very much for your attention.
Okay, thank you. I think that it's a recording, so maybe we just move to the next talk.
Okay, next talk is from Professor von Bader-Leyden. Professor von Bader-Leyden is a regular speaker at an international event. He's the head of the Center of the Structural Heart Disease Intervention and the Heart Valve Center in Mainz, Germany. Today he sent us some recording, so let's see his recording. Thank you.
Warm welcome to the Heart Valve Summit in Taipei. It's a great pleasure to give this lecture remotely. I'm sorry for the time change that I'm not able to be on site or live, but I'd like to inform you about the state-of-the-art transcatheter tricuspid treatment options. My name is Rolf Stefan von Bader-Leyden. I'm professor of cardiology and interventional heart valve therapies at the Heart Valve Center at the University of Medicine in Mainz, Germany. These are my disclosures. When we look at tricuspid valve disease, it's a therapy where the etiology drives actually device selection. And we know that about 90% of tricuspid regurgitation are either ventricular or in a large proportion, which is between 20 and 30%, atrial in nature, and this can be coupled to atrial fibrillation or hypertension or age. On the other hand, we have CID-related cardiac implantable electric devices. This is pacemakers and ICDs, formerly been put to organic or primary disease, which is a rather rare entity, a prolapse or chordal rupture or a carcinoid tumor disease is less than 5% of all etiologies. If we look into the etiology in therapy, we know that atrial FTR may be correlated to elderly, especially women with atrial fibrillation, so ablation may play an additional role. Restriction of the myocardium in hypertension, fibrosis, and oncology treatments. On the other hand, ventricular functional tricuspid regurgitation is linked to the need of guideline-directed medical therapy, surgery, or intervention of heart valves on the left-hand side. And there's a group of pulmonary hypertension where PAH, guideline-directed medical therapy, may play a role. The tricuspid valve in itself, and we've seen this year also in Taiwan, is more complex than the mitral valve. It consists of dense chordae, very thin and variable leaflets, and a very large annulus. It's the largest valve in the human body with approximately 6 to 7 centimeter square valve orifice area. The tricuspid valve is highly variable, as in this paper by Fabian Prats and also Becky Hahn. We know that type A and D are quite common, as you can see on the right-hand side. And so typically these valve is tricuspid or bicuspid in nature. If there are multiple subleaflets, treatment may get more difficult, especially with TEER devices. So if we look into the need for tricuspid regurgitation therapy, we know that there's linked to cardiomyopathies, left-sided heart valve disease, persistent AFib, pulmonary hypertension, and aging. And this all leads into a vicious circle of tricuspid regurgitation with volume overload and chamber remodeling. So medical therapy alone may not be the solution. So if TR is more than mild, it carries a bad mortality prognosis, as you see here, even if left ventricular function is good. In this publication in 2020 on 33,000 patients. If the HFrEF situation is there, it carries an even worse prognosis, but it's still dependent on the severity of tricuspid regurgitation. So both aspects have been reflected in the 2021 and 2022 valvular and pulmonary hypertension guidelines of the European Society that first mentions evaluation of transcatheter therapies as a treatment goal and shows the dependency on valvular heart disease in the aortic valve stenosis, but also mitral valve regurgitation, and the congestion leading from LA pressure over congestion to remodeling and right ventricular heart strain. So which surgical and transcatheter techniques can we use to treat TR? Well, of course, we know surgery for more than 30 to 40 years, which should now be done in a lateral thoracotomy and also with an incomplete ring because of the risk of pacemaker implantation. You can also see that this could be done beating heart, which in the latest New England Journal publication of 2022 was only done in the US in 30% of the cases. More would be helpful. There are some possibilities with heterotopic cable valve implantations. Some devices now have left the market as spacers and others. But there is an entity of different tier devices, which we also call cooptation devices. This is mainly the TriClip and the Pascal, which make up for 90% of all treatments. And then there is a smaller group of annuloplasty, like with the cardioband or chordal banding, and the heterotopic cable trach valve implantations. We always should remember that the tricuspid is not the mitral valve. So while we relatively precisely know how to deal with the mitral valve on guideline-directed medical therapy in functional disease, how long we have to wait, these questions are more open, and also the treatment goal is more open, as is the outcome and the parameters that we want to influence. The potential of transcatheter new tricuspid valve repair and replacement is that it's less invasive than surgery. Its predictable and durable elimination of heart valve regurgitation can be done in TTVR, but also in TEER procedures. And it's a straightforward procedure. But we should always remember that we are working in a low flow condition field and that there is a certain proximity to the Koch triangle for AV block, which is especially important for the upcoming replacement devices. The current therapeutic options are mainly orientated by surgical repair, which carries a grade class 1 and 2A indication, level of evidence B and C. Surgical replacement, which is less good, but in reality is approximately, also in the latest publications, about 50% of the procedures. Transcatheter repair being a new kid on the block with a 2B level of evidence C indication. And for medical therapy, there are no good studies to really support these techniques. So upcoming trials that you see here with more than 2,000 patients are important. And we know that there's no proven efficacy for diuretic spironolactone and SGLT2 inhibitors on the right-hand side. So this may be answered in upcoming trials. We just published 2 weeks ago on the arrhythmia-mediated valvular heart disease, and on the left-hand side you can see the new etiologies that atrial functional tricuspid regurgitation accounts for 23% and wasn't even mentioned in the 2017 guidelines. There is an interaction of mitral valve regurgitation and tricuspid regurgitation. So if you treat mitral, look for the tricuspid, and if you see no improvement, that may happen in 35% of the cases, you should treat the tricuspid as well, because it is outcome relevant, as shown in our propensity score match publication as start of the ART review in JACC. There are many comorbidities in these patients, and this is because they typically come too late when symptomatic burden increases and is impaired. The potential to improve now is earlier, and this is a very nice publication of the tricuspid focus group of the European Association for Percutaneous Therapies of the European Society of Cardiology. RV function and PA pressure and influence the therapy and influence whether it's a good responder, a super responder, or a non-responder, or whether you can do harm to the patient. So as a baseline, if the RV function is bad and PA pressure as afterload is high, patient experience, especially when invasively measured, a worse outcome than those with good function. To come to the different devices, we know, of course, that the first device, and I treated the second patient in the world with cardioband tricuspid, was in 2015-16, the first device to become CE mark and used in tricuspid regurgitation, mimicking surgical experience with annular reduction. It is an interesting technique, and you can see here one of the successful cases. We have a close proximity to the right coronary artery, and if we look on those images here, you see a severe regurgitation on the upper side, and after treatment, a trace to mild situation. But these are, of course, good responders to the therapy. There, 2 years ago, we published in Neurointervention the tree repair annuloplasty 2-year outcomes. You see that the annuloplasty effect is maintained, TR severity is reduced, but we have to see that approximately 27% of the patients actually remain in severe massive or torrential. So it's a therapy that works for approximately 2/3 of the patient. We see that tree repair annuloplasty has clinical impacts on functional class, on edema grade, 6-minute walk, and KCCQ, just like other therapies. In the near future, there are other devices, as you can see here, annuloplasty, especially for secondary TR, but TEER plays a more important role, and orthotopic TTVR will also be important. A new Chinese development is the K-clip that has been done first in human in the years 2021-22. You see the Persine publication on the left-hand side, and the first case published as a case report by Yang Lam, seen on the lower side. And this is a copy of the K procedure in surgery, a duplication and bicuspidalization of the heart valve by reducing the ring in the posterior part of the tricuspid valve. The most important therapy, though, is transcatheter TEER, may be done by TreeClip or by the Pascal ACE device. You see more than 8,000 to 10,000 patients on one side in tricuspid, more than 4,000 on the other. So very important therapy goals. We see that efficacy and safety is seen for both devices on the left hand and on the right hand side in very similar extent. You can see in these large trials, BeRight and Triluminate, that just have been published in JACC with an additional number of an additional 200 patients, so in total 500 patients now for the BeRight real-world study and for the roll-ins to the pivotal study. And just to give you an example, this is a patient with a severe regurgitation, partially bicuspid valve, severe regurgitation. And if you treat this by 3 triclips here with 2 XTWs, 1 XT in the middle as a third device, you can see that we can achieve a trace regurgitation in this severely diseased female patient with impaired renal function. To look further, we see that there's also a long-term effect. We see here a Pascal double device implant, and on the right-hand side, you can appreciate that the right atrium over 1 year remodels nicely, the right ventricle becomes normal in size, and these patients have a benefit that is sometimes very distinct. So at least 2/3 to 90% of the patients are responders and super responders. And this has been shown in the latest JACC publication now on 511 patients with a cardiovascular mortality that is only 0.8%. So it's an extremely safe procedure for a patient population that is in mean 79 years old, that is predominantly female, and has a huge amount of atrial fibrillation in this group, but a low stroke rate and no need for elective surgery. Just to give you an outlook, this has just been accepted, but will be published soon. You can see that the results of TreeClip now are stable in studies over more than 2 years, that the ventricle remodels. And if you achieve moderate or less TR, you reduce the combined endpoint of hospitalizations and mortality by half. So with a 2-year follow-up of the first patients here in replacement, this is from the TRISCEND 2 trial, you see that we have very beneficial 1-year and 2-year mortality that is below COAPT with 14 and 29%. And we also have now recent data from also Raja in the New England Journal for the first randomized trial. Again, we see a low cardiovascular mortality. There was no mortality sign in the first year, a very modest but insignificant sign for heart failure hospitalization during COVID. But what has been astonishing was the improvement in TR severity, and also, as we see here, and also in the KCCQ, which has been accepted by FDA as an endpoint in September 2021. And you see that the KCCQ quality of life score is highly dependent on TR reduction. So for the EVOC TTVR replacement, there are positive signs, which is also very low 30-day mortality of 4%, good echocardiographic remodeling signs, but there are disturbances in the AV node conduction and also some hold issues. So if we look into the future, this is valve replacement as an alternative option. And you see here the implant of an EVOC valve with fusion control. You see the result, no PVL, and this procedure can also be done less than an hour. We again see the situation at 1 year, and we have now also 2-year results of the compassionate use patients. There are additional German-French developments, a valve that is built in Brazil actually, and you see also very nice implementations. And from China, we have the Lux Valve Plus, which is a large steerable device, very complicated with 3 different layers of its sheath that can be implanted in patients from less than 40 to more than 60 millimeter annular dimension. This is a transjugular approach, as you can see here, to the valve, contains multiple fixation mechanisms to the anterior posterior leaflet with so-called rabbit ear feelers and septal anchoring that you can also apply. Here you see the puncture in the right jugular vein. It's a large device, 35 French, which is steerable. You go across the valve and you then expose the different components under beating heart conditions to the leaflets and the ventricular septum and a large brim to seal. So this has been done also in our institution. You see nicely these 2 feelers here in the patient, and you can see live situations of a patient with a severe regurgitation as seen on the upper left, and on the upper right you see the result, no PVL, and this patient is doing very, very well. So I come to the conclusion. Thank you very much for your attention, that we have 3 trials actually enrolled, 1 trial even reported in the New England Journal in March this year. So your patient with TR, what patient selection, what device selection, any relevant tricuspid valve regurgitation is outcome clinically relevant. Transcatheter therapy options improve symptoms. Outcome is not yet totally shown. Patient and device selection is based on etiology, right heart function, and afterload, and therapy in heart valve centers, and should be done under randomized controlled trial supervision. Please, in the future, do not treat too late as you have these devices available. Evidence generation is still needed and ongoing, and I thank you very much for your kind attention, and I hope that you have a very successful Taipei Heart Valve Summit meeting. Thank you very much, and greetings temporarily from Phoenix, from the TVT meeting, Transcatheter Valve Therapies in Phoenix, USA, and best regards to Asia and to Taiwan. Thank you.
Okay, so I think I will move to the next speaker, Dr. Scalia. He is a respected echocardiologist from Australia. He trained in Australia and also the United States. He has been involved in the first in man Thailand
implantation, and also involved many international and national clinical trials and the first in-man transcatheter valve, particularly in the echo fields. He's a associate professor in medicine at the Bond University in Australia. Dr. Scalia, you will give a talk about identify suitable unfavorable anatomies with echo for tricuspid tear.
Very good. Thanks very much, and thanks for having me here. I'm in Brisbane, Australia right now. I'm going to talk about echo and for tricuspid intervention, and I'm going to talk firstly mostly about the anatomy and how we think about the tricuspid valve. I saw the talk by Stefan, and he sort of went fairly advanced, but I want to go back to basics for a minute, and let's just remember about the tricuspid valve. Tricuspid valve has three leaflets, obviously, with a larger anterior leaflet based near the right coronary artery, a slightly smaller posterior leaflet on the free wall of the right ventricle, and a septal leaflet, which is near to the IVC and coronary sinus, and obviously near to the septum. Now, there are three commissures, but there are two really that we care about. So, and I ask people to refer to these by their names: septo-anterior, where I've got that blue mark, and you might want to put a clip or something there, and septo-posterior. Now, if you have a look at that, what that's really saying is that the septal leaflet abuts both anterior and posterior, and it's septo-anterior or septo-posterior. Now, there is a third commissure between anterior and posterior, which I refer to as the divide. It's the division or the divide between A and P. But when you look what we do with our procedures, it's always septo something. So let's have a look at that. So if you take a right ventricle, take the free wall off, there is a large anterior papillary muscle which is sitting directly under that divide between A and P. And so if you can see that large pap muscle which sends cords forward and backwards, that's the division between A and P. There's a smaller posterior pap muscle, and the septal leaflet doesn't have a papillary muscle. It's got multiple caudal attachments to the septum, as you can see there. So septal attachments, an anterior pap muscle, and a posterior pap muscle. Now, all the textbooks that you see about tricuspid valves are done from cardiac surgery. And if you have a look at this picture, the reason why I've set this out is because in all of the surgical textbooks, the head is at the left of the screen, the feet are at the right of the screen, and the sternum is at the top of the screen. And so the layout there, if you look here for septal, anterior, and posterior on that left-hand picture, always puts the septal leaflet at the bottom of the picture. And note the triangular cock there between the coronary sinus and the AV node. And so these are this thing here you're seeing here is the typical sort of cartoon that you see in surgical textbooks, but that's not how we look at it. In echo and in the cath lab, we look like this. And so we're looking from above where we have the aortic valve at the top of the screen. And so you've got septal, anterior, and posterior. And if you look at that left-hand picture, you can see that clearly. And you can clearly see the divide between A and P. That was a transthoracic picture. This is a mid-esophageal picture, but the concept's the same. You put the aortic valve at the top of the screen there, and then you've got septal, which is abutting to anterior or abutting to posterior, wall to wall, I say. Now, as you probably learned, there are three types of tricuspid valve dysfunction. Just like Carpentier has a mitral system, there is a tricuspid system with, firstly, annular dilatation, secondary prolapse and excess motion, and third, restricted motion. And as Stefan said, the minority is something wrong with the valve, that is primary TR, and the majority is secondary TR, either atrial or ventricular functional TR. But don't forget, there is real tricuspid valve disease like tricuspid valve prolapse, which is you see in mitral valve prolapse people. We see plenty of pacemaker-related dysfunction. And I think the thing that I wanted to show here is that these wires can restrict or hold down leaflet motion. And you think that you might easily be able to get these out, but they become, with time, densely adherent. So there's no way you can just move that wire and everything's going to get better. And but the majority of tricuspid regurgitation is secondary. pulmonary hypertension, atrial fibrillation, right heart failure. And as you get secondary tricuspid regurgitation, you get annular dilatation, and the RV-free wall expands. And as you do that, the annulus pulls apart in this manner. So you go from mild to moderate to grade 3 to severe tricuspid regurgitation. Now have a look at that top right picture. When you see that picture there, you can see that the coaptation distance is very wide apart, and the thought of clipping something like that would be relatively difficult. Now, when you see transthoracic imaging of the short axis of the aortic valve, this is the index view for figuring out where you are. And when you see that picture, right ventricle there, main pulmonary artery, cava and coronary sinus, when you see this picture, in 100% of people, this is A and P, anterior and posterior. Now, you see a lot of debate about this, but it's never wrong. It's always this way. And in this picture, if you could imagine on this side of the picture, this side of the TV, you've got the septal leaflet is wall to wall, because you look from below in transthoracic, the septal leaflet is wall to wall on this side of the TV, such that if you take a typical cartoon and lay it out like that, that is anterior and posterior. And if you put an X-plane cursor through this, like this, through the anterior leaflet on this picture here, then it's going to be a septo-anterior picture there on that right screen. In fact, coronary sinus are visible. And if you move the X-plane cursor out to towards P, there, the posterior leaflet, it's going to be septo-posterior. Now, we don't do that in transthoracic very much, but we do it a lot in transesophageal. So this is a typical anatomy again. You turn it upside down, and in transesophageal, you're looking from above. So the septal leaflet is now wall to wall behind the screen, such that if you put an X-plane cursor in here, that right-hand picture there, over here, is septo-anterior, because you're cutting through the anterior leaflet, you know that, and you're cutting through the septal. If you move the cursor across there, that is now on the right-hand picture there, that is definitely septo-anterior. And in this particular case, look how wide that coaptation defect is. Now, when you put color on these pictures, this is where it becomes important, because you can easily see that color on the right-hand screen there is all septo-anterior, and there's very little leak on the septo-posterior part. So when we put a cursor through that, through the color, you can see on that very right-hand picture there that the majority of the leak is septo-anterior, and that's where you're going to want to put a clip device. Now, the next view is transgastric, and in transgastric, again, you are looking from the right atrium, but you're upside down. And so the anterior leaflet, because remember, see, the aortic valve is at the bottom of the picture in transgastric, so therefore you've got septal, anterior, and posterior. And this here, which I'm pointing to, that's the divide between A and P. So the anatomical associations, obviously the septal leaflet's near the septum, the inferior cava is on this side of the TV, anterior leaflet far away from the diaphragm, and posterior leaflet sitting right on the diaphragm. You can X-plane through transgastric, and that's quite nice for finding that large papillary muscle, which I've drawn in here, which I showed you early in the piece, is connecting the anterior and posterior leaflets. When you put this picture then and put the color on, and I freeze frame that one on the right, you can see again, same person, all this color is coming from septo-anterior. And so if you're going to do a clip type procedure, you'd be going to put the device there. Lastly, mid-esophageal 3D view there, septal, anterior, and posterior. We saw that a long time ago in the talk. And in this particular case, I'm going to purport that the color is coming from there. There it is. With color, you usually want to freeze frame the color like this, and then roll it back and forward so you can see, because there's so much color that it's overwhelming. So you typically freeze frame, find the right frame like that, and then use the hand and roll up and down with the trackball to see whereabouts the color is coming from, or even crop down onto it so you can see where the color is coming from. When we start putting devices in, we use this X-plane kind of technique to steer ourselves down exactly where we want to go. And remember that when you're looking at that, on the left-hand picture, the clip is coming from the cava. On the right-hand picture, the clip is coming from this side of the screen. Now, that's very important because if you turn that device clockwise, it's going to tilt towards septal and vice versa. So when you've got a device in like this, if you pull out, it's going to pull towards posterior leaflet. If you push in, it's going to push towards anterior leaflet. If you turn it clockwise, it's going to towards septal leaflet, and counterclockwise is going to turn towards the thing that's opposite to the septal, which is either anterior or posterior. So when you're putting in these devices, you use multiple planes to work out where you are and to use all your modes of flexion. And you use mid-esophageal 3D to get axiality and perpendicularity. So from there to there, for example. Like that. So one case quickly, there's an elderly lady of mine with severe atrial functional tricuspid regurgitation who was taking 8 diuretic tablets per day, 4 and 4. So she was in severe right heart failure, as you can see, with severe tricuspid regurgitation, as you can see, massive atrial dilatation with severe TR, reversal in the hepatic veins. Here is her transesophageal, and you can see from the transgastric that most of the, well, in fact, the regurgitation is actually mostly septo-anterior, but there's some here, which is also septo-posterior, so SA and SP. So when we're looking at that, we do our X-plane through it, septo-posterior in red, septo-anterior in yellow. And in fact, in this one, the jet we thought was coming sort of both. It was across the divide. So we thought that we were probably going to have to put something like that. And when we went in with the clip, steered it on down, got perpendicular, which is like that from there to there. Also looking in the transgastric, like that. Once we were happy we were in place and perpendicular, beautiful perpendicular on the bottom left picture, we went in and went for our first deployment. Weren't quite happy with it, and so we moved it a little bit away from the commissure. And this is the second deployment, and we were pretty happy with that. So that is a septo-anterior clip, and you can see there's clearly clipping, but still a lot of regurgitation. And you can see that on this picture, I'll just go back. Yeah, the regurgitation is on the other side of where the clip is. So we're putting in a second clip. We chased the jet, basically. We had to manipulate this quite a few times to get it right. But once we did that, we were happy that we got most of the jet. And when in the end, we ended up with this, which is 2 septo-anterior clips and nothing on the septo-posterior, with a moderate residual jet. And as Stefan said, you go from torrential to moderate, which I think this is. And this lady's done very well indeed and is now taking 1 diuretic tablet per day. So with that, I'll finish and just say that it's very important to get your anatomy right and to understand all of the views that you use in tricuspid intervention. Thanks very much.
Thank you much for your excellent talk, and Dr. Scalia. And I think for the time, I think we move to the next speaker.
Okay, the next speaker is Professor Lu Fangling. Professor Lu Fangling is the director of the Department of Cardiovascular Surgery, Shanghai General Hospital, affiliated of the Medical School of Jiao Tong University. Professor Lu is also a well-known pioneer of transcatheter intervention of aortic valve and mitral valve in China. Today, his topic is transcatheter tricuspid replacement. Professor Lu, please.
Okay, thank you, doctors, and Dr. Yin, Dr. Ye. I see your side. I hope my English you can understand. So today, my talk is transcatheter tricuspid valve replacement. As we know, tricuspid regurgitation, the patient are a very large number. Just mentioned Dr. Bedeliban. So the number of patients is more than the patient who suffered with aortic valve disease. And according to one study, the patient older than 75, the TR will exist 4%. And several reasons can cause TR. And at the later stage of TR, the patient will suffer the signs of left heart failure and the signs of right heart failure. So I think the patient are very, very complicated. So we call the situation of the patient the tricuspid regurgitation syndrome. And if patient with a TR, this means TR is a common change of left side heart failure. So TR can affect the survival rate after left side valve surgery, even the TAV. And in severe TR, the patient survival rate is very low, even then lower than some cancer patients. But the surgical treatment for TR valve, the mortality is very high. So in the recent decades, interventional treatment for TR is emerging. There are several devices created for TR therapy, and the left side is for repair and replacement. Also, there are some special devices as heterotopic valve replacement and also topical replacement. So this is examples of the TR replacement devices, and the TOPS and the Monacure and the Karl valve, etc. So Navigate is the first device for clinical using in the world in 2017. But unfortunately, the early result is not so good, so the clinical trial was stopped. And because the early result is not so good, for example, the 30-day mortality and the new pacemaker implantation rate is higher as 10%. And Evoke is another created replace device for TR. Also, the Evoke valve is also used for mitral valve replacement. So just said, Dr. Bedeliban said the 1 year's result of Evoke implantation. So the all-cause mortality is around 10%. And there are three sizes of the Evoke valve. Because the anatomy features of the TR is very soft and very thin. So several years ago, we created a new device that we called, we should not use radial force independent. So we call the radial force independent device as a Lux valve. So the future is like a cobalt head. And we use the ventricular anchoring and the anterior leaflet grasp for stabilization. And the first generation is through the right side chest incision from to the right atrium. So this we should at the beginning we make a small incision at the right chest, and we put the delivery system to the right atrium and implant the device. For example, this is the early stage patient. This patient received a mitral valve replacement several years ago, and now the patient suffered with a very severe TR. So before so after implanted the Lux valve, we can find almost no leakage. So the first case, it performed in 2018. Now the first generation clinical trial was finished. But the first generation of the Lux valve, we should make the incision at the right chest. So almost 10% of the patient suffered with a very severe adverse event for bleeding. So we use we create the second generation of the device, just introduced just Dr. Bradley liver. So we use we call the second generation Lux valve plus transjugular approach. So the first case performed in 2021. We can find this patient very severe TR, and after the valve implant, there are no regurgitation. This is another case. The patient received a cardiac surgery. We can find some mental near at the chest. So we cannot insert the TE. So we check the echo with at the chest. We can find the valve working well, and the angiograph showed almost no leakage there. So transcatheter valve therapy is still in its infant stage and has a promising future. So in my opinion, I think the valve replacement can abolish the regurgitation and decrease the right atrium pressure. I think it is good for the patient recovery. So I think we can do much more clinical trial in future. And there are some benefit and shortage of the TTVR and TTVR. So I hope we can do more things in future. Thank you.
Okay.
Thank you, Professor Lu. Well, this is a very clever innovation. Thank you for your talk.
Thank you, Dr. Yin.
Thank you. Because of time constraint, we have to move to next talk. Thank you very much. The last talk of this session will be delivered by Professor Ye, entitled Management of Mixed Valvular Disease. Professor Ye, please.
Okay, good, great. This is the last talk for today, and I hope you keep you awake still. And I will try and be quick. And of course, my talk will not including all the technologies. I'm not going to including this. So I narrow it to the concomitant, the TR in the mitral valve patient, but not the whole talk about mixed valve disease. That will be a huge topic. So this is my disclosure. So this slide is already seen that TR, iso TR is pretty common actually if you look at look into it, pretty significant, and the TI is actually more complex than tricuspid valve in terms of etiology and diagnosis. So these are more complex than mitral valve if you really want to get into it. So you can see that there's many things can cause significant TR. So the TR now the diagnosis and classifications is sort of a little bit changed. So it used to be just a non-trivial, mild, moderate, severe, but now we put on the basic massive, torrential, basic, because that's also, I think it's important because TR, when we say the severe TR, is a huge range from the severe to the torrential. Used to be just a severe, but actually, I think that's reasonable because we see lots of patients actually way more than severe. If you put a clip from a torrential to the severe patient, the symptom significantly improved and surprisingly, but on the echo looks still severe. So I think this definition is probably reasonable for. And the moderate TR is definitely for your long-term follow-up. These patients, I think, will definitely affect the survival because the TR is not because of moderate because within time they just progressively become severe. That's why it affects the long-term survival. As long as you follow up longer, yes, they will definitely have a negative impact on the survival, long-term survival. So the most common mixed mitral valve and tricuspid valve disease, of course, you have lots of combination depending on the etiology, the stenosis, regurgitation, you have lots of combination. But the most common combination, I think it's only mainly is this three, is a primary MR, usually like a concomitant with TR and the mixed mitral valve disease, like a rheumatic disease. It's not common in the North America, but I think it's still little common in the Asia or Africa region. And the second, mitral regurgitation, it should have been mitral regurgitation, sorry, I'm a type wrong. Mitral regurgitation, I think, combined with functional TR. Tricuspid stenosis usually don't really see it. So the incidence, according to literature, I'm trying to find what's the incidence in the patient with mitral regurgitation. As you see here, if for the degenerative mitral valve disease on the left side, there's a 17.2% patient with moderate TR at the time for the mitral valve surgery. So if a patient with a degenerative mitral valve disease comes to surgery, about 17.2 patients probably have moderate tricuspid regurgitation, and for about severe, there's a 8.5 patient probably had severe tricuspid regurgitation. How about for the functional mitral regurgitation patient? These patients probably even higher. About 30% of patients, they usually have a moderate or more than moderate tricuspid regurgitation. So the functional actual mitral regurgitation probably have a more functional tricuspid regurgitation, and the severe stenosis, like a rheumatic disease, also very high. Because the reason high because the rheumatic valve disease usually has stenosis, they usually have pulmonary hypertension, and sometimes the hypertension, is very, very high, and the tricuspid regurgitation is pretty common. So we previous frequently seen in this kind of patient. So in terms of progression of the TI in patient after mitral valve surgery, so we know that as quite common is tricuspid regurgitation when patient come for the surgery. But if you do surgery and how many patients they will develop a tricuspid regurgitation, as you see here in the rheumatic mitral valve disease, about 14 to 15% of patients will develop a significant mitral or tricuspid regurgitation the first 10 to 20 years after mitral valve surgery. And in degenerative mitral valve disease, about 3 to 5% patient will develop a tricuspid regurgitation in about 10 years. Not really like high, because you see the time probably in the 5-10 years to develop a significant tricuspid regurgitation. And for the ischemic mitral regurgitation, and probably is a little bit high in 5 years, they probably about 25% will develop a tricuspid regurgitation. So I think it depends on etiology. On the left side, the progression of the TR is different. So the mechanism only two, basically. Is one is either cause the annual dilatation. Second, because of the leaflets tesseling. Now they call it atrioventricular, whatever they call it. It's a nice name for that. But at the end, it's two mechanisms. It's when you do the surgery, that's the two things. It's really decide what you do kind of surgery. If the annual dilatation, only purely dilatation, you use a ring. That's you fix it. But if they have a tesseling mitral regurgitation, ring never works. You probably worked at initially, but it definitely will be recurring in a couple of years, very frequently. So if a combination, that's at the end, they will all combined, is dilated and also dilated ventricle causes tesseling. So that's only two mechanisms. Whatever you do, there's two mechanisms for the functional MR. So this is a paper published just after the edge-to-edge repair. So basically to look at the tricuspid regurgitation, the impact on the outcomes. So you can see there about 500 patients, they underwent the mitral valve procedure, and they evaluated about 79 days, and they found about 33% is actually the worsening TR, and unchanged about 46%. And improved is not much, only how much? 19%. So it's a pretty small portion of this patient that actually getting better. So that's why it's important to know this patient, which patient that you really need to combine the concomitant procedure to fix tricuspid valve regurgitation. Of course, you can see that if you're based on there's a different pictures, probably difficult to understand it, but the overall, basically, if the TR greater than 2 plus at the base before the procedure, or more than 2, grade 2, like a 2 plus after the procedure, they all have a negative impact to the survival. So that's basically 4 pictures trying to say that it's quite difficult to understanding, but at the end, more than 2 plus, either at the base or after the procedure, they all have a negative impact on survival. So this is the conclusion. And this paper basically just said if a patient has a severe tricuspid mitral valve, that's pretty clear. Surgery, of course, if patient is surgical candidate, you always do the combined procedure. But for the non-surgical candidate, whether you want to do the TR tricuspid valve procedure at the same time or not, it's this paper clearly show if you don't do it, not good. So if patient have a severe TR already, they come for the procedure for the mitral valve disease, you need to do the concomitant procedure to fix the tricuspid valve. Otherwise, definitely will reduce the survival. And this is another, basically, now this I just talked about before the transcatheter, but now the surgical. If it's coming for the surgical, whether we should fix the tricuspid valve for the moderate, this kind of a tricuspid regurgitation. So generally speaking, if a patient come in for the surgery, for the mitral valve surgery, if patient have a moderate tricuspid regurgitation, if you don't fix it, I think it is a problem, because for the long term, you see that up to the 5 years, there's some negative impact on survival. And the RV function, if you do the fix the tricuspid regurgitation at the same time when you do the mitral valve surgery, and the RV function actually improving. So I think there's a benefit to fix the tricuspid regurgitation. So this, I think, the randomized trial, the only randomized trial, see whether the tricuspid, moderate tricuspid valve, moderate tricuspid regurgitation should be fixed at the same time when you do the mitral valve surgery. So this is randomized trial, small sample size, and the short-term follow-up only 2 years. So basically, this patient, I think the overall, I just don't want to go through the whole things, but basically, so basically the information is showed is that if you do the tricuspid valve at the same time, and definitely reduce the progression of the tricuspid, worsening of tricuspid regurgitation after procedure. And so that's the combined endpoints. Combined endpoints because this is combined with a severe tricuspid regurgitation or worsening tricuspid regurgitation or death. And also I think the 3 combined, but mainly driven by the significant difference between the 2 groups, and mainly driven by the basic severe tricuspid regurgitation after the procedure. So basically the survival is not really significant impact on survival, but this is pretty short, only 2 years follow-up. I think from previous studies, the tricuspid regurgitation, the long-term impact probably needs longer. So this study, we hope we have a longer follow-up data. I'm pretty sure there's some impact for the long-term outcomes. So, and this is basically another thing where the benefit or not benefited to do the tricuspid regurgitation when come for the mitral valve surgery if they only have a moderate or less than moderate or dilated annulus. There is some controversial. So this is a meta-analysis basically show the probably is benefit if you do the non-severe tricuspid valve. For most studies show there's some benefit overall. You favor the concomitant tricuspid valve surgery. And so currently the guideline, this is the guideline. It's not really a lot, if you look at the guideline, not too much for the combined valve procedure, but you can see this general speaking, if a severe tricuspid regurgitation, if you come for the left side surgery, you need to do a surgery. But they actually not a class 1 indication. If you come for the CABG surgery or come for the aortic surgery, they are not really class 1 indication, right? Or for left aortic, for the CABG is not the class 1 indication, even they have a severe tricuspid regurgitation. For the moderate, mild moderate, this kind of regurgitation, if you have dilated tricuspid annulus, probably should do surgery with this class 2B or 2A recommendation. So that's kind of current the recommendation in both America and the European guidelines. So in terms of what the option we have, so for the mitral valve, primary mitral regurgitation, I think most should go to the surgery. I think a mitral valve repair, that's a majority go to there. But for the mitral replacement, probably small portion, probably less than 5% should go to the mitral valve replacement. And the TMVR, that's really just for the high-risk patient at this moment. For the secondary mitral regurgitation, that's a more complicated. Second, basically, surgery is not a great outcome. And overall, if a patient, unless need a coronary bypass surgery, I think this patient usually go to the mitral valve replacement, not for the repair anymore. But if not, doesn't need a coronary bypass surgery, probably nowadays most go to the TEER for the edge-to-edge repair. And if they're not optimal for the edge-to-edge repair, these patients probably will refer for the either transcatheter mitral replacement or other option for the mitral valve repair. And another thing is now quite often we refer to the CRTD if a patient have a prolonged QRS or the dysynchrony. So these kind of patients actually quite a benefit from the CRTD. So we usually go to CRTD first, and then if CRTD is not really working, and then refer to the either TMVR or TMV repair. And in terms of further how to manage a tricuspid valve, I think it depends on the surgery candidate. See, for the mitral valve, if mitral valve candidate is for surgery, of course, the tricuspid valve should be surgery. That's no doubt, right? But if it's not for surgery, I think that's usually nowadays they go to the TEER. That's majority go to TEER. Very small portion go to the replacement or medical treatment. So this is my last slides. So I think that for the severe TR, I think everybody agree. I think we should do the combined mitral valve, tricuspid valve surgery, or even if a patient, a high-risk patient, still need a combined the transcatheter approach, usually TEER. That's the most time to do a edge-to-edge repair for the mitral valve and tricuspid valve. For the moderate TR, doesn't matter as function or the primary TR. In this kind of situation, if for the surgery, I think it should be to do the combined procedure, but if a transcatheter approach, that need to really assess whether staged or combined. Generally speaking, we at our center, we recommend for the staged. So you do the mitral valve first, and then see how the patient doing, how's the progression of the TR, and then make a decision for whether need a TR or other transcatheter procedure. And the next one is more complicated. It's a mild to moderate tricuspid regurgitation, and then they have some factors. So it's really dependent on factor. Usually, if a patient have a persistent chronic atrial fibrillation, these kind of patients, the TR usually getting worse. Even you fix the mitral regurgitation, TR probably won't get better. So these kind of patients, you also may need to consider to combine the procedure. Another major factor is atrial dilatation. As the annulus dilatation, if a significant dilated, and usually you fix the mitral valve, they don't get better. And another thing is if RV is severely dilated and the leaflets tethering or the atrial enlarged, these kind of patients probably more prone to the progression of the TR. And the rheumatic valve disease, of course, usually surgery, not transcatheter option. And another thing important is the pulmonary hypertension. Generally speaking, for the left side is a pulmonary hypertension. You fix the left side, pulmonary hypertension usually coming down. So the TR usually improved. But I think that you really need to determine the TR. So that's why right heart cath is very important. You need to determine that pulmonary hypertension is a precapillary or postcapillary, because these kind of response to the mitral valve treatment is totally different. So if you think the pulmonary hypertension will not improving with the correction of the mitral valve disease, in that kind of situation, the TR usually getting worse, and then you may need to consider to do something. And the tethering, of course. So this really depends on the surgical candidate or not surgical candidate. For surgical candidate, I think for this kind of factor, you may need to do the combined procedure. For the transcatheter approach, generally speaking, use a staged procedure. Thanks.
Thanks, Professor Ye, to make an excellent review and suggestion for the multiple valve procedure. And today we will the last speech, and we will finish our great meeting today. And tomorrow at 8 a.m. we still have many hot topics in TAVR procedure. Welcome the audience to participate in the great meeting tomorrow. Thank you.